Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.
One thing my prostate cancer hasn't changed: this place. We've made some great memories here, and we're making one today with a little help from Nubeqa.
Nubeqa is a prescription medicine used to treat adults with prostate cancer that has not spread to other parts of the body and no longer responds to a medical or surgical treatment that lowers testosterone.
I was on hormone therapy, but my PSA was rising, so my doctor recommended Nubeqa.
In a clinical study, men lived 2 times longer without their prostate cancer spreading when they added Nubeqa to ADT. Nubeqa may also extend survival. Nubeqa may cause serious side effects, including heart disease and seizures. Tell your doctor right away if you have chest pain or discomfort, shortness of breath, loss of consciousness, or seizure. Nubeqa can harm unborn babies and cause loss of pregnancy. Common side effects were changes in liver function tests, decreased white blood cells, feeling more tired than usual, arm, leg, hand, or foot pain, and rash. Nubeqa helps you live for what you love. Ask your doctor about Nubeqa.
This meeting has singularly been able to propel forward many of the concepts that are changing the field throughout the world. So even though you guys think that you're just sitting there as participants or audience, just through your social networking, just by sharing ideas, just by changing referral patterns, other institutions are going, well, crap, you know, we better set up a PET scanner, or gee whiz, we better get into a more aggressive mindset about therapy. I like this meeting. I like talking to patients. I think patients get it much better than doctors. So for me, that's why I come and speak to you. And for me, the privilege is simply that some of you are doing better, all right? That's all I need.
Hello everyone, and welcome to day 2 of our 2023 Prostate Cancer Patient and Caregiver Conference. We have a fantastic lineup today, including Dr. Matthew Cooperberg, Dr. Eugene Kwan, and our Executive Director, Dr. Mark Scholz, and our beloved moderator, Dr. Mark Moyad. Now, just a reminder, visit PCRI.org/2023-conference, and you can click the link in the description below to visit the exhibit hall, where you can find lots of helpful resources, information about treatments, payment assistance plans, and so much more. I would also like to remind you to donate. Your support helps PCRI to create prostate cancer education that gets shared all around the world. I'd also like to thank our sponsors, Bayer, Pfizer, Astellas, Janssen, Novartis, Dendreon, Sumitomo Pharma America, and Sanofi, who have helped to make this conference possible and enabled us to make it free for all of you. This year, we're presenting this entire conference virtually, but next year, on September 7th and 8th, we're going to be hosting this conference in person, live, here in Los Angeles, California. We will bring together world-renowned prostate cancer experts covering every type of prostate cancer, and you will have the opportunity to get your questions answered in person. From the companies who create the treatments, to the support group leaders and advocacy groups from around the country, the speakers who are going to speak on prostate cancer in every field, and the patients and the caregivers who are experiencing the same type of cancer as you. This conference will bring together some of the most incredible resources a prostate cancer patient can have, and I promise you, you don't want to miss it. There's no better way to learn about prostate cancer than from world-renowned experts, getting your personal questions answered, and having a community support you. Sign up today at PCRI.org/2024-conference. Up next, we have Dr. Matthew Cooperberg. He is the Professor of Urology and Epidemiology and Biostats and the Helen Diller Family Chair in Urology at UCSF. He will give us an update on the new developments in active surveillance for prostate cancer. And we at PCRI are big fans of Dr. Cooperberg. Not only is he an expert in his field, but he does a great job breaking down complex concepts. Without further ado, here is Dr. Cooperberg.
Dr. Matthew Cooperberg, one of
Hello,
my
hello.
BFFs. How you doing, man?
Good to see you.
Good to see you too. Look, before we start, you were already introduced. You already had this gigantic CV. I just got a shout out to one of our editorial people. It's Peter from PCRI. He's the one making the video happen today. It's Happy 3 blank. I don't want to mention his name because it's nauseating, because basically he's half my age. So, happy birthday, Peter. Love, love, love you. Making all the magic happen. Love you, Peter. Happy birthday. We're never going to mention your age because it makes me feel guilty. All right.
Birthday.
I'm fired up. I have my 1,3,7-trimethylxanthine, also known as caffeine, as a chemical structure. And so last time we did this turned out to be a big hit. And so we have decided not to go with formal slides, except you might show a couple of slides. I'm just going to jump around and pick the Cooperberg brain. This is a very important moment. Before we get going, though, I do want to mention that Dr. Cooperberg holds a place in my heart because he's the only doctor I know as a urologist married to a dermatologist, which means I always want to go to dinner with you because I could talk to you about my prostate and I'm going, excuse me, is this mole okay?
Our joke is, people come up to her at the start of the cocktail party. Usually it takes a few drinks for them to come up to me with their friends' problems. So it's a good time.
They'll always come to you, but then I don't have to go anywhere else. If I invite you to dinner, I can just have your wife, I'll just lean over and go, how's this look over here? And then I can lean back and ask you questions. Right? And then you can ask me some questions too. And it would be just really great if we got to dinner and then I wouldn't have to go see my regular physicians.
Absolutely. One-stop shopping.
Do you remember what we gave you as a gift last time when you were on?
Yeah, you sent me a shirt, a sweatshirt. I sent
you a shirt and you wore it. It says Yale. Look, see, I made a poster of it.
Very good.
All right,
Very good. I love it.
It says Yale School of Public Health. This is awesome picture. And then this is my other favorite. Before we get started, there's a long runway here. This is my favorite on your website. It says, Matthew Cooperberg, MD, MPH, urologic cancer surgeon, husband, father, runner, skier, music lover, hiker, traveler. You got any comment on that, my man?
UCSFhealth.org has a intermittently very active marketing department, and
I think it's great.
They've been doing a nice job with our web, redo. So
yeah, I think it's great.
I actually like these profiles. I think they're good. They're humanizing.
Good point. Good point. How much are you running these days? Because you're the brother from another mother I didn't have in urology, where we were always running, and so I'm still running. Right. Finished second in my age group in a half marathon the other day.
Fantastic.
Yeah, got a medal, got a plaque. Guess how many people were in my age group at a half marathon too? But it doesn't matter. Nobody wants.
Doesn't matter.
Nobody wants to go running after 50. Your running's doing okay. You're doing all right.
I'm fine. I'm very close to 50, so I'll do a little better next year if I keep the same pace. But yeah. Good marathon was a COVID goal, which I got close and not quite yet, but still do halves and shorter distances.
You got any marathons coming up?
No. There's the Great Kaiser Half that I always do in San Francisco every year. There's a few others around that I've done intermittently, but marathon, it's gonna happen one of these years.
Okay, I love it.
We'll see. We just found with my kid, there's we're looking for the oldest marathoners, and there's a gentleman in Japan that was running marathons until 99, which sounds impressive, but the impressive part is that his very first marathon was at 89 years old, which is just incredible. So
you know why?
Gives me hope.
Well, because he still had is it he or she?
He, yeah, man.
Well, if he wasn't exercising till 89, he had all his cartilage, all his joints intact.
That's right.
So then he got to use it later on.
Exactly.
That's because I'm jealous. That's all. Okay, so I think anything else you want to talk about personally with me and the rest of the world and YouTube, since 1 million people are going to watch this? I think you look fantastic. I think the code
is. You too.
Yeah, thank you very much. You've always been a good friend. Just for the audience, I'm also not going to be the nicest to Matthew if something's controversial, but the reality is I've known him for 30 years. So we are part of this club and he means a lot to me. And so I'm going to get out of the Academy Award-winning speech for a second, but he's been a great friend and I love having you on. So I'm just going to randomly jump around unless you want to start the first topic. We're just going to talk about active surveillance today.
That sounds good. Let's do it.
You want to jump right into a couple of controversies?
Yeah, that's the best part.
Okay. Active surveillance. every time I read stuff from you on the internet, it seems like the number of people who are joining active surveillance is increasing, right or wrong?
Correct.
It's becoming a larger percentage of the prostate cancer population. Is that right or wrong?
That is correct.
Okay. Is that a good thing? Okay,
That is a great thing.
Let me play devil's advocate for a second. Isn't the ultimate goal not to diagnose someone that has an insignificant tumor? No, I'm serious.
Absolutely.
Okay, so can you please comment on that? Because I'm happy that active surveillance is getting a larger piece of the pie, but this isn't exactly something a group I want to join unless I'd rather find out I don't have cancer. I'd rather not have cancer. So do you want to comment on that?
So you're already skirting into a major area of development in the past year and a big controversy, which is what are we doing with low-grade prostate cancer, and is it even cancer? Okay, which has, that's a question that has been kind of percolating through the literature for 18 years now, but has really been picking up steam in the last couple of years.
Okay.
The reality is, what we call cancer. First of all, let's step back a second. That word, cancer, this goes back literally to Hippocrates, right? 400, 500 BCE. Cancer was the crab, was the carcinos, right? And what does cancer do? It spreads, it kills. About 150 years ago, we started diagnosing cancer by looking under the microscope and seeing what stuff looked like to pathologists with, wax-embedded, paraffin-embedded tissue, which, using what was at the time revolutionary, today is getting to be a bit of an antiquated technology. The Gleason grading system has been around since the 60s. It's held up incredibly well over the decades, all things considered. And yet, in an era where we are drilling down into full genomic, multi-omic profiling of cancers and understanding their biology increasingly well, it is really no longer sufficient. And it is increasingly clear that there are molecular changes in what looks normal under the microscope. And conversely, there are things that look like low-grade prostate cancer that molecularly aren't cancer and have absolutely no capacity to spread. So why do we call these things cancer, right? Grade group 1, we were talking about aging a minute ago. If you get to your 70s as a Black man, your 80s as a white man in the United States, 50% of all men have a couple of these cells under the microscope. This is not cancer, the way we think about cancer. And as you say, we are trying increasingly hard not to find these things. So look, PSA, prostate-specific antigen, best screening biomarker in the history of oncology, okay, if we use it well. But, we haven't used it well. We have screened men a little bit too old when there's a lot of BPH in the water, and we do too many biopsies. So, in contemporary practice, first of all, when we screen men younger, the thresholds are a lot cleaner. It's not 4.0, but these low thresholds work much better to rule out prostate cancer. But for men who have an elevated PSA, we don't run to biopsy anymore. We have MRI, we have liquid tests in the urine, liquid tests in the blood that work really well to rule men out for biopsy. So we're trying really hard not to find grade group 1. If you look at all these tests I'm mentioning, MRI, ExoDx, 4K, Select MDX, there's a ton of them, more than we know what to do with, honestly. Every one of these tests is set up so that if the test is positive, there's a risk you have grade group 2 or higher, and maybe we go forward with a biopsy. The test being negative means either benign or grade group 1. We are implicitly saying, if there's grade group 1 there, we're not going to go looking for it. You're perfectly happy not knowing you have it. Okay, so you're absolutely right. The first goal is don't find it.
Yeah, don't find it. Don't tell me something I got something.
Correct.
When we were growing up, they'd say, well, I want to know. Sometimes you don't want to know what you got if it's incidental, right? I mean, this is happening all throughout cancer. So does this mean that grade group 1, 3+3, Matt Cooperberg does not want to call this a cancer?
We should not call this a cancer. Okay, I'm in a small but growing minority of folks that are saying this. Actually, Scott Egner and colleagues just had a paper out polling, urology, pathology, radiation oncology, and the tide is kind of shifting on this. And they did it by age, right? So the older generation, especially in pathology, are very committed to this is cancer, looks like cancer, it's cancer. But the folks who are kind of coming through now have, are a little bit more open to the idea. And my vantage point on this is that, you take something that looks like low-grade disease under the microscope, but does not have any molecular hallmarks of cancer, cannot spread. It looks like a duck, but it doesn't quack, fly, or speak. Why are we calling this thing a duck, right? And the reality is that grade group 1 is not a normal finding. Just like if you have polyps in your colon, that is not a normal finding. It means you need and to be perfectly clear, if you have grade group 1, I think you should undergo active surveillance just as you would today if we called it a cancer. None of that should change. But the idea that we're going to go straight to surgery or radiation should almost never happen.
So you want to just call it the grade group 1 thing. You don't want to call it, you don't want to use the CA word. Is that right?
Correct.
Okay, so
correct. It's not normal and it needs to be followed, but it is not a cancer.
Okay. I used to go to George Carlin concerts. Remember George Carlin?
Yeah, sure.
I mean, I'm just playing devil's advocate. I'm not saying this is how I feel. The spotlight's on you today. It's not on me. I'm just here to make you look good or bad if you have to. So the reality is I used to go to George Carlin, and what he used to say is if we keep using politically correct language, this was his point, because, he was very politically active. He said, if we keep using benign language for things that tend to be serious and should be taken seriously, ultimately we won't take that thing seriously.
Yes.
Does that make sense? And I used to always think about that. He was talking about military vets and shell shock and using the word. All I'm just saying is if we downplay this too much, is there a chance that ultimately then people just don't take prostate cancer that much more seriously?
Absolutely a concern. I'm going to throw up another slide here.
Okay.
But what we're dealing with is a continuum. Okay. This is not a yes or no phenomenon. And this is clear. This is really not that controversial. If you look not under the microscope, but you really drill down to what is happening at the genetic level, we've got a continuum. There are folks whose prostate is absolutely normal, nothing that we can detect. Then there are these biopsies we can do where it looks perfectly normal to the pathologists under the microscope, but there are pre-malignant changes that we can pick up when we look at what's happening to the genes, to the DNA, the RNA within the tissue. And this is, on the way to cancer. Then there are these precursor things that have been controversial over the years, how much we're supposed to worry about things like ASAP and PIN. Then we've got grade group 1, and then we've got higher grade real cancer. And, it is not known how many of the bad ones are born bad versus how smoothly you kind of progress along this chain. But we have to acknowledge that where we draw the line today is arbitrary. Okay, calling cancer based on this difference, based on how things look under the microscope, is arbitrary. And there is no particular reason we could not draw that line here. Now, all along here, we're not saying normal. If you have ASAP, which is atypical small lesion or proliferation, the guidelines over the years have been, you need to pay attention to this. You should get another biopsy. We don't do that as much anymore because we have MRI, we have confirmed MDX, we have other testing. But again, this is not normal. You need more close observation. If we draw the line here for cancer, nobody is saying this is normal, okay? And the other point here is, let's say we don't call it cancer. Some men don't take it seriously. They don't come back for their follow-up evaluations. And a fraction of those men, some number of those men, will go on to miss the window of opportunity for cure, and they will die of prostate cancer. Look, that number is not zero. Okay, that will happen, and that will not be good. However, what's the flip side? The flip side is every man who dies of prostate cancer, in a sense, was a screening failure. They could have been screened, and most men that die did not get screened early enough, did not get screened well, in part because screening has been so controversial, and primary care docs don't do it that well. Why is that? Because, and for many reasons, but in large part, because for many years we overtreated and overdiagnosed low-grade prostate cancer. So if we stop doing that for real, and convince the US Task Force and others that we had no interest in finding the high-grade ones, let alone treating it, then the equation for screening becomes much more favorable. So we may miss a handful if they don't take the non-cancer grade group 1 diagnosis seriously, but we will save tens of thousands, hundreds of thousands of lives if we screen more aggressively.
Here's a paper you did. Can we just talk about where screening is today, just for people who aren't there yet? They just want to be screened. This came out July 2016, Matthew R. Cooperberg. And then you have to explain this to the audience. I like these positions that you take, at least they're not soft. Why the prostate arm of the PLCO trial failed and what it has taught us. Failed! This is the largest PSA screening trial in US history, and you called it a failure, Dr. Cooperberg. What's your problem? Why
I
are you
actually,
calling the largest PSA screening trial in U.S. history a
Yep.
failure? And can you explain why, where we are with screening, and what does this mean?
Yep. PLCO did a lot of wonderful things. What it failed to do was answer the question it set out to ask, which is screening effective? Okay. And I used that word at a presentation just after the trial originally came out, at UCSF, and got a hand raised from someone I didn't recognize in the audience afterwards. It was one of the authors of the paper who didn't love the word either. But it's a great question. It's a fair question. I'm going to stand by that word. And it's no fault of the investigators. Okay. The PLCO failed because it started too late. The PLCO, for those who don't know, the PLCO is prostate, lung, colorectal, and ovarian screening trial. And the history I have heard over the years about this is that originally it was going to be the P trial. Originally this was just meant to be a prostate cancer screening trial when it was conceived in the 1990s. But there was a feeling that this needed to be broader, more ecumenical, including more groups of patients, and in particular, including women. With ovarian cancer screening, and that delayed the onset by quite a number of years, as this is a massive undertaking to plan something like this. So expanding it from P to PLCO set it back by years. And by the time the PLCO launched in the late 90s, 2000 in the 1990s, prostate cancer screening was out of the bag. Prostate cancer PSA screening hit the market in the 1990s. And what happened is we found all these prevalent cases because everybody and their uncle went to the primary care doc and said, hey, there's this new test. I want a PSA test. So by the time the PLCO launched, we had already, first of all, diagnosed a bunch of prostate cancers in the population and culled them. Basically, those guys are not eligible for the trial, right? And then for pragmatic reasons, because so much PSA testing was going on, the trial organizers said, okay, we're going to allow for no more than one PSA test within 3 years before the trial. Okay, so you've got more kind of contamination, as it were, and it gets worse from there. So if you had an elevated PSA, well, of course you have to get a biopsy. Fewer than 40% of the men who were supposed to get a biopsy actually agreed to get the biopsy. So at the end of the day, when the trial first came out in 2009, on my birthday, as it happens, together with the European screening trial, the EuroSPC, the differences in the look of the prostate cancers between the screening arm and the control arm were basically identical. They were all stage 1 and 2, which are by definition screen detected. The only time in the New England Journal of Medicine, we wrote a letter to the editor about that first trial saying, listen, this does not look like an unscreened population in the so-called control arm. And I think what we said in the letter is this wasn't screening versus no screening, it was screening versus ad hoc screening. The term that has now come into parlance is opportunistic screening. And this is now increasingly clear. And by the time the PLCO was updated in 2012, the authors of the trial said this. They said this is screening, organized screening versus opportunistic screening. It took a long time for that message to really get through to the U.S. Task Force and others. At the end of the day, there was a paper that came out in the New England Journal in 2016. The number of men in the control arm, in the no screening arm, okay, who got a PSA test at some point before or during the trial, 93%. Okay, so it was a laudable effort. It was too late. We were just screening too much in the world, in the United States, during the PLCO. So the PLCO tells us a lot of things. PLCO tells us that screening every year for 6 years, starting in your 60s, is not the right way to do it. Okay, it did teach us that. That is not a particularly effective or efficient way of using PSA. But it tells us nothing about, is PSA a good test?
All right, it was contaminated. We don't know what the real answer is. What's Cooperberg's answer? Should men go for screening for prostate cancer? And if you believe men should be screened for prostate cancer, this is before we go back into active surveillance.
Yeah, fantastic question. This has been in evolution, a lot of evolution in the last few years, guided actually less by the randomized trials as by some really beautiful cohort studies that have been done. In particular, there's one in Malmo in Sweden. And, one of the lines is everybody wants to be an epidemiologist in Scandinavia because nobody ever moves. They track every heartbeat from birth to death. They have these incredible record systems and this, totally captive population. Perfect example. In 1982, in the city of Malmo in Sweden, just across the water from Copenhagen, they rounded up basically the whole city population, drew blood on them, and stuck it in the freezer. Okay, and this was mostly for cardiac risk factors. Nobody, PSA was not in anybody's, glimmer in anyone's eyes at that point. The people in Malmo lived out their lives. About 12% of the men got prostate cancer. About 2.5% died of it eventually, which is not too dissimilar from what things looked like in the US at the time. 20 years later, Hans Lilja and his very sharp clinical chemists at MSK in New York, sorted out ways to run a valid PSA on this antique blood sitting in the freezer. So they had a beautiful natural history study of what happens based on a single PSA test early in life. And what we learned from that, and this has now been validated in a number of other cohorts, the median PSA at age 45 or 50 is around 0.7. Okay, it's 0.7 at 45, 0.8 at 50. By the time you get to 60, it's 1.0. Wow. And if you just screen basically the population, we can talk about shared decision-making, we can talk about screening a little earlier for Black men and those with family history and all that. But the bottom line is a baseline, somewhere in your 40s or early 50s, is an unbelievably good test, because if it's under 1, you're basically done. It's hard to say for life, but you're done for a long, long time. And you can take this off your list of many worries in life. Okay, and that's 75% of the population. You can take prostate cancer off their list of worries with a single $20 test, and we're done. But that's a threshold of 1. So 4.0 needs to disappear from anybody's imagining. So the way we are now doing this at UCSF and some other centers, and this is in collaboration with our primary care docs who historically have been very skeptical about PSA testing. This is a 2-year conversation with them, but it's now baked into our EMR. The primary care docs in our system get a ping, a reminder to talk to the men about prostate cancer screening between ages 45 and 75. If the PSA is under 1, the reminder zeroes out for 5 years. It could be 20, but we said 5 years.
So if I'm a 0.9, I'm less than 1. If I'm actually touching there close to 1, 0.9, that's still less than 1.
0.9 is still good. 0.9 is good.
And then can I just interrupt for a second?
Yeah, of course.
I'm going to a single value. Wouldn't I just want to repeat that a few weeks later to make sure it's the right value?
You can. So look, PSA varies. Okay, PSA will bounce up and down a little bit. It doesn't usually, if it's low, that's really reassuring. It's more the case that when it's high, it might be high because you just went for a long bike ride or recent sexual activity or the moon was full. I mean, PSA will rise for funny reasons and come down. It doesn't fall, we don't think.
I didn't want to kill your mojo. So you're back to PSA's less than 1, you're done.
PSA less than 1, we're done. PSA over 1, we have fairly low threshold for considering a workup. So if it's over 2 for a guy kind of 45 to 60, that's already in the 90 to 95th percentile, needs to be chased down. If it's over 3 for older men, needs to be chased down. Now, chase down does not need biopsy. In the gray zone, so 1 to 2 for younger men, 1 to 3 for older men, that's where we're going to look at risk factors. So, again, Black men, men of African descent, men with family history, certainly BRCA mutations and things like this. First of all, you might want to start at 40, but certainly we're going to act on a lower PSA. But again, ACT does not mean biopsy because we don't want to find the grade group 1s. So ACT means, again, blood tests like 4K and PHI, urine tests like ExoDx, Select MDX, MRI. Okay, these are all really good secondary tests. And if we don't have a suspicion we're going to find a high-grade cancer, we do not do biopsy.
Are you using those? Can you explain to the audience? So are you using a blood test with the MRI? Are you using one of the, how are you, what am I asking for if I'm seeing you or not seeing you? You're saying I got all these other tests. Can you walk me through what you use?
We are, and to be clear, we are all over the map about this in terms of even what happens in the US and certainly what happens in other parts of the world. If you're in the UK and you have an elevated PSA, everybody gets an MRI. And if the MRI does not show a lesion, you don't get a biopsy. And that is the paradigm. Okay. There's other places where they use markers very heavily. I am a fan of the liquid tests first because in the US they're less expensive. In Europe, MRI is a few $100. Here, MRI is very expensive. And the inter-reader variability on MR is still a concern. So if you're going to use prostate MR as a rule out, you got to make sure it's done at a really high volume center that does MR day in, day out. You don't want somebody that reads, mammogram in the morning and then a prostate MR in the afternoon, reading the prostate MR. It takes a lot of experience and expertise. So for those reasons, I personally tend to favor the liquid tests first. We've done a lot of ExoDx in the COVID era because it's literally just a kit. You mail the patient and they pee in a cup and send it off to the company. 4K, likewise, you can order to a lot of different remote labs. So it's very convenient. And these to me are very good kind of secondary screens. If they are concerning, then we're going to go on with MR and use that to guide the biopsy. Sometimes we'll do MR first if the man also has a lot of voiding symptoms and we think there might be a lot of BPH at play. If they've already had, certainly if they've already had negative biopsy in the past without imaging, then we'll definitely get MR. So it varied. We customize it a little bit.
All right. I'm sorry to put you in this position.
Let's
just say the world is perfect and medicine is not that expensive and everything's kumbaya.
Yep.
Why wouldn't I or let's just say I have extra cash. I don't know. Let's say I invented the MRI machine. I got connections. Why wouldn't everybody just get an MRI and cut to the chase?
The UK is asking exactly that question. There's a trial called MRI First that they published as a pilot, and they're currently running a bigger trial of MR versus PSA as the first screen. So I think this is, and I have the highest respect for the UK trials apparatus. Those guys have done incredible things. They're great investigators. I think this is a little bit crazy. First of all, no matter how perfect the healthcare system, MR is never going to be less than orders of magnitude more expensive than an MRI, first of all. Second of all, PSA is just a blood test. I mean, we talk about shared decision-making, but the reality is PSA probably should be used just like you just get a cholesterol, when you're 50, you just get a PSA because most of the time it's negative and it's a really short conversation. The conversation is, worry about your cholesterol, don't worry about your prostate, okay? Yeah. We can get into the shared decision-making when it comes to how hard are we gonna chase this. So that's first of all. Second of all, MR, even if we had enough MR machines all over the place, this inter-observer variability problem is an issue. Depending on what you read, the negative predictive value, meaning how well MRI can rule out a high-grade cancer, ranges from the 70s to the low 90s. That is not as good as the liquid tests. MR does miss grade group 2 cancers, 3+4s. It doesn't miss that many. It's not going to miss, a big aggressive prostate cancer, but it will miss, cancers that we want to know about over the next 5 to 10 years, ones that we would need to watch pretty closely. The idea that we're going to train up enough radiologists to do this well, to use it as a first screening test, that all men are going to get an MR when they turn 50, I just don't see it.
I'm Johnny Public Health. You can call me Johnny Public Health if you want. And then you, to me, are Johnny Public Health too, because you know your statistics. Can you explain to the audience, because it's a good point, what inter-observer variability is when it comes to MRI? Why is that an Achilles heel of the MRI? Can you explain that to the audience?
Yeah. So first of all, what do we mean when we say MR? Well, most of the time when you get an MR, and anyone that's had an MRI knows, you go into the magnet and you hear this clanging and it goes on for a while, right? It takes us 25, 30, 45 minutes to do a full multiparametric MR exam. You're getting an IV injection of gadolinium in most cases. So what's happening is there's multiple sequences that get run, and each part of the MRI exam is looking at slightly different aspects of the anatomy and of the physiology. So the most basic piece of it, we call a T2 exam, and it's basically just looking at anatomy. It lights up, areas that contain a lot of fat, which is cell membranes for the most part, can really sort of highlight those areas. Then we have something called diffusion weighting, which is looking at, basically how water moves through the tissue, and it moves less well through cancer tissue because the cells are more densely packed and the vasculature is not normal. So we see those as these dark spots on an ADC. And then finally, the injection, the gadolinium, is looking at how the vasculature, the blood supply, may be altered in a cancer. We see more micro vessels, small blood vessels, in cancer compared to normal prostate tissue. So you look at each of these sequences, you spend all the time in the magnet, the computers in the MRI machine collect all this really, really incredibly complicated data about where the protons are moving, literally, at the atomic level within your body, within your prostate. And it basically, I don't want to say dumbs it down, but the computer, sums that up into these grayscale pictures that the human radiologist is now going to look at. And these things, there's a lot of subjectivity in this. And, a lot of us in urology are pretty religious about looking at the MRs ourselves as well. So the radiology report is very helpful, but we always look. And, sometimes they're obvious, sometimes they're quite subtle. And it's not like, I always joke that we want pregnancy tests in prostate cancer. If it turns blue, you take out the prostate. If it doesn't, leave it alone. These are shades of gray. This is not a yes, no. So the PIRAD system is an attempt to standardize the read of the MR. So you give, a certain number of points, certain weighting for the T2, more weighting for the diffusion weighting, the dynamic contrast, the injection, that's kind of a tiebreaker in many cases. And that gets summed up as a 1 to 5 scale. And then we kind of dichotomize that in terms of, do we go forward with a biopsy? So we're losing a lot of information along the way. And there have been some very good studies, even at very good MRI centers, that if you show 2 radiologists the same exam, they come up with different scores. Okay. So Stanford University, just down the street from us in San Francisco, they may not have quite the volume that we do, but they do a lot of prostate MR, and it's a very good prostate MRI center. They had the courage to actually report on, by radiologists at Stanford University, depending on which radiologist happened to pull your MRI off the cube, what is the positive predictive value of a grade group of a PI-RADS 5 for finding a bad cancer? In other words, radiologist A, B, C, there's like 12 of them reading prostate MR. Depending on which one happened to pull your exam at 10:23 in the morning on Thursday, the likelihood that PI-RADS 5 lesion does indicate a high-grade cancer ranges from 25% to 75%. This is problematic. Those same numbers apply, by the way, looking nationally. So Antonio Westphalen, who was with us at UCSF, now is at UW, radiologist up there, collected data from 25 major MRI shops around the country, and same problem. The positive predictive value for PI-RADS 5 ranges from 25% to 75% from center to center. And these are the good centers. These are the ones that do this all the time. This is not the community shop where the radiologist is reading mammograms in the morning and prostates in the afternoon. So look, MR is a fantastic tool, okay, but it is not a yes, no, and there's a lot of subjectivity and a lot of subtlety in reading it, just like there is with pathology, just like there is in many aspects of medicine. This is not a critique of MR as a, on principle or anything like that. It's just to say that it's actually quite difficult to standardize and to use well and consistently, just like pathology, just like surgery, radiation, active surveillance, everything else we're going to talk about. The devil really is in the details.
Repeat again, if you're thinking about getting screened, can you tell them the Cooperberg screening policy as it stands right now? Just can you repeat that one more time? Just basically.
So early baseline test, early 50s. Okay. PSA under 1, you're good. Okay. PSA over 2 if you're younger, 3 if you're older, work that up. If it's in between 1 to 2, 1 to 3 for older men, consider working it up. Work up means biomarkers and imaging. It does not mean immediate biopsy. And then the final critical point, which is probably the perfect segue for what we're going to talk about next, is you don't go down the screening pathway unless you understand that grade group 1 does not get treated. Okay. So, that understanding, this is where the shared decision making is important upstream. It's much harder to convince the man who's just been given the C-word diagnosis that he doesn't need treatment for this little grade group 1 if we've had that conversation, ideally before the PSA, but definitely before the biopsy. Okay. It's much harder to have that conversation when you've just been on this train. This is the feeling of the task force when they say don't screen anybody. They looked at what we did as a field in urology and radiation oncology in the 90s and 2000s. So you're just putting these guys on this inevitable track from PSA to biopsy to treatment, over treatment complications, and you're not pulling anyone off that train once they're on it. And the easier it is to understand that this is not an inevitable train by any stretch, the easier it is to have those conversations at the time of diagnosis.
Okay, I love that. All right, but there's 3 little letters we didn't use, and I want to know your stance on that because it's weird. People are either talking about it or not talking about it at all. There's no middle ground. 3 letters are DRE. Digital rectal exam. So let me provide some background here. I just had a colonoscopy, got a DRE. I had to do a follow-up. I had like 1 polyp. It ended up being a benign polyp. The GI person gave me a DRE. So I've had like 2 DREs in the past 3 or 4 months. And I'm thinking to myself, wait a second, no one's ever even talked to me about even if a DRE should be done. And so where are we with the digital rectal exam?
There's no recent evidence on this because nobody really studies it anymore. The guidelines all still say do a PSA and a DRE. The active surveillance protocols, for some reason, still refer to DRE as a means of following the prostate cancer, which I think is a little bit crazy. It comes from the fact that in the era of the threshold of 4.0, which was much too high a threshold to use for PSA screening, we would find clinically significant cancers with quote unquote normal PSAs based on DRE. Now, if you're using a threshold of 1, the yield of the DRE falls dramatically. Are you going to occasionally find somebody with a PSA 0.8 and a clinically significant tumor? Sure, but very, very uncommonly. And it's a barrier to screening. Men don't like it. Primary care docs don't really like doing it. They're often not that great at it anyway. Yeah. So to the extent that it is an obstacle to screening, I'm perfectly happy dropping it. Now, that is screening. The minute the PSA is high, this is no longer screening. It is workup of the elevated PSA. So if the PSA is not low, under 1 or whatever your threshold is going to be, then you really have to do the DRE as part of chasing down the PSA. Because now you want to know, is it an enormous prostate? Is there a nodule there? You know, this helps you, make sense of the PSA. If I've got a, 61-year-old with a PSA of, 1.8 in the office, and we're trying to decide are we going to chase that down or not, and he's got a, clearly a 60+ gram prostate on DRE, maybe we don't even go down the path of MRI and all that, because it's obviously BPH driving the PSA.
Before we just spend the rest of the time on active surveillance, I've always found it interesting how people guess the size of the prostate with the rectal exam. I think I got a better chance of the guy at the circus picking my weight. I don't know. I understand it's an estimate. And we give plus numbers, or urologists give plus numbers, but you identified where DRE still has value. Okay, but I just don't understand how you can guess prostate size. Why don't we let the MR? I mean, is it really accurate in guessing prostate size, or just
no? We can say small, medium, large, right? I think we can tell 20 from 60 for the most part, right? But obviously we're not going to tell you within 5 or 10 or even 20 grams, especially once it gets big, right? We can't feel the anterior. We don't know what's going on in the bladder. I mean, it's, the threshold for MR is going to drop more and more. It's just, it is way too expensive in this country compared to everywhere else on the planet. And that's a whole different conversation.
Yeah, that's a different conversation. Do you want me to get out my 2 other general comments before we go?
Sure.
Because we're going to spend active surveillance the last 45 minutes. So I want to give it time, but I don't want to give it all the time. I just want to mention 2 other quick things, and then it's going to be all active surveillance on an alphabetical list. Why are you on Twitter so much, by the way? No, I'm not saying that in a negative fashion. I mean, you're one of the more. If I talk to Alex at PCRI, she's got her hands on everything there and looking in the PCRI, the prostate cancer sphere. And I talk to other people, they say, man, Cooperberg's really active on Twitter. He's like really busy. I know that I put a slide up one time and you put it up on Twitter, but it was a nice slide. You didn't say anything mean about me. It was very complimentary. But do you want to just comment on why you're one of the most active oncology people on Twitter?
I've been doing this on and off for, it comes in waves for about, I don't know, a little over 10 years. And I was initially very skeptical when Twitter launched that it would have anything useful to do in healthcare. Yeah. There's actually a couple of colleagues of mine, Declan Murphy's been doing this even longer than I have, and Ben Davies, both of whom kind of made the case, especially when you're at a meeting. The old thing is, somebody would give their talk. Maybe there's somebody from Euro Today or one of these, magazines hang out in the, behind the plenary, and they grab you and do an interview. Maybe the next day, some article comes out online a couple of days later in the magazine, and the information kind of slowly percolates out there. Now, halfway through the talk, you can start getting information out there. And it was kind of this aha moment for me. One of these early meetings, I don't even remember what the talk was, but there was some key slide that I tweeted out, and I only had 200 people following me at the time, but 1 or 2 of them were journalists, and kind of the next thing you know, it was really kind of out there. So speed of transmitting information is much, much faster, and it's great for people that are not at the meeting to be able to follow what's going on, for both for the plenaries and for poster sessions. And for medical journals, there are, it goes without saying, there's too many journals these days. There's too many articles. It's incredibly difficult to keep track of what's going on. And there is, there's something to be said for, Twitter streams as part of, sort of another way of keeping track of what's going on in the literature. And it's a great place to have usually friendly debates and discussions about controversial areas. I will say the whole thing has kind of cooled off in recent months with Musk and X and Twitter in general. I think there's still a lot of activity in medical Twitter, and I hope that continues. I think it is a good forum.
How many people follow you on Twitter?
11,000.
It's a very large number. I actually checked.
It's about 11,000. It's not. Look, there's people like Stacey Lowe who are. What's that?
11,000? I'm just saying there's certain people I want on Twitter if they're going to choose to be on Twitter, and I'm saying this as a compliment. I've known you long enough to know that not only do I feel that you're objective, I feel that we're going to talk about this in a second, that you know the numbers and you know the data. So if anyone's going to go on Twitter, I'm happy. And I hope after this interview, it turns into 21,000. what I like about it is not just your objective reporting. I mean, you also insert your opinion. I think it seems to be, I don't follow you, but I don't follow anybody. So the truth is, anyway, I just wanted to know your opinion. I'm glad that you're doing it rather than someone who's, anyway, I won't go down that path. All right.
I appreciate that.
This is the last thing I want to do. And then I'm going to go hardcore into this. You wrote this, and I wish you would have changed the title. European Urology 2018. I love the title of this. I love these just non-generic titles, but you're going to learn something. How should a man with prostate cancer choose his surgeon? Ooh, ooh. Okay, so I'm gonna change the title for today.
Okay.
And I'm gonna say, how should a man with prostate cancer choose his localized treatment, whether it radiation, surgery, whatnot? Can you just give us what's the meaning here? Do you have any tidbits you want to give to the audience about just choosing a treatment doctor before we go into active surveillance?
Yeah, I mean, it's so, look, the first comment is that it is never an emergency. And, you know, the vast majority of urologists out there, radiation oncologists out there, know the material reasonably well and understand the lack of urgency and all that, and have varying degrees of objectivity about the whole thing. But I do see men for second opinions all the time who have felt like they're just being rushed into the OR or the radiation suite, you know, within weeks of a diagnosis. And the first comment is, it is never an emergency. If you've got a Gleason 9 tumor, you got to get moving, but that is in a period of months, not weeks. Okay. Prostate cancer grows over years. It grows over decades. I mentioned earlier, the autopsy studies, 50% of men have cancer in their later life. 30% of men in their 30s have cancer cells we can find on autopsy when they get hit by buses and things. Meaning, you know, these cells grow exceptionally slowly. Even the high-grade ones are not ticking time bombs. You know, you got to get on a high-grade cancer, but it's not an emergency. You have time to collect opinions. You know, generally speaking, you want to see somebody at a center of excellence. That does not necessarily mean an academic center. Often it does, but there are some of these large urology groups that have really subspecialized their care within a group of 50 urologists. They've got one or two, you know, men or women in the group who are really focused on prostate cancer and do the treatment exceptionally well and know the data. That's fine, you know, but you want a conversation with somebody that really eats, breathes, lives, and sleeps prostate cancer, which a lot of us in academics do. And these days with telehealth, it's just easy. You know, the interstate rules are getting to be a little bit of a minor barrier again, but you know, you can certainly find somebody in your state or cross state lines, or just tell somebody that you crossed the state line. Nobody's checking IP addresses on this, and do a televisit with an expert. You know, that is almost universal advice.
Okay, I'm just glad you wrote that. Are you ready to do active surveillance for the last 40 minutes?
Let's do it.
All right, let's just start at the A's. Let's just make it easy. Is there an age limit on active surveillance? You diagnosed me at 45 with a Gleason pattern. No, we're changing the name. It's called the Gleason pattern thing. We can't use the CA anymore. Look at, is there an age limit really? Because if I'm 42 and you're telling me I'm on active surveillance, I'm getting nervous if I want to live to 90.
Fantastic question. And the answer is absolutely not. So one of the key planks to this whole idea of early pervasive screening, you know, we cannot screen everybody at 45 if we're not willing to do active surveillance when we find these little specks of grade group 1, whether or not we call it cancer. Okay. So, you know, we find prostate cancer, we find a little bit of grade group 1 in a 43-year-old, a 45-year-old, a 49-year-old, 54-year-old. You know, those guys are going to need treatment at some point. You're 42, we already found it. You're not going to make it to 90 with an intact prostate. But the window of opportunity is going to be decades in most cases. Okay. And a lot of guys in their 40s are still having families. You know, sexual activity is really important. Some of them have, you know, new relationships, who knows? And there is no rush. I would much rather have my prostate out at 55 than 45, and I'd rather have it out in 2036 than 2026, quite frankly, because, you know, technology moves on, people get better, and the field moves on. So, you know, active surveillance does not mean watchful waiting. It does not mean go home and forget about this. It means you don't need to do anything about it now. Okay. Right. And even if they're only on surveillance for a year, maybe we see early progression, you know, even that 1 year of observation very reliably translates to less regret, better satisfaction, you know, this feeling that you weren't rushed into something. You've had time to collect your opinions, to kind of get your thoughts in order about it. All that is highly, highly valuable. Now, look, there are exceptions. And I've said before, even if we don't call it cancer, most of the time we shouldn't treat. You got a 43-year-old whose dad died at 56 of prostate cancer, and he's got 9 cores of Gleason 3+3, yeah, fine. Like, that is a conversation about if not when, and when not if, and when is probably not more than 6 months down the road. If that person wants to go straight to treatment, nobody's going to argue. Okay, but that is a edge minority situation. There's folks, to be clear, there's folks in the world who are doing prophylactic prostatectomies now. Just like we do. I don't know if you're going to BRCA for B, but this is happening.
I am going to BRCA for B, and I'm glad you brought that up. Okay, but I also think of I think of ASM. I think of mental health. Should anybody who's going to go on, this is very serious, actually. It's not a joke. So if anybody who's going to go to agree to be on active surveillance, I think of bariatric surgery. I think of other situations where mental health is evaluated before a protocol is installed. Do we have to know that somebody is mentally strong, low anxiety before they can enter this? Because I always learned that one of the greatest reasons people come off active surveillance wasn't that their cancer got worse, it was that their anxiety got worse.
Yeah. That is a really, really good question, a really important question. The answer is, I think, again, we talk about the ideal world healthcare system that would be part of it. Frankly, for everybody with a cancer diagnosis, I think the reality is we do not have enough mental health folks around the cancer center to do anything close to that. But I would also say that for most men who don't have an anxiety disorder but are anxious about the diagnosis, that's on me. Okay, part of my job is to dial down that anxiety. And that's gotten easier over the years. When I started in practice, which is now 12, 13 years ago, surveillance was still kind of a new idea outside of the academic centers. And this whole conversation, what do you mean you're not going to treat my cancer? I've got this, up every night in a cold sweat thinking about it. There is less of that. Surveillance is definitely more in the vernacular, most, at least around California. It is definitely a understood concept, I think, among a higher proportion of men. So that phenomenon is actually interesting. The phenomenon of treating men on surveillance, so switching to treatment with no objective evidence of reclassification of progression, that's still happening, but I think it's happening a lot less. We don't actually have great numbers on it. That's a couple ongoing studies are trying to get at that. So, I think for the most part, anxiety really needs to be managed by the urologist. That's part of what we do in managing prostate cancer and doing active surveillance. The folks who really have anxiety problems, and this is the straw that is going to break them, on top of the list of life anxieties, and, they're already under mental health care and all that. That's a different situation. They really do need to see psycho-oncology, or we have a symptom management service here. We will work with their psychologist, psychiatrist if they have one. Once in a very blue moon, that person might wind up getting treated. Sometimes we'll sort of, these days we have focal therapy, we have other things that we can talk about in that scenario too. But, at the end of the day, I can think about, out of almost 1,000 cases, there's less than 5 I've brought to the OR with grade group 1.
But but do you actually cover that in the consult? Do you talk about, the stress, the anxiety of it all? And do you guys have that part of the conversation generally?
A little bit. I mean, it depends a little bit on what the mood in the room or the mood on the Zoom feels like. And, the guys that are sort of marginally comfortable with it, we see them more often. This is also where genomic testing can be very helpful. Maybe we'll touch on that at some point too. I don't think genomics are necessary for everybody with low-grade disease, but anxiety is often a reasonable reason to get a genomic test done, get an MRI done, get more testing. Plus, I will say one other thing, which is that a critical point of active surveillance is the confirmatory biopsy. So when we see someone, especially if I didn't do the diagnostic biopsy, if I didn't diagnose the cancer, they come in from somewhere else. Yeah. Again, we don't trust outside radiologists, but we don't really trust outside radiologists or anybody else. And the confirmatory biopsy is really essential. It is not.
What does that mean? A confirmatory biopsy?
Meaning within the first year, we're going to do a UCSF or equivalent MRI and a biopsy by us with fusion to make sure we've not missed anything worse. And that is a really we know the upgrading rate is still about 25% from biopsy 1 to biopsy 2. Once biopsy 2 is done, if we've got 2 biopsies confirming low-grade disease, that's actually very, very reassuring.
So that's an interesting thought, because a lot of people get one biopsy in general and join active surveillance. Are you saying that most people should have 2 biopsies within the first year to
Well, the second,
really officially go into active surveillance?
yeah, I mean, the second biopsy is the launch for active surveillance in a way.
Okay.
Especially, like I said, especially if we're seeing somebody as a referral from outside, the clock is, you start the clock at the diagnosis, obviously, in terms of how long you've been on AS and all that. But, to me, until we have that confirmatory one done, I don't know if we're going to find something worse, because sometimes we do.
What's the time period generally between the initial one and the confirmation biopsy? Do you wait on purpose a certain time period?
Not really. There's so much variation in terms of when we see people, for one thing. And I will look at details there. A 78-year-old with 2 cores of Gleason grade group 1, I don't care so much. 43-year-old or 6 cores of grade group 1, MR showed something, we're going to do it sooner. Somewhere between 6 and 12 months is typical.
Okay. And we talked about a bunch of the biomarkers. You use that, but before we talk about that, I want to stay in the bees for a second, because you hinted at something. To me, this is the most controversial moment of the conversation. All right, let me just give you some history so you know. I mean, you know me a long time. You know I'm a little bit wacky, but not wacky enough that I can't be trusted. I remember going 6-7 years ago to people dealing with advanced disease, and I said, well, maybe it was longer. I said, these BRCA tests, BRCA looks like it's going to be a part of prostate cancer. Why shouldn't it be mandatory? Anyone that has advanced disease, get BRCA testing. And so now people are getting that with advanced disease. So now what I've been asking at meetings and moderating is I'm going, okay, well, shouldn't I want to know right after I'm diagnosed whether I'm not on BRCA positive? Why do I got to wait till I have advanced disease? If it may have some impact on whether or not I stay on active surveillance or what my prognosis might be, and the test is not that expensive, why can't everybody who's diagnosed today automatically shoot into a BRCA test? Give me one more thought. This idea that family history is really accurate. Come on. You talk to people that are 2 diagnoses of prostate cancer in the 80s, both were fine. That's family history is so relative, and we need other tools to define family history or genetic history.
Totally agree.
There's my question. Why isn't everybody diagnosed today getting a BRCA test?
The reality is we're probably heading that way. Okay. The guidelines in terms of who should be tested are broader every year. Okay. So it used to be you had to have like 3 first-degree relatives who all died of it. I mean, I'm exaggerating, but it used to be extreme cases. All right. Then it was everybody with metastatic prostate cancer. Now it's everybody with high-risk prostate cancer at diagnosis is eligible for testing. I'm not sure we'll get to the point where everybody with low-risk disease, if they don't have a family history, needs it, because the studies that have been done show that the prevalence of mutations is basically the same as the general population. So the tricky thing with prostate cancer is that, we know from these really nice genetic linkage studies done a long time ago, it is the most heritable major cancer, meaning family history. I mean, given all the limitations, I totally agree with you about limitations of family history. But if you look at family histories, prostate cancer is, the most attributable to who your family is compared to all the other major cancers, including breast cancer. The difference is in breast cancer, BRCA1 was just a massive smoking gun, and BRCA2, followed closely thereafter. Those 2 genes explain a high proportion of, bad breast cancers. The BRCAs in prostate explain a much smaller proportion of prostate cancers. BRCA2 was actually a bigger deal than BRCA1 in prostate. Interestingly, but the details again matter. I will see some men where they've got a BRCA2 mutation. All the women in the family have breast and ovarian. None of the men have prostate with the BRCA2. There's other men with the BRCA2, and all the men have prostate. So the specific mutation in the BRCA also matters. Yeah. But we're now doing germline testing. So germline meaning the DNA you're born with. And it's important just to understand this. This is a totally arbitrary, linguistic distinction. This is all genetics. It's all DNA. But we use the term genetic testing or germline testing when we say we're looking at the DNA that you were born with, that you inherited from your parents. You've got the same DNA in every cell in your body. The BRCA genes and the related genes are related to how the cells deal with mutations to the DNA. Okay, so walking around the world every day, all day, you get hit by a cosmic ray. You walk past a field with a little bit of radon in it. You drink too much Diet Coke, maybe, and you get mutations that happen in the DNA. And the Kidding about Diet Coke before they come after me with a libel suit. No known associations with DNA mutations. Your body has lots of repair mechanisms to catch errors in the DNA and fix them. Okay, and the BRCA gene and the related genes around BRCA, like ATM and CHEK2, these are all related to DNA repair. And if you've got mutations in those genes that you're born with, you are going to pick up more mutations as life goes on over the course of your life. The term genomics refers to how the regulation of the DNA in the cancer is off. Okay, so the DNA, you got 3 billion letters in every cell in the body. You think about those as broken up into words or paragraphs. Those are the genes. You got 30,000 of those. And what tells the body, well, that's a prostate cell, that's a brain cell, that's a bone cell, is the pattern of genes being turned on and turned off. I think about them as little switches, okay? And if you get too many signals, too many growth switches, for example, that are on when they should be off, too many regulation switches that are off when they should be on, things like that, that's a more aggressive cancer. So that's genomic testing, things like Decipher.
Right.
So BRCA, so we are testing more and more men with germline, and the guidelines are increasingly broad in terms of who should get germline testing. What the guidelines do not tell us is, what do we do differently now that we know you have a BRCA mutation? Okay, and just to make the point about AS, there's only one good study here that's been done so far from this Hopkins and one other center. So they looked at men who have a BRCA2 mutation, or they looked at BRCA1 or 2, or ATM, which is another cousin of the BRCAs. And what they looked at here, this is over time, okay, out to 10 years, what is the likelihood of finding a higher grade cancer? These guys all started with grade group 1. What are the odds of finding a grade group 2? So if you don't have one of these mutations, and this is Hopkins, where they check very aggressively. This is frequent biopsies, very low threshold for treatment. So out to 10 years, if you did not have one of these mutations, only 40% of men had an upgrade event. If you do have a BRCA2, that was about 80%, much more common. Slightly lower numbers for looking at all 3 of these genes. So what do we do with this? And this is truly controversial. I have colleagues who are total advocates for active surveillance who look at this and say, men with BRCA2 should not be on AS, they need to get treated. I have to say my take on this is, okay, well, let's look at the guys, look at the orange line here, the BRCA2s. At 5 years, half of them have reclassified. Okay, half of them haven't, right? Half those guys are chugging along with grade group 1. And just because you reclassify doesn't mean that we've now missed the window and you're going to die of cancer. When you reclassify, we treat with every expectation of cure. That's the point of active surveillance.
I know, but you just convinced me that everyone diagnosed should get a BRCA test based on that data. You know why? Because the patients are the customers, you're the business, and as a customer, I want to know. I want to know that there's with those graphs separated, and maybe they didn't separate enough, but I want to know that theoretically I have the prognosis has changed.
Correct. The prognosis is a little different. Prognosis is a little different. Does not mean you're going to die of cancer. It does mean you're more likely to need treatment at some point in the next 5 or 10 years, for sure. Now, the question, do we do that with a BRCA? Do we do that with a Decipher or some other genomic test? That's a whole... Decipher is a lot more expensive than the germline tests, but it's probably telling us a little more about the cancer biology, but that's a whole different...
Okay, but then you got to admit, there's this huge pool of guys who come to see you, that you go family history. Well, I was adopted. I didn't know my father that well.
Oh, for sure.
And so I don't know. I have no idea my family history. So will you still give me a BRCA? Like, what do you do in that case?
Anybody that wants one can get one these days. It's like $250. Most insurance covers it with like I said, the eligibility criteria are more all the time. So, look, we're seeing guys now that went to the shopping mall or, did a mail order whole genome test, with no particular indication, just because, they're worried or they saw an ad in whatever magazine. And now we're dealing with it, right? So this is going to happen more and more. This is like the Gattaca future where everybody knows their genome and we're supposed to know what to do with all these mutations.
I know, but this is the big target, right? I know that people are going to go, they're going to be a million companies offering a million different genetic tests, and we won't know 3/4 of the time, sometimes, what the difference means. But BRCA seems to not be whispering anymore. It seems to be screaming.
It tells us something, but do you go on to get a prophylactic prostatectomy? I would say absolutely not. Okay.
Yeah, no, I'm not saying but I
it
think
means, but it also means, I also would say it does not mean we should overreact about a grade group 1 in the setting of BRCA. We need to follow that guy more carefully. He is not somebody who drifts away for 5 years without an MR biopsy and all this sort of thing. He's a when, not if, but when may still be way down the road.
I know, but I'm getting to be an old man. And what I'm trying to tell you is, I know I look very young,
Yeah, yeah,
but let me tell you, I had a lot of breast cancer in the family that caused
yeah.
a lot of deaths. And the reality was they called BRCA for a reason, breast cancer. So we thought, then
Correct.
all of a sudden ovarian's tied. Then all of a sudden then all of a sudden
Correct.
prostate. Now they're telling me there may be related to pancreatic
Yep,
tumors
that too.
also, right?
That too. That too.
All right. I'm just telling you, for the audience out there, I'm not saying to go get out one of those tests and get 6,800 mutations are looked at that we don't know what to do with. I'm talking about BRCA testing. Now,
Yeah.
can I talk about pathology? And I'm going to
Sure.
talk about pathology based on the C's, cribriform, and all these.
Yes.
So now
Yes.
when people are getting their pathology reports and they get a Gleason 4, it says cribriform positive, cribriform not seen. And you've been writing on this. So
Yes.
can you comment on these pathologic variants that are
Yes.
scaring people into getting treated, and should they be treated? And what are the pathologic variants that scare you?
Yeah. So great question. Again, this is where the devil really is in the details, and it is another area of subjectivity. So just like the radiologists may disagree about PIRADS, very good pathologists may disagree about 3.3 versus 3.4. But where this focus has been is really the subtypes of pattern 4. Okay.
Exactly.
So Gleason 3, most pathologists agree on what it is. There's controversy between pattern 3 and something called a fused gland subtype of pattern 4. And not to get too far into the weeds, but what they're really looking at in the microscope is a cut across the prostate glands. What are glands? Are a bunch of tubes. If you cut tubes, with a knife, you're going to get a bunch of circles. And that's literally what the pathologists are looking at under the microscope is circles. When the circles are too small and they're kind of crammed together, that's a grade group 1. That's a low grade pattern, Gleason 3. The fused gland subtype of pattern 4 means the circles are starting to fuse with each other. They're not quite round. And it's not always clear, is that because the glands are actually fusing, or maybe the knife just went across the tip of one of these tubes. And that can be a subtle call, 3.3 versus 3.4. Now that fused gland subtype turns out to be the least worrisome of the pattern 4 patterns. There are other things that the pathologists see under the microscope, which they all agree, should be called pattern 4, but they are different. And the cribriform is definitely more aggressive on average than the fused gland subtype. Some pathologists, and not others, are then subclassifying cribriform into expansile or large cribriform. Those definitely matter. And there's another one called introductal, which definitely matters. I am very hesitant about surveillance if you've got these patterns, the expansile cribriform, the IDC.
You got to repeat that, because I almost got a pathology degree and then I left to go to medical school. And so what happened was, what I'm learning now from the pathologists, because I know they're learning this, is a cribriform is like the big umbrella, right?
Yeah.
Cribriform. So if you have a Gleason 4 and you see the word cribriform present, you can find all these subtypes of cribriform under 4. One of those subtypes, correct me if I'm wrong, this is what I've just been self-teaching, is the introductal, right? So if you have introductal, or you have a large cribriform, I've seen you talk about large cribriform, then you don't stay on active surveillance.
Yeah, those are concerning. Okay, those are real. Okay, but don't forget, you're talking about active surveillance in the Gleason 7 group, which already is, a lot of folks are not doing, which they should. Just to make this point a little bit more generally for a second.
Before you bring that point up, Matthew, but let me tell you why this. People will send me their pathology all the time and go, your pathology pretty well to be dangerous. So I look at it and they don't even mention whether or not they looked at cribriform.
Correct. And this, so you got to look, and this is where, it's just like seeing another urologist is important. Slide review is really important. We have all the slides re-reviewed by our pathologist. Hopkins does such essential service. That is critically important. Okay, critically. We will often see downgrading from small bit of 3.4 back down to 3.3. And yes, identifying expansile cribriform or large cribriform is really, really important.
And you were going to make a point, and I interrupted you. So.
No. I was just going to say that this question about cribriform is within the broader category of which guys with Gleason 7s can get AS, right? And the subtypes. So there's a couple things that are important here. The subtype of pattern 4 is really important. The amount of pattern 4. So 3 plus 4 means you've got anywhere from 5% to 45% pattern 4, and those are obviously quite distinct. And then the other one that gets a lot of focus appropriately is PSA density. So this is the PSA related to the size of the prostate. Right. If you have a high PSA, if you have a 100-gram prostate, well, you have a high PSA because you have a 100-gram prostate. PSA is prostate-specific antigen, not prostate cancer-specific antigen. So PSA of 8 in the setting of 100-gram prostate gives you a density of 0.08. It's literally just division, PSA divided by prostate volume. And we know that we can ignore that PSA of 8. If you have a PSA of 8 and a 25-gram prostate, we cannot blow off the PSA based on the size of the prostate. Yeah. So this is just 2 examples of patients who are both quote unquote favorable intermediate. But the guy on the left is a chip shot surveillance candidate for me, whereas the one on the right, I would be much more cautious and probably would be better off going straight to treatment.
Let me interrupt you there. So the PSA density, the cutoff I see from Hopkins and all these places where you can stay on active surveillance or not is 0.15. Do you use that 0.15 number where higher is more concerning to stay on active surveillance and lower is more favorable? Do you use that 0.15?
We do, not as a hard line, because like I said before, there are no hard lines, but that's definitely the threshold that has the most validity around it.
Okay, so this is mind blowing. So in the pathology, if you start throwing out intraductal or large cribriform, give me any more buzzwords. You're saying I'm not comfortable with active surveillance, plus maybe BRCA. We haven't decided on that.
Yeah.
But if those come up in pathology, intraductal,
large cribriform. Our pathology is called expansile cribriform rather than large, but those are the same thing.
Why do they do that? Come on. I'm pretty. That's the same thing as beautiful. Okay, so you don't have to change the wording.
Yeah, I agree.
All right, expansile. Okay, so expansile. Okay, all right.
Yeah, but yes, those are flags.
A pathologist wrote on this. It's also the number of cribriform sites. It was like the number, so that there was just no, it is. Look, the more cribriform there is, the more concerning it is. Any large cribriform, because you got to remember with prostate cancer, the cancer is driven by the worst corner of it. Okay, you can have a prostate replaced with 50 cubic centimeters of low-grade prostate cancer. You're fine. That is never going to spread. You can have a 1 centimeter Gleason 9, and that can be out in the bones. So, to that point, any large cribriform or intraductal to me is concerning, because that's the area where the cells can pick up the ability to spread. And it doesn't honestly even matter what's happening in the rest of the prostate, all the rest of the grade group 1 and all that. If you have a significant little nodule of these high grade patterns, we need to start getting concerned. Okay, so 11,000 of your Twitter subscribers now suddenly turned into 21,000, but half of them right now are going, wait a second, I've never heard these words. I never saw it on my pathology report. Should I get another biopsy and see if that's there? Because it wasn't on my original pathology report.
Yeah. Well, again, the slides can be reviewed. So you send off the slides from the original pathology for pathology review. Does not mean another biopsy. Means central review. Now, this again is where genomics can be very helpful.
Off to another reading, right?
Exactly. And if there's any doubt, edge cases, most Gleason 7s we do send for genomic testing. So whether if it's 5% fused gland, maybe not, but any cribriform or any significant amount of even fused gland, we will do genomic testing, not bracket testing. We usually use a test called Decipher. That's the one that looks at how the switches are inaccurately thrown that I mentioned before, and that can be a very good tiebreaker.
I wonder if someone's looked at cribriform and someone with a lot of cribriform actually comes up BRCA positive. I don't know why. I just thought of that on the top of my head.
That one, not to my knowledge. We actually, one of our residents just published looking at gene expression, Decipher testing in cribriform versus other patterns, and it is higher on average, but there's still a lot of variation.
Which one's higher on average? Say that again.
So intraductal is the worst, then expansile cribriform, then regular cribriform, then fused gland.
So intraductal on the cribriform scale.
Intraductal is the worst.
Is the worst.
Intraductal is the worst.
I'm telling you, this is the only video that's ever explained that. This was my understanding in my pathology learning sphere as I started to learn about cribriform. That wait a second, cribriform is this big tent. It's the pizza. Yeah. One of the slices is intraductal, and it's the worst pizza slice. It's the most concerning pizza slice, and you got to have a conversation about going off of active surveillance. Oh my gosh, this is mind blowing. But I got to ask you a few more because we only have about 10 minutes. Are you doing DREs and active surveillance, folks, or not? Okay, that's very honest. Here's the problem.
I cannot imagine a scenario where the DREs can tell me something that the imaging does not. We get MRI every 2 years at least, and I cannot imagine DRE picking up something faster.
Okay, that's really helpful. Okay, so you're not doing that. Okay, but the protocol is okay. Now I'm on the official Cooperberg active surveillance program, how often, just by the way, am I getting PSAs, and how often am I getting MRIs? Like, how often do I have to come back and see you?
It is all getting customized and personalized. So it really depends on the details. And this is important because everyone wants to know what our protocol is. And the reality is we are less and less protocolized as we've learned more and more about AS. Let me throw up one more graphic here in terms of the way we're thinking about it, or I'm thinking about it. You know, because we're getting so much more information about individual situations, we're really trying to customize how intensive we have to be about this. So first of all, you know, low volume, grade group 1, low density, no other risk factors. We do a confirmatory biopsy. Maybe it's even negative. If these men are older, they don't even need AS. And the folks in the UK are better about this than we are in terms of selecting men for watchful waiting, which means no biopsies. We'll just keep a, you know, half an eye on the PSA once in a while. But, you know, you're 78, you know, maybe you have some heart disease, you have 2 specks of 3-3. We shouldn't have done the biopsy. We certainly should not call it cancer. You're fine. If by some miracle, you know, well, if not by some miracle, if you happen to be around 20 years from now and develop a progressive prostate cancer, we'll slow it down. But the odds of that happening are exceptionally low. So that's watchful waiting. For the more typical person, higher volume grade group 1, maybe they have a little low volume grade group 2, the less concerning subtypes, as we just talked about. Maybe they've got a high density family history. Maybe their MR is more concerning. Then we really look at stability. So this is where we pick up information as we go. So if we get a couple biopsies under our belt, the MR is stable, the PSA is not doing very much, we can start to de-intensify. We're using MR to replace biopsies. We are backing off on the PSA frequency, et cetera. On the other hand, if they are, you know, if the PSA is drifting up, if the MR shows us a new lesion, they need what was standard for us 10 years ago, which is PSA every 3 months, MR every year. We do not skip the biopsies every 2 years. And sooner or later, we're going to be treating this guy. And then finally, they're the ones who I don't even really think should be on AS. Okay, so they've got a real grade group 2, they've got a BRCA. Okay, they've got
money. They got BRCA. See,
yeah, they got a BRCA. They got a real PIRADS 5, maybe even a little bit of 4+3. These are the patients that I really think should be treated. But some of them come and they really, really want to do AS. They've sought us out for surveillance. I don't kick them out of the clinic, but you know, these men, it is definitely when, not if. I get genomics on all these men. If they're favorable, okay, you know, they can go into a very cautious surveillance protocol. But, you know, if not, then they really need to get treated. And, you know, the only way you wind up in the treatment path is from one of these 2 boxes here. You know, we really should not be treating anyone until we find something that has to be treated. So, you know, the slide has gotten busier because it is more customized, more personalized.
What's older mean in that slide?
Life expectancy.
Okay.
Less than 15 years.
Okay, good answer. Good answer.
I do want to come back for 1 second to your question about, you know, how do you choose your urologist and how do we manage things? I want to show one more slide from data that just came out this year from a big national registry called AQUA that the American Urologic Association ran that I helped launch. And we had a paper out looking at the rates of active surveillance around the country and from practice to practice. So first of all, so this is just men with low risk disease, grade group 1, low stage, PSA under 10. So first of all, the good news is surveillance is going up from barely a quarter in 2014 up to around 60% in 2021. This is still not as high as it should be. We should be around 80 or 90%, but progress in the right direction. And this is about 25% of all urologists in the country that are represented in this database. Now, here's the however. The however is these circles here are individual urologists across the country, okay? And the x-axis is the percentage of getting surveillance by urology practice, these little hashes here, if you've got low risk disease, by practice. The y-axis is the individual urologist that you see. And the bigger the circle, the more patients they're seeing in a given time period. So depending on which practice you happen to roll up at, likelihood of surveillance ranges from 0% to about 75%. Depending on which urologist you happen to knock on the door, the rate ranges from 0% to 100% of men with low risk disease getting AS. This is a massive problem. Now, this is not remotely unique to active surveillance or prostate cancer or urology. We call this a small area variations problem in medicine and healthcare. We find this everywhere. We have the courage to pick up the rock and look under it. And this is true for tonsillectomy rates, for any, you name it, we find this variation. So it's not to pick on urology here, but to say that, where you go and who you talk to may have a very, very strong effect on what treatment you are guided to, subtly or not so subtly. And it's always worth getting second opinions.
Do PSA kinetics matter anymore on active surveillance? So someone jumps from a 3.2 to a 4.8. Am I freaked out? Do PSA kinetics, the way PSA is moving, PSA velocity, doubling time, any of these things, does these make a difference anymore in active surveillance for you?
They can if they are real trends over time. So, when you go from a 3.2 to a 4.8, we recheck it. 9 times out of 10, it comes right back down to a 3.6. So we look at the trends over time. When it is steadily going up over time, yeah, that matters. And we've shown in the Canary Consortium, PSA kinetics do matter. More rapidly rising PSA does matter. But what we don't have is a threshold where we say if the PSA doubles in X amount of time, that is an indication for treatment. Guys with PSAs that are rising faster, we take it a little more seriously. They need more frequent assessments, but they're not necessarily going to go straight to treatment. If they have really variable PSAs, that's something that sometimes we will put on a 5-ARI like finasteride or dutasteride because it's probably bouncing because of the BPH, and we're going to stabilize that, which I know is a whole different conversation.
That's a whole different conversation. Remember this trial, the meal trial?
Of course. June Chan, my colleague here at UCSF.
Yeah. So
that was Kelly Parsons. That was Kelly Parsons. Yeah.
But the point being, I wanted to touch this. I'm of course a big fan of diet. I'm a fan of taking something if you need it, but I also am a big fan of pure honesty. Yep. And so this meal trial was negative. They put active surveillance individuals on a healthier diet. Okay, they weren't vegan, but they moved more plant-based, and it didn't seem to work any better than not moving that direction. Do you take stock in this, or do you think there's a long way to go to still learn whether or not we should all go vegan on active surveillance?
The truth is, and you're probably going to agree with me on this, I don't care, because we give the men the dietary advice about the cancer at the time, at this teachable moment, and they're not going to die of a heart attack because they went on a plant-based or better diet. So, most men, as you of course well know, most men with prostate cancer die of heart attacks. So any favorable dietary, lifestyle, exercise changes that they make are going to help their life, period. Plus, it's good for their erections and their bladder function and everything else. So it's a win-win-win conversation. I think meal, any trial you're going to do in AS has a major endpoints problem. The event rates are low. I think it's way too soon to say it doesn't matter. It almost certainly does. You would probably need a 300,000 person trial over, over many, many years to prove it. And, it's just too expensive. But, healthy lifestyle is just so valuable from every other aspect that it's a no-brainer to give that advice.
I didn't know you were going to say that, and I love that answer. Like, I think of just breast cancer. There's done 10 times more work in diet than prostate, and Women's Health Initiative, others. Look, at least you were lowering the risk of cardiovascular events in people, and they were becoming heart healthier. What I just don't like is weaponizing diet. I don't like saying definitively, we know if you move into a cave and eat nuts and berries, it's going to change your possibility of going from a Gleason 3 to maybe no cancer. I don't know, but I'm saying as long as you're losing weight, as long as you're becoming more heart healthy, go for it. Whatever you want.
You're going to feel better. You're going to feel better. Like the vegan thing. I mean, I do joke. You might not live to 120, but if it feels like it took that long, then you're not enjoying your life, right? So you do have to enjoy the years as well as maximize them.
Do you counsel men on the fact that if they don't exercise and they can't go on active surveillance? See, that's my twisted world. If you don't exercise, you can't go on active surveillance. Knowing what we know about the ERASE trial and other trials that showed men became more mentally healthy on active surveillance, they maybe had some anti-prostate cancer effects. Shouldn't you have a piece of paper that says, unless you're going to exercise, I'm not going to follow you? Tongue in cheek, but kind of serious, right?
Yeah. I mean, again, you talk about weaponizing. It's hard. We'll see anybody, and we take care of. You meet people where they are as best you can. But I agree. We do. As you know, my colleagues here, June Chen, Stacey Kenfield, have been at this for years. We've had randomized trials of interventions in active surveillance. With specific, not just eat well, but some specific things like blueberries, cruciferous vegetables. There's some things that are probably particularly good to try to increase in your diet. And exercise is, the best thing you can possibly recommend in any healthcare setting. So,
save a ton of money on therapy for me. I can tell you that much, right? So I just know that you live it, you've done it. I'm assuming you talk about exercise and the data we have on active surveillance with patients, right? testosterone replacement therapy. Well, we know, I mean, at least the TV commercials tell me that every man should be on testosterone replacement therapy. Gee, I want to believe those commercials. Everybody is apparently hypogonadal. Everybody has low testosterone. We should be taking a million things. So this comes up all the time. What's your stance on, I'm just being sarcastic. What's your stance on testosterone replacement therapy for active surveillance?
In 1 minute, this one has really evolved. You know, I think time was when I was in training, that's putting fuel in the fire. You would never do that. It's malpractice. You know, then we would say, okay, after surgery, give it 5 years. If you're still negative, okay. Now these days, I think the thinking is really, look, if you had a normal testosterone, we wouldn't put you on hormone suppressive therapy to knock your testosterone down if you're on AS. So if you've got a low testosterone and you've got a lot of symptoms of, you know, hypogonadism, why wouldn't we supplement you back to a normal level? And that's kind of the way I'm thinking about it. But knowing, you know, acknowledging we have no real data about it. So, you know, if a guy has a normal testosterone, I don't really love it. I don't like super supplementation. And I think there's probably other reasons, his energy levels down, et cetera. But if he's actually hypogonadal, we've got it documented, and he's symptomatic, we'll supplement to get him up to, you know, low end of normal. But with the big caveat, the PSA is going to go up, and he's got to know that. And I will definitely make sure we've got a clear baseline PSA before starting. We're going to check it a few times in the next few months, sorry, in the next year, to make sure we know what the baseline now is. And he probably needs MR, you know, soon, and maybe a biopsy soon, to make sure we're not fueling growth of a cancer.
That's a good point.
You know, but we're doing it judiciously.
Okay, so I had one last question, but it's up to you whether you want it. It has nothing to do with anything we talked. It has nothing to do with, nothing to do with. It's just a general question, and it kind of makes me wacky because no one ever answers it, but you're the perfect person to answer it. I have a problem with the fact that there are two types of PSA tests out there, and some institutions only offer one or the other. And I understand what you offer, what our institution offers, but can you just explain this for a second? Let's just say it's after surgery. There's PSA ultrasensitive versus not so sensitive, right? So this goes down to 0.01 and maybe more. The other one is 0.1. Right. Can you just please give me the Cooperberg opinion on, do I get, after you treat me or anyone else, or say, should I just get an ultrasensitive or not an ultrasensitive? Should I get both? Why aren't we talking to patients about this on YouTube? Why not?
Don't get both. No reason to get both. First of all, ultrasensitive means different things in different places. You know, it's anything under 0.1 is considered ultrasensitive, and it tells us, you know, PSA less than. Because don't forget, what we're looking for is the less than. We'll never say 0, but less than. You know, so less than, where the regular test is 0.1. Ultrasensitive will say, I've seen 0.06, 0.05. Our place is 0.015. I've seen 0.006 at some places. You know, and there was a company, it didn't succeed, but there was a company that was trying to come up with like a nano-sensitive test that would get down to like 10 to the minus whatever. At the end of the day, we have done ultrasensitive as long as I've been at UCSF, which is almost 20 years now. Basically because we want the information and we want to know which way the wind is blowing. But this has come up at our patient services committee. You know, some of the advocates don't love this. You know, they would much rather not worry about the, you know, the 0.08 after surgery. It only really has a role after surgery. Okay, radiation, it just has to be low. It doesn't have to be 0. And if you haven't had treatment, it can be whatever. It's, you know, ultrasensitive is irrelevant. And ultrasensitive is only relevant after prostatectomy. And, you know, I can definitely see the scenarios where you're pretty far out from surgery. You know, we know you don't have a high-risk cancer. We don't want to know if you've got a 0.08 or whatever. Getting a lab to run both has just proved challenging at our place, and it's just not a battle that we kept fighting, so we kind of gave up. But you know, in theory, you could go to Quest and you know, we can order, you know, to Quest or LabCorp, we can order a non-ultrasensitive, but it becomes, usually we have the other problem. You know, we try to get ultrasensitive and they run a regular one. So it's, you know, I am, you know, personally just, you know, liking the data, liking the information. You know, if you get to 0.12, I kind of want to know if that happened in a month versus was it drifting up slowly. So again, as long as we are good about toning down the anxiety level and, you know, convincing men that they're not dying because they have a PSA of 0.07, you know, there's a lot to be said for that, I think. But there are places that just 2.1, and it's fine, quite honestly.
Yeah, no, I mean, it's important to mention. I've heard from some of your patients on your patient committees. They've said, Why can't we choose? And I'm going,
Yeah.
I'm not picking on UCSF. This is a national problem.
No, I know. It
Answer is
is.
they can choose, but they've got to talk to you about choosing. Am I correct?
It's not so much, it's more the lab directors, because it comes down to how they calibrate the machine.
Yeah.
So the lab would basically, because they don't want to buy a second machine. So the lab would have to mask it. So the lab would basically say, well, we know it's 0.07, but we're going to report this as a less than 0.1. And they've got their own fish frying, and
But this is what confuses people. If they've had ultra-sensitive PSAs and they're 0.08, 0.09, now they're 0.1, now they're 0.15. Let's say the ultra-sensitive says 0.15. Is that as accurate as the regular PSA now?
Yes.
Okay. So you can trust if the ultra-sensitive starts to go into 0.2, 0.3.
No, for sure.
That, right?
The only difference is that range below 0.1.
Thank you. So that's still a good test, even when the PSA
Absolutely.
Yeah, I mean, is there something I didn't ask you today? Because
we covered a lot of ground.
I've had with you in 30 years. I'm so glad we did it off the cuff. Is there something I didn't ask you I should have asked you? Because I went crazy.
We covered. I mean, there's always more to talk about, but I think we covered a lot of good ground.
Okay, but there's going to be a slight part 2. I'm going to let some of the readers. They're going to say, "Hey, Moyad, you didn't cover this," and I'm going to take their questions and say, "Listen, you bozo Moyad, you think you know so much, but what didn't you cover with the Cooperberg man?" And I'm going to tell him. All right, can Alex come on and give you your gift? We'll still give you your gift because you didn't come in person. There it is, baby.
Oh, that's a good one.
I know, but it's a running hat.
I love it.
So it takes sweat.
The Dubs need the support this year, so
they do. They do, because you got rid of the Michigan guy in their team.
Don't even get me started. It's driving me crazy.
Anyway, so this is.
Thanks so much. It's great to see you.
That's your running hat, so you got to run with it. It takes sweat well. Hey, listen, man, you've always been a great friend. You always do a great interview. I just think you're fabulous. I really do, and I love the fact that you take the tough questions and you don't just be PC about them. You answer them, and I hope you do get 21,000 on people on Twitter.
All right. At Dr. Coops.
Dr. Coops, thanks. Thank you.
Take care, all.
Our next speaker is a PCRI all-star. His name is Dr. Eugene Kwan, and he's a world-renowned urologist at Mayo Clinic who's been speaking for PCRI for years. He has expertise in imaging, immunology, and the treatment of advanced prostate cancer. Today, he will be continuing his insightful and in-depth DIY prostate cancer combat manual video series, which launched through PCRI in 2021. Now, his talk has 3 different parts, A, B, and C. A being the concepts behind advanced prostate cancer and the biology. B being the common terms that we hear and how advanced prostate cancer works and the options. And C, the options and how we apply them. Is your doctor really giving you the optimal care? One of the things I really loved about his talk is he talks about the gold standard versus standard of care and really optimizing care for you. Now, I strongly encourage everyone who wants to learn about the treatment of prostate cancer to watch his entire video series. Each talk gives practical ways to handle advanced disease, options for patients in advanced situations, and hope. Dr. Kwan has spent countless hours developing these talks, and it shows. He has an incredible heart for patients, and he wants to share his expertise with the masses and clarify that there are options even in the most serious situations. Through this series, he's sharing what he wishes every patient knew about advanced disease. Now here on the screen is a QR code to the previous talks, but you can also watch his talks through the playlist on the front of our YouTube channel. Right after his presentation, we're going to have a Q&A session with Dr. Moyad, and it's going to be very informative. So without further ado, here is Dr. Eugene Kwan.
I'd like to sincerely thank the PCRI for this wonderful opportunity to speak once again. Today's presentation is the Prostate Cancer Survival Guide, and the first part of this presentation is entitled Building Blocks for a Treatment Plan. All right. For disclosure, I always have to mention that the Mayo Clinic and I have received licensing payments for PD-1 and PD-L1 immunotherapy-related intellectual properties. And this particular presentation is focused on hope, all right? So who's this lecture for? This lecture is for any man who's battling advanced prostate cancer. More specifically, this lecture is for men who have forms of prostate cancer outside of their prostate, patients with advanced prostate cancer, metastatic disease. So, what's the problem? A surprising number of patients that we encounter in our clinic have not been offered the full spectrum of diagnostics or therapeutics that are currently available for the treatment of advanced prostate cancer. I find this incredibly distressing, and this begs the question why? One reason might be that both physicians and patients tend to want to oversimplify the treatment of prostate cancer. Everyone is stressed, there's a lot of emotion, people are in a hurry, and as a result, people want quick diagnosis and a quick pathway to treatment. Bada bing, bada boom. In addition, there's so many diagnostic and therapeutic options available for the management of prostate cancer. On top of this, there are so many different practice and business models that influence the management of advanced prostate cancer. You got urologists, you got radiation oncologists, you have medical oncologists, you have your insurance companies, you have pharmaceutical companies. All of these entities have different viewpoints about prostate cancer and different agendas. I also think so many terms and concepts are misinterpreted or misunderstood. Concepts like standard of care, guidelines, and clinical trials. Finally, there are some really outdated perceptions still floating around out there. These include the view that only old men get prostate cancer, or the statement that prostate cancer doesn't kill anyone, and the concept that prostate cancer can't be cured. Personally, I find some of these perceptions to be irritating or even offensive. The reality is that treatments are evolving at light speed, and the end result is mass confusion. Reminds me of a song by CCR, Credence Clearwater Revival, Who'll Stop the Rain. Long as I remember, the rain been coming down. Clouds of mystery pouring, confusion on the ground. So true, right? So the goals of this presentation are to update concepts pertaining to the biology of advanced prostate cancer, clarify terms and concepts that are often misinterpreted, and finally to provide an up-to-date resource or menu that patients can easily use to create checklists that will enable them to pursue most optimal forms of therapy to manage their advanced prostate cancer. But before I launch into this presentation, I just want to quickly review the basics of advanced prostate cancer so that everyone is up to speed with the terms and the concepts that we will be reviewing today. I can hear Mark Moyad sighing heavily in the background. Sorry, Mark. So once again, I've said this before, prostate cancer is like a dandelion. As everyone knows, prostate cancer first forms inside of the prostate, and like a dandelion, prostate cancer can send seeds throughout the body. Wherever the seeds land, they can grow more prostate cancer. And every site of prostate cancer growth is called a metastasis. Multiple sites of prostate cancer growth are referred to as metastases, like metastases. Finally, every one of these metastases can generate PSA to make PSA levels go up in the bloodstream. As a point of further clarification, even if prostate cancer grows in the lungs, it's still called prostate cancer. Likewise, if prostate cancer grows in the bone, or in the lymph nodes, or in the brain, or a major organ elsewhere, all of those spots are still called prostate cancer. You may also hear medical people use many technical terms when discussing prostate cancer: carcinoma, tumors, lesions, metastases, mets. All of these terms refer to spots of prostate cancer. Finally, you have to remember, even if a spot of prostate cancer is tiny, it's vital to remember that this tiny spot of cancer harbors a huge number of cancer cells, A spot of cancer the size of a drop of water can contain anywhere between 500,000 to 50 million cancer cells. So now that we've covered some of the basics, let's start discussing key concepts a patient might need to know in order to optimize his plan for treating advanced prostate cancer. Without question, I think it's imperative to understand the concept of cancer heterogeneity. I've mentioned this before. Prostate cancer cells are not identical clones of each other. Instead, prostate cancer cells tend to be heterogeneous. An obvious support of this when a pathologist evaluates a prostate cancer sample, the cancer specimen is typically assigned a Gleason grade, which is basically a visual description of the chaotic heterogeneity of cancer cells within the specimen. So, where does the heterogeneity of prostate cancer come from? Genetic instability. When a prostate cancer cell divides, it can generate two entirely different cancer cells. This leads to the heterogeneity of cancer cell populations within a patient's cancer. And heterogeneity of cancer cells can worsen over time and with therapy. Specifically, when a treatment is administered, it can set into motion the phenomenon of cancer cell selection, meaning that certain resistant cancer cells may survive treatment or be selected after a specific medication has been given. These selected cancer cells are then left behind to proliferate and spread. Simultaneously, selected cells may continue to mutate due to ongoing genetic instability. The collective process of selection combined with ongoing mutation is referred to as transformation of cancer cells. Transformation of cancer cells can lead to highly resistant cancer cells over time. When pathologists discuss prostate cancer, they are typically discussing three types of cancer cells: adenocarcinoma, neuroendocrine cancers, and small cell cancers. In general, adenocarcinomas generate PSA and respond to hormone therapy, whereas neuroendocrine and small cell cancers do not. Adenocarcinomas constitute 50% of the cancers that we see in our clinic, whereas neuroendocrine small cell cancers comprise about 5% of the cancers encountered. In reality, however, I think the classical view of prostate cancer is far too simple and does not account for the vast heterogeneity of prostate cancer. In fact, I suspect that about 45% of the prostate cancers that we see in our clinic don't fit into any classical descriptions of prostate cancer. Moreover, I suspect that most cancers that we see in our clinic likely harbor a blend of all of these different cell types. Thus, most men with advanced prostate cancer likely harbor multiple tumors composed of multiple different cell types that can change dramatically and with treatment over time. From this, it follows to eliminate a bunch of different kinds of prostate cancer cells, it will be necessary to use a bunch of different forms of treatment. So luckily, we have a wide array of systemic treatments that can be used to combat the heterogeneity of advanced prostate cancer. Here's a list of systemic treatments as of 2023. But before we discuss how to use these forms of treatment, I think it might be useful to understand a little bit about how these treatments work. So, what is a systemic therapy anyway? A systemic form of therapy is a drug that will spread throughout the body to treat all sites of cancer, both inside and outside of the prostate. Systemic therapies can cause some or all spots of prostate cancer to either go dormant or to die off. When I think about systemic therapies, I like to further classify systemic therapies into two separate categories of treatment, specifically suppressive treatments and cytotoxic treatments. Suppressive therapies can cause cancer cells to go into a state of dormancy or hibernation. Zzz. So that's like sawing logs, going to sleep. All forms of hormone therapy are thought to be suppressive. These therapies put cancer cells into a state of dormancy for months, up to years, but these forms of therapy are not thought to kill off prostate cancer cells. When used alone, these forms of therapy will fail over time, and they can give rise to more aggressive forms of prostate cancer down the road. These suppressive forms of therapy include the popular GnRH agonists and antagonists, including Lupron, Eligard, Zoladex, Firmagon, and Orgovyx. Also, oral anti-androgens such as Casodex, nalutamide, flutamide are all forms of suppressive hormone therapy. And finally, second generation hormone therapies, also known as ARPIs or androgen receptor pathway inhibitors, such as abiraterone, enzalutamide, apalutamide, and darolutamide, are also forms of suppressive hormone therapy. In summary, hormone therapies function to suppress prostate cancer cells, much like standing on the tail of a tiger to keep it in place. In contrast to suppressive forms of therapy, cytotoxic forms of therapy function by killing prostate cancer cells. Generally speaking, cytotoxic forms of therapy are thought to induce more durable outcomes when used to treat advanced prostate cancer. Cytotoxic forms of therapy include various forms of chemotherapy, including taxane-based forms of chemotherapy, such as docetaxel, cabazitaxel, PARP inhibitors, such as Lynparza or Rubraca, checkpoint inhibitor forms of immunotherapy, such as nivolumab, pembrolizumab, ipilimumab, and radio-ligand therapies, such as 177 PSMA lutetium, also known as Pluvicto. When constructing a treatment plan for advanced prostate cancer, I think it is also very useful to understand how these various drugs actually work against prostate cancer cells. In the medical scientific world, we refer to the way in which a drug works as mechanism of action, or MOA for the drug. Understanding the general MOA for these drugs is very vital so that you can construct a broad treatment plan that will be effective against the heterogeneity of advanced prostate cancer. For the purpose of this presentation, I'll describe the MOA, or mechanism of action, for these 1, 2, 3, 4, 5, and 6 different groups of drugs. So, hormone therapy is a suppressive form of therapy that capitalizes on the 1941 observation that prostate cancer cells use testosterone to grow. Testosterone is produced predominantly by the testicles, unless you cheated in pro sports back in the early 1980s. Anyway, once testosterone enters prostate cancer cells, it's converted to dihydrotestosterone, also known as DHT. Dihydrotestosterone then causes two halves of the androgen receptor to come together, and then this complex, which looks a lot like the old lunar landing module, moves into the nucleus, or the control center of a prostate cancer cell. Inside the nucleus, the androgen receptor complex interacts with the cell's DNA to stimulate growth and proliferation of prostate cancer cells. Popular forms of hormone therapy, also known as GnRH agonists or antagonists, such as Lupron, Eligard, Firmagon, or Govix, stop the production of testosterone by the testicles. This causes prostate cancer cells to become dormant, thereby arresting further proliferation of these cells. In contrast, anti-androgen agents such as bicalutamide disrupt the androgen receptor complex, which causes prostate cancer cells to go dormant. However, after prolonged use of hormone therapy, prostate cancer cells will awaken and become active again, even in the complete absence of testosterone. This phenomenon is mediated by mutated forms of androgen receptor that can function in the complete absence of any testosterone or any DHT. Clinically, this event marks the emergence of hormone resistant prostate cancer and is typically discovered due to resumed production of PSA and resumed cancer growth. Thankfully, an array of new drugs called androgen receptor pathway inhibitors, or ARPIs, I'm going to refer to them as RPs, can block activities of mutated androgen receptors in hormone-resistant prostate cancer cells. These drugs include enzalutamide, apalutamide, and darolutamide. These drugs will cause prostate cancer cells to once again go dormant. Abiraterone is also in this class of drugs, but abiraterone works differently from the other ARPIs or ARPs. Specifically, some of these mutated hormone-resistant prostate cancer cells develop the ability to counterfeit their own testosterone. Stranger than fiction, right? And as expected, counterfeit testosterone is used by cancer cells to make them prosper and produce PSA once again. Abiraterone shuts down this counterfeiting activity like Elliot Ness going after Al Capone, putting the cells back into a state of dormancy and once again lowering PSA. So let's move on to discuss some non-suppressive forms of therapy. In stark contrast to hormone therapy, chemotherapy is cytotoxic. In general, chemotherapies enter the cell's control center. There, the chemotherapies damage DNA to kill the cells. The main forms of chemotherapy that are used to treat advanced prostate cancer include the taxane-based forms of chemotherapy, docetaxel and cabazitaxel. Other forms of chemotherapy include platinum agents such as carboplatin, cisplatin, or agents like VP16. Finally, oral PARP inhibitors or poly-ADP ribose polymerase inhibitors such as olaparib or Rubraca also function like chemotherapy. Another form of cytotoxic therapy that can be useful to treat advanced prostate cancer is checkpoint inhibitor immunotherapy. This category of drugs includes agents such as nivolumab, pembrolizumab, ipilimumab. These agents work by triggering an immune response that attacks prostate cancer cells. Immune cells then swarm on the prostate cancer cells and kill the cells by injecting them with toxins, much like a swarm of murder wasps. Finally, radio-ligand therapy is another form of cytotoxic therapy for advanced prostate cancer. One form of radioligand therapy that has recently been introduced for the treatment of advanced prostate cancer is 177 PSMA lutetium. This highly specific form of radioligand therapy works by targeting the protein PSMA on the surface of some prostate cancer cells. Doink. Once this radioactive particle binds to PSMA on the surface of a prostate cancer cell, it's swallowed by the cell. And then the radioisotope delivers radiation to the cell and all cells around it, causing these cells to die. So in the next section of the Prostate Cancer Survival Guide, we will discuss how to assemble a treatment plan. So now that we generally understand how these various agents work, let's ask the question, what's the best way to create a treatment plan? I generally try to follow several major rules when choosing therapies for my patient. First of all, when one therapeutic agent fails, I always try to consider an agent that uses a different mechanism of action as the next form of treatment. For instance, instead of choosing another form of suppressive hormone therapy after hormone therapy fails, I might be inclined to select cytotoxic chemotherapy as the next form of treatment. Get it? Second, if a subject is healthy, I tend to be as aggressive as possible up front, and I try to use several diverse therapies in combination to treat advanced prostate cancer due to its heterogeneous nature. Or you might do something like this. Finally, I always try to formulate treatment plans that can whittle down the disease to a point where it might be eliminated altogether. Those who are familiar with my clinic already know that we generally favor curative pathways for treatment of advanced prostate cancer. We are not fans of serial palliative treatments where the only strategy is to hold the cancer down until the cancer becomes resistant and then aggressive and then fatal. Specifically, we try to pursue treatment sequences that are likely to reduce the cancer to something that can be killed off in the end by some form of direct therapy. By doing so, it is then possible to start thinking about rapid de escalation of therapy so that an individual doesn't need to stay on treatment indefinitely. Related to this, when a woman sees an oncologist for breast cancer, the first words that come out of an oncologist's mouth are surgery, radiation, chemotherapy, hormone therapy. And these four treatments are offered with intent for cure. In my opinion, I feel that our approach to treating advanced prostate cancer is closely aligned with the aggressive contemporary approaches that are used to treat virtually all other forms of advanced malignancy. At any rate, to achieve this goal, proper sequencing and planning of therapies is imperative. So now let's discuss how a person might use this menu of systemic therapies to combat advanced prostate cancer. In what follows, I'm going to present some of the most commonly encountered cases that we see in my clinic that I feel best illustrate smart options to treat advanced prostate cancer. Just as a reminder, today's discussion primarily pertains to treatment of individuals who have rising PSA and metastatic disease. You'll see some abbreviations in my slides. So just for clarification, HT is hormone therapy. ARPI, I'm going to use the word ARPI, ARPI. You can repeat it with me, ARPI. Androgen receptor pathway inhibitor or second generation hormone therapy. CHTX is chemotherapy, IMTX is immunotherapy, RTL is radio-ligand therapy, and PARPI is a PARP inhibitor, also known as poly-ADP ribose polymerase inhibitors. It's a mouthful. So before we plunge into the very complicated world of failed therapies, I'm going to say a little bit about the treatment of newly diagnosed metastatic prostate cancer. Specifically, Bob is a 67-year-old man who's relatively healthy. He was recently found to have a PSA of 117, clearly abnormal. On the PET scan, he was found to have multiple metastases in the bones and in the lymph nodes, seen by the red arrows here. Biopsy revealed Bob has Gleason 8 prostate cancer. Thus far, Bob hasn't received any treatments whatsoever. What should Bob do? Well, if you're a relatively healthy man with newly diagnosed advanced prostate cancer, like Bob, triple therapy is probably the best way to launch into this treatment. Triple therapy is the simultaneous use of a suppressive form of therapy such as Lupron, Eligard, Firmagon, or Govix, in combination with a second generation form of suppressive hormone therapy such as abiraterone or darolutamide, in combination with 6 cycles of a taxane-based form of chemotherapy, usually docetaxel first, sometimes cabazitaxel. Generally, chemotherapy requires IV infusion by a medical oncologist once every 3 weeks for typically up to 6 cycles of treatment. However, depending on the response to therapy and the tolerability of treatment, up to 10 cycles of chemotherapy can occasionally be administered. Thankfully, triple therapy has recently become the IT therapy or the in vogue treatment for advanced prostate cancer. Thank goodness. In our clinic, we've used triple therapy combined with directed forms of therapy that we'll discuss later on with curative intent since about 2010. For those of you who have seen some of our previous presentations, I've referred to triple therapy as the deluxe treatment package. Although triple therapy is commonly given to men with extensive metastatic forms of prostate cancer, we also favor use of triple therapy early on for young men as well as healthy older men, since use of suppressive therapies alone, such as hormone therapy plus or minus an RP agent, inevitably will fail over time. Likewise, we strongly favor use of triple therapy early on in men whose cancers harbor aggressive features such as high Gleason score. But what if you didn't start with triple therapy? Is there still a promising therapeutic pathway forward? The answer is yes. Over the next segment, I'll review some of the most common situations of failing therapy that we see in our clinic. I'm going to try to show you how we use the 2023 list of systemic treatments to best guide yourself, or how you can use the list to best guide yourself from one treatment plan to the next. Originally, I was going to try to cover every scenario possible so that you'd never have to go visit your doctor ever again. But Dr. Moyad and PCRI thought that my 76-hour presentation was a bit excessive. Therefore, I've trimmed down my presentation to just touch upon some of the high points. For case number 1, let's talk about Eric. Eric is a 72-year-old who has been on continuous hormone therapy for 2.8 years. Most recently, his PSA has started going up, and it's risen from undetectable to 17.2. On a scan, he's found to have cancer in some lymph nodes as well as on the bone. What should this patient do? So when a patient is on hormone therapy, his PSA value should be undetectable, meaning less than 0.10 nanogram per ml. If the PSA is rising above 0.10, and or if he is experiencing spreading cancer on a scan, then that patient is developing hormone-resistant prostate cancer. The designation for hormone-resistant prostate cancer is HRPC or CRPC. The little m means metastatic. So the bottom line is, if you're on hormone therapy, Your PSA should be less than 0.10, and you shouldn't have cancer that is spreading or apparent on a scan. For many patients who fail hormone therapy, an oral second generation form of hormone therapy, referred to as androgen receptor pathway inhibitor, or ARPI, is often prescribed. Just like conventional hormone therapy, these agents are typically convenient to administer and are also suppressive. In general, the 4 RP agents that are shown here are roughly equivalent in terms of their ability to control disease. Use of these agents will generate a favorable drop in PSA in about 75% of the patients treated. Treatment with these agents is palliative, lasting about 1 to 3 years. Another option for men who fail hormone therapy is treatment with chemotherapy. Frontline chemotherapy for hormone-resistant prostate cancer is docetaxel. Second-line hormone therapy for hormone-resistant prostate cancer is cabazitaxel. Favorable responses to these chemotherapies can be seen in roughly 75% of patients with relatively minimal side effects of treatment. For healthy men, we tend to favor chemotherapy over RP agents for several reasons. First of all, it's our impression that responses to chemotherapy tend to be durable. In addition, therapy is finite, usually being completed within about 18 weeks. In addition, we have previously published that men who have been treated with chemotherapy first, depicted by the red line here, seem to survive longer than men who were first treated with oral RP agents, depicted by the blue line here. In addition, we've noted that patients who fail RP agents tend to be very difficult to treat with chemotherapy due to probable hardening of resistance brought on by prolonged treatment with suppressive agents. The reverse, however, doesn't appear to be true, since patients who fail chemotherapy first tend to respond very well to RP agents down the road. At any rate, any conjecture that chemotherapy is better than an RP agent is probably a moot point, since it seems likely that combined treatment with an RP agent and a taxane-based form of chemotherapy is likely far superior to using these two forms of treatment alone. In our experience, using these two treatments in combination results in favorable response therapy in about 80 to 90% of patients that we see. Okay, what about case number 2? In this case, Neil is 45 years old, and he's been on hormone therapy for 13 months, but he also started enzalutamide 13 months ago. Most recently, Neil noticed that his PSA is going up. It's no longer undetectable, it's 0.11. He got a scan for this, and the scan shows horrific disease, innumerable metastases spread throughout his bones and throughout his lymph nodes. What should Neil do? In our clinic, we encounter quite a few patients who have failed both hormone therapy, such as leuprolide, and at least one form of RP therapy. In general, these patients are very difficult to treat, most likely due to hardening of resistance induced by long-term use of suppressive forms of therapy. Nevertheless, these patients do have multiple options for treatment. One therapeutic maneuver that is frequently offered to this group of patients is to simply switch from one RP agent to another. For instance, if a patient was failing enzalutamide, his physician may switch him to apalutamide. In general, switching back and forth between the various RP agents is a relatively weak maneuver that triggers only transient improvements for a small percentage of patients. I typically don't use this maneuver unless other more robust options have been completely ruled out. of course. One exception to this, however, is when a patient is switched from an RP agent such as enzalutamide to abiraterone or vice versa. Due to the differences in the mechanism of action for abiraterone versus the other RP agents, strong and lasting improvements in therapy can sometimes be observed upon switching between abiraterone and other forms of RP agent. However, once again, this is only a palliative maneuver. For this reason, and almost without hesitation, when a man is healthy, we strongly prefer taxane-based chemotherapy for initial treatment after a patient has failed both hormone therapy and an RP agent. In this context, treatment with a taxane-based form of chemotherapy will evoke improvements in disease for about 40-50% of patients. Even better, treatment with a taxane-based form of chemotherapy plus a platinum agent such as carboplatin can generate more favorable responses in about 60-70% of patients after failure of hormone therapy and an RP agent. Response therapy might be further enhanced by switching RP agents at the same time while treating with chemotherapy with a taxane-based form of chemotherapy plus or minus carboplatin or platinum-based agent. Finally, based on its PSMA-4 trial, Novartis recently announced that 177 PSMA lutetium improved outcomes for men with hormone refractory PSMA positive disease after failed RP therapy. Therefore, we anticipate that 177 PSMA lutetium may soon become available for treatment of patients who have failed hormone therapy and who have failed at least one RP agent. However, the extent to which radio-ligand therapy can outperform chemotherapy for this population of patients has not been determined and will need to be determined in future trials down the road. One more thing, for those of you who are still awake during this presentation, why is Neil's PSA so doggone low? As I mentioned before, as prostate cancer cells become more mutated and more aggressive, they become more chaotic and uncivilized, and they can lose the ability to produce PSA. Therefore, some of the most aggressive and advanced forms of prostate cancer that we see in our clinic are associated with extremely low levels of PSA. Related to this, 20 to 40% of patients who are being treated with an RP agent will exhibit a paradoxical response therapy in which PSA values are declining, but the disease is actually worsening on imaging. Finally, even worse than that, 12% of patients that we encounter in our clinic who are on suppressive systemic therapies will exhibit metastatic disease progression despite having undetectable serum PSA value. We refer to these patients as PSA 0 patients. The take-home message is you cannot depend on PSA values to tell you how you are doing, especially if you're on suppressive forms of systemic therapy to manage your advanced prostate cancer. Instead, you can only depend on imaging to tell you how you're doing when you're receiving systemic therapies. So some patients that we see in our clinic have actually received past treatment with chemotherapy. In case number 3, Mark is 52 years old. He's failed hormone therapy 4 years ago. He also received some docetaxel chemotherapy about 2 years ago. Now, Mark's PSA has suddenly risen to 425. As might be expected, Mark's bone scan shows lots of spots indicating metastatic disease. So what options for therapy does Mark have? So Mark has failed hormone therapy and has previously received some chemotherapy. The most common question that comes up in this situation is whether or not chemotherapeutic treatment can be repeated. And the answer is yes. Not only can the chemotherapy be repeated using the same agents as before, but it can often be repeated with expectation of a decent response. In addition, chemotherapeutic retreatment can be performed using a second line agent such as cabazitaxel, and even better than that, retreatment with docetaxel or cabazitaxel can be enhanced with the addition of something like carboplatin. As I mentioned before, use of ARPI agents after failed chemotherapy works very well. You can get some very favorable responses with RP agents after chemotherapy. Finally, retreatment of patients with some form of chemotherapy retreatment in combination with an RP agent can elicit a very robust response to therapy. So, what about men who have failed multiple therapies? So, David's a 67-year-old gentleman who's failed hormone therapy 4 years ago. He was also treated with Taxotere chemotherapy 2 years ago. And he's been on an RP agent for the last year and everything's failing. David's PSA is now 1,328. His most recent scans reveal metastases diffusely spread throughout the bones and the lymph nodes. What should David do? So David's situation is probably the most common situation that we see in our clinic. At first blush, it probably seems like David is in big trouble. However, believe it or not, David still has quite a few potentially effective treatment options available to him. Once again, a patient like David may benefit from trying an RP agent he's not received previously, especially if he's not switched between abiraterone and the other forms of RP therapy and vice versa. And once again, a patient like David might benefit from chemotherapeutic retreatment with either docetaxel or cabazitaxel alone or in combination with carboplatin. And on occasion, a patient like David might also benefit from other forms of non taxane based chemotherapy, such as treatment with cisplatin or carboplatin or etoposide. Most recently, however, patients who come to our clinic after failing hormone therapy, RP, and chemotherapy are offered radio-ligand therapy with 177 PSMA lutetium, also known as Pluvicto. This form of therapy was first approved by the FDA in March of 2022. In general, a response to this therapy is observed in about 60% of patients who are treated. To date, we've treated nearly 300 men with Pluvicto in our clinic at Mayo. About a third of our patients exhibit very robust response to treatment, especially when disease volume is low. But wait, there's more. Men who have failed multiple forms of therapy can, on occasion, suddenly become eligible for treatment with agents such as PARP inhibitor and or checkpoint inhibitor forms of immunotherapy. What? So did I hear someone in the audience just ask, how is this possible? That's a joke. I'm in my office giving this talk virtually, so there's no audience. Some patients may say, well, my doctor said that's not going to work for me. He tested for that many years ago. How can you tell me now that suddenly these therapies are going to work for me this late in the game? This is a great question. In the next section of the Prostate Cancer Survival Guide, we will discuss the proper care and feeding of your treatment plan. Remember these slides? They showed that over time and with therapy, genetic instability generates further heterogeneity of cancer cells. Therefore, treatments that may not have been possible early on might suddenly become more relevant over time. It is for this very reason that we use this comprehensive strategy to follow our patients over time. Specifically, we have our patients follow up with us every 6 weeks to every 3 months after starting a new therapy. We repeat blood tests at every follow up visit, including assessments of PSA, alkaline phosphatase, testosterone. We additionally have our patients follow up with us after every 3 infusions of chemotherapy, approximately 9-week intervals. And we repeat PET imaging of our patients every 3 months. On occasion, we also obtain conventional imaging of our patients to get more detailed views of the skeleton, abdomen, pelvis, or chest if we have questions about those areas of the body. Finally, we always have our patients undergo genetic testing before starting any form of therapy, and we always have our patients who are failing therapy repeat their genetic testing approximately every 3 months. So let's talk a little bit about genetic testing. Many patients that we see in our clinic have not undergone any form of genetic testing. These days, I think that's probably not acceptable. Some patients that we encounter have only undergone genetic testing one time, sometimes a very long time ago. This is also a problem because, as we've already discussed, cancer changes over time and with treatment. Cancer genetics are dynamic. You shouldn't base huge therapeutic decisions on genetic profiles that might no longer be relevant. Other patients have only undergone something called germline testing or genetic counseling. This is probably also not acceptable. Most treatments for advanced prostate cancer or cancer in general are based on somatic genetic profiles. This means that you need to assess the genetics of your cancer and not just the genetics of the body that you are born with. If the only form of genetic testing that has been conducted for you is germline testing, such as testing cheek cells from your mouth by a genetic counselor, that's not sufficient to assess the genetics of your cancer. Related to this, sometimes treatment is being based or assigned based on a tissue biopsy, for instance, from original prostate biopsy from years ago, or from a lymph node. Obviously, an original prostate biopsy or prostate specimen from many years ago is what I consider to be yesterday's news and is likely irrelevant to assigning therapy for a patient that has ongoing advanced prostate cancer. Likewise, a biopsy from a single lymph node might not be representative of the genetics of the patient's cancer in totality. Therefore, we typically interpret genetic profiles from tissue samples or biopsies with some degree of caution. Anyway, since it's clear that cancer changes over time and with treatment, we repeat genetic testing roughly every 3 months in patients who are failing therapy. In my opinion, genetic tests that assess circulating tumor cell DNA in the blood are probably the best because these tests likely reflect changes in the genetic profile of the patient's cancer overall and in real time. For this reason, we tend to favor blood sample assessments of circulating tumor cell DNA using kits such as Guardant 360 or perhaps Invitae testing. Based on observations made in our clinic, we know that serial genetic testing will show variations in tumor mutations over time. And we typically look for two specific classes of mutations that can be exploited to enhance advanced prostate cancer therapy. One class of genetic changes pertains to mutations in DNA damage repair genes, or DDR genes. Don't confuse this with CCR, which is Creedence Clearwater Revival. This is DDR, DNA damage repair genes. The upfront incidence of germline DDR mutations among men with advanced prostate cancer is about 10%. However, over time and with treatment, DDR mutations likely increase in incidence to 30%. Common mutations in DDR genes found in association with advanced prostate cancer include mutations involving the BRCA genes, BRCA1 and BRCA2, as well as ATM and CHEK2 mutations. If some of these mutations are discovered during serial genetic testing, then a PARP inhibitor agent might prove useful for therapy. PARP agents such as Lynparza or Rubraca are convenient oral agents that function like chemotherapy. When a relevant DDR mutation is present, the anticipated response for treatment with a PARP inhibitor is approximately 33%, and these can be fairly profound responses. A second class of mutation that might appear during serial genetic testing pertains to checkpoint inhibitor forms of immunotherapy. Early in its development, we've determined that prostate cancer represents a lousy target for immunotherapy. But we found that prostate cancer does accumulate mutations over time. And some patients' cancers will eventually acquire so many mutations over time that the cancer itself becomes recognized as a foreign predator by the patient's host immune system. At this point, checkpoint inhibitor immunotherapy may prove useful to treat the patient's cancer. Specifically, as a cancer becomes more heterogeneous and more chaotic, two parameters called MSI, which is microsatellite instability, and TMB, which is tumor mutation burden, can increase over time. MSI and TMB are indices that can reflect the immunogenicity of a patient's cancer. Over time, serial genetic testing sometimes reveals that a patient's cancer will acquire an MSI high designation or a TMB value of over 12 mutations per megabase DNA segment. Such findings might suggest that a patient's cancer can be treatable using either a checkpoint inhibitor such as nivolumab, pembrolizumab, or pilimumab. Using serial genetic testing, we've identified patients who have failed up to 6 to 8 forms of prior therapy who suddenly become candidates for PARP inhibitor or immunotherapy, sometimes with excellent responses. For example, Al is a 75-year-old gentleman. Obviously, so I'm not using anyone's real name in my presentation. Just want to make that clear. And the names that I actually picked for all of my case, they're all my favorite electric guitarists, all right? So you'll have to figure out who they are, or they're all my favorite guitarists, but that's where I got the names. So Al is a 75-year-old who previously failed radical prostatectomy, external beam radiation therapy, hormone therapy, abiraterone, enzalutamide, Taxotere times 6 cycles of treatment. He's also failed a PARP inhibitor for a previously documented BRCA2 mutation. He's failed apalutamide. He's failed stereotactic radiation therapy for oligometastatic disease. He's had palliative radiation therapy and Taxotere plus carboplatin times 8 cycles of treatment. This is an average day in my clinic. Now, Al's PSA is 330 nanograms per ml. It's jumped up dramatically. A recent PET scan clearly shows that Al's in trouble. He has multiple metastases throughout the bones and the lymph nodes. So we decided to retest Al's genetic profile, as we do for all our patients who are failing therapy, and a repeat in the genetic profiling showed that he had a TMB value, tumor mutation value of 22 mutations per megabase DNA. Based on this observation, Al was assigned to receive checkpoint inhibitor nivolumab, which is also known as Opdivo. Thus far, Al has only received 6 of the 25 cycles of treatment planned. Al's PSA has dropped down to 35 nanogram per ml, and his scans have markedly improved. As an aside, it's very important for you to always check what type of genetic testing is being done on you. Not all kits will test for key mutations that are important for the treatment of your cancer. For this reason, and probably because we just don't want to think about it that hard, our group uses Guardant test kits since it examines many of the key mutations that we believe are typically relevant for the treatment of advanced prostate cancer. So I hope I've impressed upon you how imperative it is to have a comprehensive follow-up strategy when treating advanced prostate cancer. But what other useful bits of information might be gleaned during regular and comprehensive follow-up? Well, for one thing, a patient might actually discover that he is not as sick as he thought he was after receiving systemic therapy. In fact, he might even find out that he only has a very small amount of residual cancer that might be amenable to complete elimination using various directed forms of treatment, sometimes even to achieve a curative outcome. In order to identify patients who might benefit from small amounts or who might have small amounts of residual cancer that might benefit from directed therapy, as I mentioned before, we aggressively repeat PET and conventional imaging of our patients who are receiving systemic therapy. I've stressed the importance of repeat imaging in some of my previous lectures. As many of you already know, I do not believe that you can effectively treat advanced prostate cancer unless you visualize it and know precisely what you are treating. Since this topic has been previously discussed in some of my earlier DIY combat manual presentations, I encourage you to go back and look at some of these presentations. If you scan this code here, it will take you to those previous lectures, but don't scan the code right now, because if you scan the code right now, then you won't watch this lecture, okay? At any rate, there are multiple ways that residual disease can be eliminated after completing systemic therapy. For instance, at Mayo, as I've shown you before, we routinely use surgery to eliminate disease in the chest and in the pelvis. So for example, here's a patient that completed systemic therapy and there's just one spot of cancer left over. It's a lesion in the chest. We have a dedicated thoracic surgeon at Mayo who does our chest cases for advanced prostate cancer. He resected this one lesion. PSA went from 1.1 down to undetectable. It's a year out, patient's doing wonderful. Just like the surgeons, the radiation guys, or the radiation faculty are able to eliminate various forms of residual disease after systemic therapy. And they have all kinds of tools. And I tell you, radiation has really become remarkable. They can basically eliminate virtually everything except for widespread systemic disease. So using stereotactic irradiation such as SBRT, they can remove oligometastatic disease. Here's an example of a patient that we presented 11 years ago. This was one of the first cases of solitary met or oligometastatic disease that I brought up at a PCRI conference about 11 years ago. This patient had PSA of 1.2, had a lesion on his lumbar spine, got treated with stereotactic radiation, and 11 years later, no further therapies, doing great. Likewise, same kind of patient, has a single spot in the middle of his breastbone. 10 years, 9 months ago, we irradiated that with stereotactic radiation, the disease is gone, stayed away. The radiation oncologists also have general radiation that can be used to mop up residual disease in places like the pelvis or the retroperitoneum. They can also use stereotactic radiation now to even go after lesions inside the prostate that have sometimes even been irradiated before. Alternatively, minimal invasive procedures such as cryotherapy or thermal ablation can also be used to eliminate residual disease following systemic treatment. This includes residual disease in the prostate. This is a case that was done by Dr. Minders and Dr. Woodrum here at Mayo Clinic. They're experts with cryoablation and thermal ablation. Here's a patient that had a little bit of disease left in his prostate after systemic therapy. This patient received either thermal ablation or cryoablation. It's doing wonderful. PSA dropped down to 0.31. Minimal invasive procedures can also be used on bone and in lymph nodes. And minimal invasive procedures can even be used to eliminate disease from the liver. So here's a gentleman that Dr. Woodrum worked on. PSA 3.7, liver lesion. Dr. Woodrum did an ablation on this. 2 years later, patient has undetectable PSA, no evidence of disease recurrence. So this brings us to the last part of my talk. And finally, at the very beginning of my presentation, I indicated that many of the patients that we see in my clinic have not been offered a full spectrum of diagnostics or therapeutics that are available for treatment of advanced prostate cancer based on my observations over the last many years. I do believe that one major reason this occurs is due to misinterpretation or misunderstanding of several commonly used terms or concepts. These include standard of care, within guidelines, and clinical trials. We see a significant number of patients in our clinic who are told that they cannot undergo a procedure or specific treatment since it's not regarded as standard of care. Many patients take this as some kind of gospel, sometimes with tragic consequences. What you need to know is standard of care does not mean gold standard of treatment. All right? Instead, standard of care really means acceptable bare minimum treatment. Okay? It's just like the term shelter. The basic word means something that covers or affords protection, but a shelter can be a shack or it can be a mega mansion, kind of like the one that Mark Moyad lives in. Therefore, it's important for a patient to realize that the term standard of care encompasses a very broad swath of available diagnostics and therapeutics for the management of advanced prostate cancer, ranging from bare minimum to an acceptable level or average level to an exceptional level of care. In fact, for patients with advanced prostate cancer who have failed some form of therapy, many professionals would absolutely agree there is no real single standard of care. Finally, it's important for a patient to realize that he's fully entitled to the highest levels of care that he so chooses. If a patient is being told he cannot undergo a certain diagnostic evaluation or treatment because it's not standard of care, I would strongly recommend that the patient challenge that or seek a second opinion. Likewise, a fair number of patients that we see are told that they cannot undergo certain forms of diagnostics or therapeutics because these things are not within guidelines. There's no question that guidelines are important to define some basic boundaries of clinical practice, but guidelines are like guardrails on a road. Guardrails define extreme edges of the road, but they don't define the journey. Once again, if a patient is being told he cannot undergo certain diagnostic evaluations or treatments because it's not within guidelines, I would strongly recommend that the patient consider getting a second opinion. Finally, I'm occasionally alarmed, to say the least, to encounter a very sick patient who has received clinical trial treatment in lieu of a useful FDA approved form of therapy. In fact, some of the patients that I see in my clinic haven't even been told that these other therapies are out there and instead are put on clinical trial. For 11 years, I served as the chair of the Institutional Review Board here at Mayo. In this capacity, I was in charge of overseeing the safe and ethical conduct of human subjects testing. Needless to say, based on what I encounter in my clinic, I do sometimes worry that patients are not being sufficiently educated or informed about the role of clinical trials in their overall care. Specifically, I think it's absolutely imperative for a patient to understand that clinical trial does not mean state of the art therapy. In fact, the likelihood that a candidate drug or treatment will pass through all the hurdles to succeed and get FDA approval for solid malignancies at best is 5 to 10%. Patients on clinical phase 1 and phase 2 trials gain very few benefits from being on trial. Maybe slightly higher benefits are extended on phase 3 clinical trials. However, benefits extended to a patient on a clinical phase 3 trial might still be quite limited since these trials tend to be randomized and definitions of benefit may be modest at best, prolongation of survival for an average of 2 months. Even worse, you might be randomized to a controlled treatment group in which you receive a minimal form of standard care therapy until you exhibit significant radiographic progression of your disease. As a result, you might significantly delay your access to a useful next step therapy. At any rate, although it's clear that clinical trials are vital for the development of new drugs, no doubt, I think you should review all treatment options that are available to you prior to enrolling on a clinical trial. When in doubt, have other physicians or healthcare providers review the clinical trial protocol with you before you enroll, and always be fully informed, and always ask lots of questions. And finally, please realize that signing a consent is not the same as signing a contract, okay? I hear a lot of patients say, well, my doctor said I can't get off the trial because of this or because of that or because, no. Participation on a clinical trial is entirely voluntary. You can leave that trial at any time and there should be no course of action taken against you, all right? If you believe you are receiving questionable treatment on a clinical trial, contact the Office of Human Research Protections. These are the addresses and phone numbers. In summary, the management of advanced prostate cancer is not simple and linear. Instead, it's a complex and multi-dimensional problem, but it's not insurmountable. At any rate, I hope this presentation will be helpful to those of you who are currently undergoing evaluation and treatment for advanced prostate cancer. Please take the following lists I've prepared for you and carry them with you at all times when you meet with your healthcare providers. And always ask your physicians about the items on these lists before you commit to your next form of treatment. So this is page 1 of the list, page 2 of the list, page 3 of the list. I threw in some of our previous lectures in case you want to look back on things. We might update this to include this current lecture. That's my email. That's office phone number. If you got questions, we'll try to help. This is my team, believe it or not. I have the best clinical team in the world. We're kind of horsing around a little bit here. case you can't tell. But I have an exceptional team. We call it the Kwan team at Mayo. These people are truly expert, and they care about your problems, and they care about your disease, and they'll do everything possible to help you. I also work with some of the most talented people in the field. Our PET group and our Radio-ligand group here is probably tops bar none. Dr. Johnson, now we have Oliver Sartor at our institution. Our minimal invasive group, Dr. Minders, Dr. Woodrum. Our surgeons, Dr. Carnes, Tollefson, Frank, Shaw, Dr. Kana. Our radiation oncologists are exceptional, Dr. Chu, Dr. Wilson, Phillips, Stish, Davis, Park. They're all the best. These guys are like Da Vinci with a paintbrush. They can paint the Mona Lisa. See, I know that the Mona Lisa was painted by Da Vinci. We have outstanding thoracic surgeon, Dr. Cassavy. So I'd like to thank you all for your attention to the video, and I hope this is useful. Bye-bye.
Dr. Eugene Kwan, you outdid yourself again. I gave you a score on that presentation of 9.9 repeating because I told you I didn't want to give you a perfect score because then that would make you too large for us, and then you would possibly never talk to me again. So out of survival, I think that was the best talk that you have given since I've known you for many reasons. One, because I think it's even more understandable than your other talks. And two, I think you just kind of walked through the different sequences and the different permutations really well. I've never seen anybody do it that well. So, okay, I have to admit it. That was awesome. How do you feel about it?
Well, you know my parents.
I do.
And so now that you didn't give me a perfect score, they're gonna just focus on, well, you didn't get the perfect score. You're inferior. You should have gotten a perfect score.
Right.
So I guess I feel crappy now.
No, I don't want you to feel bad.
You know what I'm talking about. You know, the parents.
I know the
they're always
parents.
like that.
I came from that strict parent background also, and my, if you got into Yale, it wasn't Harvard or something like that, and I understand. So I'm sorry. I did the same thing your parents might be doing, which is I've raised expectations, even though you probably deserve a perfect score. So I apologize. In terms of, since you and I have had that kind of background, a similar therapy, that was a 10. But to your parents, that was 9.9. And I'll admit to your parents, that was 9.9. All right.
Thank you.
Who's your best MD friend outside of the Mayo Clinic right now?
Well, that has to be you.
Yes. You're 1 for 1. What should the official mascot of the Mayo Clinic be?
Frosty the Snowman?
That sounds good. Or maybe it's Dr. Kwan. I don't know. Last but not least, I want to tell you what I did. I have never done this with you before. And maybe this was inspired by Alex and others who I don't agree in reading all the comments, but I just thought I'm going to read what people have to say about Kwan. And let me see if I got this number right. I counted hundreds out of the several hundred ratings. 99% of them were 5 stars. So that's not what struck me, that you've got the most 5 stars of anyone I've seen. I don't know how big your family is, but a lot of people from your family might have participated in that. Yeah. Here's a word that came up in a lot of the comments, and it really made me sad. Quanology. I coined that word. Where is my freaking royalty check?
That's funny.
Can you believe it? I'm serious. Quanology came up, like great quanology. I'm going, that was my word. That was my word. That is ridiculous. All right. So, all right. I just want you to know that. So it made me think of my new word, because today we're just going to talk about various treatments that you talked about. As a reminder, your talk was based on 3 different segments, and they flowed together quite nicely. There was the building blocks for your treatment plan, correct? That was part A. Yep. And how to assemble a treatment plan was part B. And then C was looking at your treating plan, the feeding of the treatment plan, So it really flowed together nicely. But I just want to talk about little ditties within all that. I got
Sure.
a new word. I got a new word for you. It's called Quanotherapy.
Yeah.
Do you
Thank
know,
you.
do you know, do you know why I'm giving you this word in all seriousness? I'm going to chuck this thing. Do you know why I'm giving you this word? Because I went back a little bit on our last Q&A, and you said chemo is the most underrated cancer treatment. And we were talking on the phone. You said looks better than ever. And so I just want to go back through that for a second. Can I?
Yeah.
Because first of all, my question is, I've been reading a lot in the journals and online about a chemotherapy shortage. Now,
Yeah.
is that apply to you? Is there really a chemotherapy shortage going on right now?
It's really horrible.
It's
It,
real?
it it's for real. I can't believe it. I've had patients come from far away, places like Alaska and stuff, and they say that they can't get systemic therapy. So then I get in contact with someone locally and I say, "Can you treat this guy?" And they say, "We're short on carbo." I think Mayo's even short on carbo. And it's kind of incomprehensible. I don't know how these things are happening, but I think that they're somehow all related to all the other shortages that are happening. It's kind of multifactorial, either not enough help, not enough resource, not enough sources, breakdown in shipping, communication, maybe businesses have gone out. Yeah, there are shortages. There's genuine shortages. We even had shortages for a while. I mean, the chemotherapy therapy shortages are one thing. We've had shortages of gadolinium for contrast for MRI. I mean, we were in the midst of the pandemic and toward the tail end. We can't get MRIs for patients because there's no gadolinium. It's just mind numbing. So I don't understand why it's happening, but it is happening.
So if I come to see you, is there going to be a shortage of some of the chemo drugs that you talked about?
I think that they tend to ebb and flow. I don't know where we are right now with the chemotherapy shortage for carboplatinum. I cannot honestly answer today, do we have it, don't we have it? But I do know that it's been problematic. Same with MRIs. We've got backlog of MRIs. And it's not only, as I mean, you must be aware of it. I don't think that there's anyone that's watching the video that's not aware of these things. Just workers. Where are the workers? There's shortages of workers, there's shortages of staff, there's shortages of shifts, there's shortages of all kinds of things. And I honestly don't understand a lot of it, and I don't know where it comes from. But, unfortunately, that's our current reality.
I don't know if a lot of people know there's a chemo shortage out there, but I'm sure the clinics give a heads up if they're not able to deliver it. Obviously, they don't just say surprise. So, but I think that's an important thing to know. But you said it was the most underrated cancer treatment. Do you want to comment on that further? Because chemotherapy gets a very bad rap in some circles in prostate cancer. It is attributed with all sorts of side effects. And what you said to me last time, I never forgot in the interview, is you said, look at the long list of side effects these other treatments give. And if you compare chemo to some of the other drugs that are given, actually the list of side effects are less.
I think that the side effect of dying quickly trumps everything. And unfortunately, I think that there's a tendency to, want to be nice to a patient, want to give them an agent that's easy to use, want to spare them some headaches, but then not tell them that that agent is going to leave them in the lurch down the road. A lot of patients that I run into, they are given some convenient treatments, or they're given some, I don't want to say easy treatments or bad treatments. They aren't provided with the option of doing chemotherapy. Chemotherapy, no one would do, none of the agents that we give in my clinic, no one's going to break into the Mayo Clinic and steal these things and sell them on the street, because these are not recreational treatments. They're all miserable treatments. But I'm not foisting an opinion about chemotherapy because it's a fun treatment to have. I'm foisting it because it is a very, very powerful tool in the toolbox of therapies against a disease that can be lethal very quickly. So what I try to do with my patients is I try to tell them very quickly, this is where your disease could go. These are the options for therapy. This is what these therapies can do. This is what these therapies can do. Of course, chemotherapy has side effects, but I think that sometimes the side effects are overplayed relative to the side effects of the other drugs. If you take my young patients and you say, what do you like more? What do you like least? They will complain almost uniformly about the hormone therapies. And a lot of them will even say, can't I just do the damn chemotherapy and avoid the hormone therapy? It's that miserable for them. So I think that the side effects of chemo, and I'm not trivializing any of this.
Yeah.
You know, I totally get it. I totally respect patients that write in and say, well, Kwan doesn't know what he's talking about. He's never had any of these things. How dare him say anything about this? I'm not trying to represent my point of view. I'm trying to parrot back what I get from the thousands of patients that I see in my clinic. And almost uniformly, patients are surprised at how well they tolerate chemotherapy. And a lot of times, a lot of them are shocked and they're very pleased with the response. On the other hand, there's not a single person that says, hey, can I sign up for another 5 years of hormone therapy because I'm enjoying getting tireder and more run down and blah, blah, blah. No one says that, especially knowing that hormone therapy is just suppressive. It's palliative. It's going to fail over time. So, that kind of is where I'm coming from.
It seems like when you give these talks, and unlike some other talks, I actually listen to all of your talks when you give them. So obviously I'm a fan, but I don't want to admit that privately to you because then you're going to get a huge ego, especially if I'm a fan of yours. But it seems as if you're always trying to say that not enough people are getting chemotherapy who could qualify in prostate cancer, unless I'm misinterpreting that.
I have a fear that, there are so many products coming out and there's so many treatments coming out, and chemotherapy is definitely cumbersome. I'm just afraid that a lot of patients are going to jump on all the easy blingy stuff, and a lot of them are going to end up in bad places with regards to their disease. If I saw something that clearly, this is like, okay, here I have the analogy.
Okay, I'm
This
ready
is
for
like
it.
raising your kids. So you're raising your kids, and the kid comes and says, I love the Twinkies. I love the ho-hos. I love the potato chips. I love this. I love that. I hate my spinach. And you say as a parent, okay, don't eat spinach. And then their teeth fall out. We haven't done them anything good. We have not done them a service. I think that, for better or for worse, chemotherapy is like Popeye's spinach. And I am skeptical. This is the kind of thing that you say that, after I say it and you record it here, you may want to look at it before you air it.
Okay.
But look at what's being used as the control group for every new agent that comes out.
Bingo.
Why aren't the trials being done in direct comparison to chemotherapy? Well, one of the reasons why is it works so damn well. Period. So people don't want to compare a new agent against chemotherapy because it may not shine as brightly. And I don't blame anyone for that. We need more agents. There's no question about it.
Yeah.
But to me, it underscores the fact that chemotherapy is probably a very powerful form of treatment that's hard to shine above in a head-to-head comparison.
So does chemo drop PSA?
Yes.
Does chemo improve quality of life?
Yes.
Can
It
chemo
can.
be can chemo
Yeah,
be combined?
absolutely.
Okay. Can chemo be combined with other treatments? It's not a standalone?
Absolutely. That's
Okay.
nowadays, I think, so the whole point of the talk that I just gave was prostate cancer is heterogeneous. It's not one cell, it's a bunch of cells. So you need a bunch of therapies. And you can't just use all one flavor of therapies. You got to use a spectrum to cover the spectrum or the heterogeneity of the cancer. And the
Right.
great thing about chemo nowadays, and the good thing about the field, I think, especially with triple therapies rising to the top, it's funny because when I first started my practice back in 2002, I started using things together. First, it was hormone therapy, then it was hormone and radiation, then it was hormone and chemo. We were giving Taxotere in 2007, okay? And then abiraterone was out there, but it was not approved. But we were giving abiraterone with chemotherapy, with hormone therapy back before 2010. And we were getting phone calls. Dr. Kwan, too aggressive. Dr. Kwan, too much. Dr. Kwan, there's no reason for this, not guidelines, not standard of care, not nothing. So now, this year, PCRI had a speaker earlier on, right? And that speaker spoke about triple therapy. Triple therapy has been rising to the top. The reason triple therapy was used by us back then, it was clearly apparent that just doing hormone therapy was not going anywhere. We had to do better than that.
Yeah.
So I think, and what's nice is now that triple therapy is becoming more and more embraced. I think by definition, people are going to think more and more about using combination therapies for treatment of prostate cancer. But as I mentioned in my talk earlier, which is a very important point, and you and I have talked about this a million times over, and every single patient that I see in my clinic says the exact same thing. Why is prostate cancer treated different than every other form of cancer out there? So, breast cancer, surgery, radiation, hormone therapy, chemo. Pediatric malignancies, chemotherapy, radiation, surgery. Every one of them is a combinatorial, multi agent, multi modality form of treatment. Why is prostate cancer just take these pills and give me a call when it fails down the road? Makes no sense. So I think that the good news is people are thinking more now about combination therapy.
So triple therapy, you said in your talk, was standard hormone therapy with a second generation and then chemo. So you're doing all three of those at once, right?
Right.
But the chemotherapy is not necessarily continuous. You're only doing so many hits of it,
Yep.
right?
So each time you get it by vein, it's
Right.
called a cycle.
Okay.
And we typically prescribe 6 cycles total, spaced at 3-week intervals. So you're done in 18 weeks. Yep.
So
with chemo.
you're receiving chemo. You're talking about receiving chemotherapy 6 times on 6
Yep.
visits, and then you're done with it.
Yep.
Unlike the other therapies.
Right.
So maybe everyone watching your combat manual and all your lectures needs to just bring up, am I a candidate for chemotherapy? That should be a standard question up front, right? Because you just answered a couple of questions. It reduces PSA, you said. It improves quality of life. It can be combined with other therapies. Is it generally covered by insurance?
Yep. Absolutely.
Okay,
Absolutely.
it's generally covered by insurance, so that makes 4 things on the Moyad checklist. Here's the 5th thing on the Moyad checklist that you and I like to talk about privately. Does it go after mutations? When there's a mutation that arises, and sometimes it go after that mutation also?
Yeah, absolutely. Chemotherapy is, I couldn't put it in my video. It just gets too deep into the subject matter. But chemotherapy binds to the DNA of these cancer cells. And then the minute the cancer cells try to multiply, it kills the cells. So it's a little bit of a generic way of going after cells that are dividing. And that's what gives it its effectiveness. But
Yeah.
the but the reality, the main reality is unlike some agents, it doesn't just hold them down, it actually kills the cells.
Hmm.
So the more cells you can kill up front, I think the better off you are in terms of treating these kinds of malignancies. Yep.
I mean, look what chemo did for testicular cancer, right? I mean, you're in urology. You can see what chemo did. I mean, these were game changers. But here,
So do you know? So I'm gonna quiz you a little bit. Oh, here we go. Yeah.
no, I want to take you through this list because now that you've made a number of people excited about chemotherapy if they qualify. You mentioned Taxotere and Jevtana, right?
Yeah.
And then there's one that Scholz talks about a lot too, but you never hear about it. This you mentioned it. Do you want to comment on these other ones that you said you use once in a while? Because when you look up the list of FDA approved products, I don't read the word carboplatin, but I know a bunch of oncologists are using it. So do you want to talk about these other chemos that possibly people might qualify for just briefly?
Yeah. So for the audience, I think that they have to understand I don't give chemo. So I directly don't give chemo. I have no conflict of interest. I have no invested interest in it. Where I got the language for chemo is from several of the medical oncologists that take care of my patients. And so Taxotere and cabazitaxel are known as taxane-based forms of chemotherapy, and they're frontline. They're the first types of chemo that are given for advanced prostate cancer. However, in this era of second generation hormone therapies, the ARPs, the ARPIs, these cancers are getting tougher, I think.
Yeah.
And what we found is that even Taxotere or cabazitaxel sometimes bounces off these cancers because these cancers are tougher, they're rougher. So a lot of the people that I work with, when they get in trouble, when they see that the cancer is rougher or tougher, they wheel out carboplatinum.
I see.
The other place that they wheel out carboplatinum is when you see elements of nasties in the cancer that are sprinkled in there. Little elements of neuroendocrine, little ductal elements, little bit of this, little bit of that, they say, or Gleason 10. You know, a guy that has Gleason 10 prostate cancer that's poorly differentiated, not making a lot of PSA. And I've actually heard, and you know, this is why my life is so weird. I'm not a medical oncologist. I'm a urologist, right?
Right.
But the funny thing is that when you talk to these medical oncologists, a lot of them say, well, I don't know why we just don't start with Taxotere plus carboplatinum. A lot of them will say it's a better combination than just taxanes alone. And I agree with that. I mean, I think that, again, this goes back to the Twinkies and the ho-hos. So, you know, there's this hierarchy of, we'll take the pills, they're nicer, but if we have to, we'll give you docetaxel. But if the docetaxel doesn't work, we'll maybe make it spicier. But here's the fundamental problem. If you don't kill the cancer up front, nothing
Yeah.
gets easier. Nothing. So if you've had 6 cycles of docetaxel-based chemotherapy and nothing good is happening, and then to come back and say, oh, well, now we have to give you Taxotere and carboplatinum, a lot of the patients are wiped out by then. You know,
Mm.
it's just too much. So carboplatinum is weird to me as a urologist that's in this field because I don't know why it doesn't have a lot more discussion other than the fact that it's an agent that's been around a long time. And for some reason, us being in the US market where we like to drive a new car every year, for some reason, we don't like talking about older drugs, you know?
Yeah. Yeah. Or we can't find funding for it. I mean, it's really it's tough. You gotta find someone who's willing to find funding for something where there's not much funding, correct? And then you got to get somebody else excited.
There's no funding. There's no funding.
No
No
funding.
one, once you get a drug approved, there's no reason, unless you're going to widen the market on that drug, there's no reason to do further studies. There's only a downside, right?
Yeah. Okay. So here's what you said. I wrote it down with a pen. You said chemotherapy is cake compared to hormone therapy. That's what you said. I thought that was a good quotation. But you said,
Well, I want.
no, I know what you're going to say. You're going to
I
say it's
don't.
not cake, but I think the audience who knows, I mean, you're just trying to provide a comparative. But before I leave chemo and all these chemo options, because you also brought up etoposide, or etoposide, VP16. You brought up all these other ones that people can write down and talk about with their doctor. But I mean, okay, you sold me, except there's the 6th point in the Moyad checklist. Chemotherapy is arguably natural because it originally came like Taxol from the Pacific yew tree. So I think that's fascinating that we found chemotherapy from trees, and then we just isolated these compounds and used them. So maybe that should be another point. But how early do you recommend it? In other words, people know to use it later, but do you use it, or do your oncologists use it really early in the game if they come see you and have advanced disease?
It's not just a panacea, and you do have to consider a number of things. So you're dragging me out into deep waters here, and I know that you're going to fire a torpedo into my stern.
No.
So the central, the eye of the storm is the concept of large volume or small volume disease.
Okay.
So if you look at Stampede, if you look at Charted, they make a distinction between large volume and small volume. And to be honest with you, I mean, I can drag up what the definitions are, but they don't make a lot of sense to me. And not only that, but the people that I talk to that have discussed this have pointed out that on the Charted trials and on the Stampede trials, these trials were loaded with advanced prostate cancer patients with minor subsets of low volume disease on them. And the statistical comparisons of the low volume disease categories did not show dramatic advantages to getting chemo. But saying that something is not statistically significant for a group that's underpowered on a big study is not to say that it doesn't work. And in my mind, it makes no sense, because are we saying that chemotherapy works unless you just don't have quite enough disease? Oh, it doesn't work anymore. Makes no sense whatsoever. The other thing is that we have a lot of caveats when we give chemotherapy. Number one caveat is, where are you going with your treatment? So a lot of people that are discussing chemotherapy are thinking one thing and one thing only: I'm going to give chemo. They're not thinking about combinations, and they're not thinking about knocking out the disease. In our clinic, everything that we do is, can we whittle it down? Can we get it all into nice little manageable little things at the end? And then can we knock it out with directed forms of therapy? So a prime example is a guy that comes in and he's 42 years old. This happens to us all the time. A guy will come in, he's 42 years old. He's got Gleason 10, stuff that you can hardly even imagine, boring into his bladder, boring into his rectum, boring into lymph nodes down there. And I say, well, we better start with some chemotherapy here. And the person comes back and says, well, my doctor doesn't want to give it to me because it's not standard of care and it's low volume disease. It's like, what are they going to do for you? Well, they gave me enzalutamide and hormone therapy. That's a death sentence. If you give someone Gleason 10 prostate cancer that's invading his prostate, invading his rectum at age 40, and all you're doing is giving him hormone therapy, that's not going to work. So with those patients, we tend to say, well, we know hormone therapy is not going to work for. These are the patients that become the PSA 0 patients, the patients that, grow a ton of metastatic disease because they have no measurable PSA.
Yeah.
And they're told, you're fine on the hormone therapy. No, they aren't. They're growing disease all over the place. So we have caveats. We're looking at people where the upside is much bigger than the downside. Young patients, really bad disease, that we know that we're going to have to fight fire with fire. And even in that situation, we're very clear we're in a dogfight. You know, this is a life and death situation. So, you know, I do use chemotherapy in patients that I think warrant very aggressive treatment, especially because, you know, it's a different story if someone comes and says, well, Kwan, you're all wet. That's a dumb idea. I have this idea. And it's like, whoa, that's a better idea. But the part where we always push back is don't come back and tell us, well, what we're recommending isn't right. The only thing you're going to give is hormone therapy because we
Yeah.
know where that goes. I've gotten in these arguments over the phone, and the doctor will say something like, well, yeah, but you know, chemotherapy isn't indicated in that situation. I said, what are you going to do? They said, well, we're going to do standard of care, hormone therapy. And I said, well, where's that going to take you? And they
Yeah.
said, well, the patient's going to progress and he's going to die. And that's just the fact of the matter. And,
Yeah.
you know, that's when I generally say, well, I think that we want to be a little more aggressive.
Yeah, so let me just go back a second so you can clarify it for the audience, because I know the trials, you know, we know these trials like Charted and Stampede. So these are supposed to be definitive trials that tell clinicians how to treat patients. And so you talked about low volume and high volume. What those standard trials are telling you is to do what with chemo in terms of volume, and then your message is, well, maybe there's some exceptions to that rule. Will you just explain what people are being told versus what sometimes you might change the protocol?
And I don't know the exact definitions as of
That's
now,
okay.
what constitutes large volume disease, but basically these were trials with multiple arms where they're looking at what groups of patients got what kind of treatment and which ones did better than other groups. And what they found, according to Charted and Stampede, that's what gave us chemohormonal therapy is, and mind you, we were already doing chemohormonal therapy when they ran the trials. The trials basically were testing whether chemotherapy plus hormone therapy was better than hormone therapy alone. So I had already made that decision back before 2010. Hormone therapy doesn't do anything. Anything is better than hormone therapy alone. Anyway, they did the trial. The trial, lo and behold, said, oh, chemotherapy plus hormone therapy works better than hormone therapy alone. But then they carved out this little group that they said, however, when the volume of the disease is kind of small, chemotherapy plus hormone therapy doesn't seem to provide an advantage. And the definition of the disease being too small was some arbitrary thing, one
Yeah.
spot versus three spots
Yeah.
up here versus down here. And I think it's because of a statistical anomaly on how many patients were in that group. But here are the major points. These trials were not done in the era of PET imaging, and they were not done with all the other caveats that we're talking about. Can you irradiate the disease at the end? Can you knock out whatever's left behind? So that's, but that's the gist of the whole discussion between large volume and small volume.
No, that helps me. That helps a lot. So that I, I just don't think there are enough videos on chemotherapy, and I don't think there are enough videos on chemotherapy and prostate cancer, but you always talk about it in such a positive way. I want to leave standard treatment for a second, so I don't want to forget this because you finished off your talk with this, and I agree with how you finished it, but I just want to clarify something. I just want to talk about clinical trials.
Mm-hmm.
Because you're in an institution that does a lot of clinical trials. And I look at, for someone to jump into a clinical trials, not knowing the pros and cons, not knowing their rights, that is a tragedy. And for someone to have a wonderful, acceptable option available to them and still jump into a trial where we're not sure what happens, that is, like, you brought up all these points. But I guess the question I would bring up with you then to play devil's advocate is, do you get excited about some clinical trials? I mean, who do you steer toward a clinical trial then? I know there are concerns about some, but there are some you get excited about. do you have a sort of an overview about when a patient might get excited about a clinical trial or no?
I, you know, patients are patients, and it's not getting excited or not getting excited about clinical trials. It's what you tell them. So I think that patients have to know what are their options.
Yeah.
I have tons and tons of patients. I'm sure they're a large audience of PCRI. They want to participate in clinical trial. That's fine. They have, and they should have a right to participate in a clinical trial. Some of them have even read all the papers from the first observation all the way to the translation of the drug off the bench into the clinical arena. That's all fine. The point that I was making is I don't think that the reason a patient should go on a clinical trial is because they think that they've run out of good therapeutic options
Yeah.
and they don't know of anything else. I think that's bad. I have plenty of patients that if I sit down and I say, well, you got chemotherapy, you got this drug, you got this drug, you got this drug, and there's this new agent. I have patients that will say, I want to try the new agent. That's fine, as long as they know about the other ones.
Yeah.
Where I disagree is I get lots of patients. They say, my doctor never brought up chemo at all. You would
Yeah.
not believe how many end stage disease I get, how many patients. So a lot of people don't know this about my clinic. My clinic actually started with most of its patients coming out of hospice. Patients would call me up. They say, Dr. Kwan, I'm in hospice. I have no options. I'm laying in hospice. I was wondering if you can help me. And I said, if you can get here, I can see what I can do. I still have some of those patients from hospice 15 years ago that are now doing great. Several are not even on therapy anymore. Patients in hospice that have not even been shown the option of chemotherapy or hormone, whatever. So I think that the point that I was trying to make is, and that's the whole point of this whole talk. I'm not cheering for chemo. I'm not cheering for RP. I'm not cheering for this. I'm cheering for a patient to have a full list of options in front of them so that they can ask about the pros and cons of all those things. And a
Yeah.
lot of patients will choose things that I don't like, but at least they made the decision, and it wasn't a decision that was just made because no one told them. You know what I mean?
I absolutely know what you mean. That's why I thought the most powerful slide, well, you had a couple powerful. The only one I took a picture of was the direct treatments of 2023. And because it kind of alphabetized everything in one slide so that people could start making their own checklist. That was one of the powerful slides to me, because it shows you that unlike 20 years ago, there's more of an, as opposed to it being a barren sea, there's more of an ocean of opportunity. And I think that slide in and of itself is powerful. But the reason I brought up clinical trials is because I know privately that you helped get a lot of people into a trial that eventually became the regular part of treatment. I apologize. That's my dog barking in the background. For some reason, every time you give a talk, my dog barks when you're a part of my lectures.
Your dog loves me.
Your
I'm
dog,
very, very popular with dogs. Dogs are my demographic.
March 24th, 2022, we were talking and I went, yay, Pluvicto got approved. And so do you want to talk about, because you put a lot of people in the trial, and the trial was successful. And so in terms of who you're giving this now, this radio-ligand to, are you giving it to people who haven't had chemo? They've had chemo? I mean, I know there are certain parameters involved. I mean, how do I even contemplate that I qualify for the latest, greatest treatment for prostate cancer if I have advanced disease?
So, answering the first question of, kind of how do I feel about putting patients on that particular trial? So, that trial really speaks to a very interesting thing. I felt good about putting patients on that trial because that trial was being conducted on patients that had received taxane-based chemotherapy.
They had received chemo.
They'd received hormone,
Safe hormone.
and they received RP. So when you talk about those three things, the eligibility for enrolling on Vision trial was you had to strike out in these other areas, and then this is available. The other reason I liked it was because not only did I think it addressed an unmet need, but also the mechanism of action. That's why I talked about mechanism of action. It's not suppressive, it is cytotoxic. So to me, it was like saying, well, this is a nicer form of chemotherapy that uses a different route to get to the cells and kill them. And there was already documented evidence, very, very good documented evidence, that this stuff was effective in patients with nasty cancers. And we actually had some experience sending patients to Germany and overseas for treatment with lutetium overseas. So that's what gave me comfort in enrolling patients onto that trial. I didn't feel bad about putting patients on that trial. Now that it's approved, there's no question that it meets a need. There's no
Yeah.
question, because a lot of patients are, what are your options? So you could see when I gave the presentation today, after failing three things, you can retreat with chemo, you can play with RP agents, you can, check the genetics, blah, blah, blah. But that's a big, powerful drug in that position. Okay.
Yeah.
So I think that it really meets a need.
I think that supports, again, your foundational talk, which is you've gone through a large litany, a list of things. Okay, now what else is there? And there are a number of people that still respond. In your personal experience with this, I'm not trying to get you down to specific numbers. You're seeing responses, and I mean, are these? Do you see the PSA drop with this, for example? I mean, what are you seeing with this product?
We've treated about 300 patients to date,
Wow.
since that rolled out in March.
Okay.
And we have not analyzed the data systematically. We just got done doing a deep dive into all the responses and everyone. So we've got complete data on 300 patients, first 300 that we treated here. And I can't quote you the numbers, but I can give you generalities. There are definitely patients that have miraculous responses, and there are definitely big disappointments for patients. We don't know why necessarily for each of the populations. Some of these guys will have very attractive disease to treat with Pluvicto, but for some reason it doesn't work. Other patients, you sit there and I say, this ain't going to work. It's just not going to work. And it works miraculously. The older I get, the more that I can comfortably say that the more confident I am about anything, usually is the time when I'm the most wrong. Okay? You cannot predict anything. And I've really become more of you just have to try some of these things to see if it's going to work.
Yeah.
I don't think any doctor on this planet right now, I don't care what anyone says, I don't think that there's going to be a bioassay. I don't think there's going to be a predictor. I don't think there's going to be anything. You have to try. And the big thing with my patients is I make them try things because you don't know what's going to stick. You just don't know. For a while there, we thought, oh, there's a trend developing. This guy's not going to do well. This guy's going to do well. And then the next 5 guys, they all do well, So it is, if you're asking, is it here to stay? Absolutely. If you're asking, can it be improved upon? Absolutely. And they're already coming up with the improvements. That's a beta emitter, the alpha emitters, 225 actinium, all these other things are coming online. 225 actinium. So
here's the reason I bring this up is because we heard about people going to Germany and other places, and they would get Pluvicto, but then if they stopped responding, the idea was then they would get actinium, and So where are we with that? Is there a trial? Are we going to get some trials here? Or is this going to become exciting in the future?
There's
It'd be nice to
actinium
have a
trials.
backup. Pardon?
So the trials that are going on is, number one, they want to move lutetium further forward.
That's
So
right.
they want to make it
Earlier.
they want to make it a frontline therapy. So that's the PSMA addition trial. And
Yeah.
then the PSMA 4 trial is after you've failed RP therapy, ARPI. Actinium trials are springing up all over the place. So
Yeah.
actinium is definitely coming. Actinium is a more powerful radiation agent that binds in the same way, and it can target the cells, but it can deliver more intense radiation to the cells. And I've had patients that failed or did not respond very well to lutetium that have gone for actinium, and they've done very well. But I've also had patients that have gone for actinium and nothing happens. So once again, it's a kind of we'll see how it works type of thing.
Yeah, but you're excited about it.
Oh, absolutely.
Good. Here's the thing that's the con. I always like to tell people when I interview that I like to play the con and pro game. I don't say pro and con. I like to start with the negative first, then end with the positive.
I'm from Chicago. I'm used to cons.
This is a side effect. It's with Pluvicto, and they're also seeing it with these other radioligands like actinium, where you get bad dry mouth, and because the salivary glands basically stop producing saliva or not able to produce saliva. Are you seeing? Is this manageable with Pluvicto? What are you seeing out there?
Yeah. So some of the patients are impacted. Some of the patients are not. Some of the patients that are impacted say it's horrible, horrible. Their teeth decay more rapidly because of the lack of moisture. Probably
Yeah.
get different flora, stuff like that. Sometimes it ruins their single pleasure, which is eating. Sometimes
Yeah.
it makes eating almost impossible. I don't know where people are going with the management of xerostomia. I don't know what's being thought of. I mean, early on, we had a lot of ideas, maybe how to block that.
Yeah.
Maybe we can give ligand by direct arterial injection to block the salivary glands prior to giving
Yeah.
Pluvicto. The problem with that, of course, is it's hard to block this area without blocking a. And unfortunately, I mean, I just had a patient recently, 2 patients that their metastases are in their salivary gland. So what do you do for those patients? If you block those areas, then the Pluvicto is not going to get there.
Yeah.
So I don't know where it's going, but I certainly, and again, backing up to chemotherapy, I don't want anyone out there to think that Kwan's just a kamikaze that wants to give chemo or this or that. All of these treatments have side effects. All of these treatments can make your life better or miserable. All of them. There's no such thing as something without a downside. I'm not trying to be disrespectful of that. I'm just saying that, for a lot of our patients, when they have to face either side effects versus the prospects of dying relatively quickly, a lot of them choose the side effects. But some of these side effects are pure hell. And some of them really do make patients feel miserable. And to whatever extent we can, we will investigate ways of trying to mitigate against. So chemo, for instance, this is a fascinating story. I'm glad that we have this opportunity. I'm actually surprised at how much variability there is in giving chemo. So some of my guys that give chemo and some of the best guys in the world for giving chemo, they will force their patients to do ice water immersion of their hands and feet while they receive chemo. And they will have their patients, if they're public figures or people like me who are vain, hang on to their hair with a freezing cap. I am shocked at how many of my patients will get chemo and they'll say, I've got no neuropathy. I've got no side effects. I still have my hair. Actually, some of the patients actually have more hair than I do, even while they're getting chemo. So what that means is that, there are maneuvers that can be pursued to mitigate against some of these side effects. But it's a matter of going to the right doctor, sitting down, going through these details to make sure that attention is being given to all of these things. In terms of xerostomia, I don't really think that there is something that mitigates against xerostomia. We've tried ice packs, we've tried a number of things. I don't think it works that great. We don't have something right now.
Oh, it's good to say. I'm still wondering where the trial is of acupuncture for xerostomia, since that was used in head and neck cancer patients that had xerostomia. But that's just me, again, finding money for these studies. I don't know, but okay. Here's a word that you and I have never talked about. Are you ready for it?
I think so.
Why don't you ever get excited about me? Usually excited on the phone I'm talking to you, but when we're on video, you don't seem as excited. That's okay. I'm going to change your level of excitement. But I know you have an opinion on this, so I want to get your opinion. And I do think you should add this as a part of the discussion somewhere in your manual as a separate lecture, because it's not going away in other cancers like ovarian and renal cell carcinoma. And that's debulking. The idea of cytoreduction. The idea is if you have a lot of tumor, you can even explain it better than I can, but if you have a lot of tumor in your prostate and you have metastatic disease, the tumor in your prostate is sort of the main ship, right? And you go after that main ship because they could send out satellites, and you not only go after the metastatic spots, you go after any living, breathing cancer within the prostate itself. It's sometimes called debulking. You take out that primary or you radiate it, or sometimes it's called cytoreductive therapy, where you're drilling those cells and trying to kill the cells where they initially started. What say you about this debulking cytoreduction theory in prostate cancer that's used in other cancers?
So I do have kind of in my mind a scientific argument for why I think debulking works in certain situations. So I showed a lot of little kind of tumors that had a bunch of marbles there, the genetic heterogeneity, the genetic instability. So the way I see debulking as possibly imparting an advantage to a patient, if you have a chunk of tumor that has 50 million cells in it, and every one of those cells is genetically unstable, then the likelihood of hatching a fatal resistant mutation is pretty high up there, as opposed to if you have only 5 cells. So if you have a big chunk of tumor and it's got gazillions of cells and they're all genetically unstable and it's like Russian roulette, every one of those can hit a fatal mutation and create an Andromeda strain, then there may be benefit to yanking the tumor out, because you're going to lower the incubator for mutations. So I think that debulking may work, especially when you have relatively small degrees of metastatic disease. It's not going to work simply when you're packed with mets and you decide on some Sunday that you want to rip out someone's prostate. That makes no sense. But at the beginning, if you have a patient, like one of our patients, big nasty tumor in the pelvis, couple lymph nodes outside, probable mets elsewhere that you can't see, you remove the big tumor, you treat with hormone therapy, chemotherapy, everything else, the likelihood of that patient moving on to hatch some horrific mutation down the road may be less than a guy where you just left the big tumor in. Does that make sense?
It absolutely makes sense.
Yeah.
And what, to me, the reason it makes sense to me, and it's always made sense in the context that you describe, is when the battlefield and the number of soldiers is smaller, that's a better chance to wipe out and win the war in the battle. The idea that, because I don't like it also when some clinicians don't give cancer deference, if that sounds strange. Cancer is very intimidating. And as it starts to mutate and cause resistance, the idea that just doing something really petty or tiny and there's all this metastatic disease is going to cure it just in that one little attempt, I think that's being too optimistic. So where your battlefield is smaller, I would think you'd want to optimize that versus where your battlefield is large. You're asking way too much of debulking therapy. So I've never heard your theory on it, but I agree with that. And let me tell you where this has relevance, Eugene, or as other people would call you, Dr. Kwan. But since we're best friends, I call you Huge, and you call me MM. I don't know, or you call me something.
Sir. I call you sir.
I think this is an important point when it comes to the discussion, which I get all the time, that when it comes to over-the-counter medicines or supplements or certain diets or repurposed drugs like metformin and these other ones I get excited about, like cholesterol-lowering drugs. When they use these agents at the very later stages of the disease, they tend to fail because they're asking too much of a large population of heterogeneous cancers. When they use them earlier, they have more interest or more of a signal. So this is what made me half wacky. In the old days, they would try something alternative, whether it was an herbal or something else. They would use it after someone's failed every therapy, and then they would go, it doesn't work. I'm going, nothing works in that situation. The only way you're going to have sort of a bullet work that early in the game is when the number of soldiers are small. So I love your answer on debulking, not just because you and I are BFFs, but because I wish we would look at a lot of these over-the-counters and these minimally invasive treatments. I wish we'd look at them earlier as opposed to expecting so much of them later. I'll get off my soapbox now.
I think that, one of the disappointments is I think that people are thinking less and less about kind of the mechanism and the pathophysiology of things, and people are more and more just thinking of procedure or treatment. Unfortunately, no one's really sitting down. To me, there's, what I tried to lay out today is that there's a logic to going after cancer. Even the treatments that you provide, you should pursue some form of logic. You have to know how they work and what they're trying to accomplish. I always tell my patients, look, I understand that chemo is not fun. I understand these. None of these treatments are perfect, just like the PET scanning. There's no single PET scanner that can see everything. There's still a role for choline. There's still a role for PSMA, FDG, oxumin, whatever. There is no single perfect anything that will cover everything.
Right.
What you want to do is you want to take all of these imperfect therapeutics and all of these imperfect diagnostics, and you want to use them in a wise fashion so they overlap and are more comprehensive to treat. The surgical debulking thing, I mean, we're thinking about answering that because it turns out that now my group is one of the top groups on the genetics of solid cancer in the world. We've done so much sequential tracking of prostate cancer that we have more information on the genetics of a solid cancer than any other form of solid cancer in the world. And I think that there's ways of answering it. You can look at tumor mutation burden in someone who's been resected versus tumor mutation burden in someone who has not, i.e., prostatectomy versus radiation therapy failures, those two groups. So there's ways that we can sneak up on them. And, those are things that we need to look at.
In part B, you said how to assemble a treatment plan. One of the words you use is being aggressive up front when you need to. I think that summarizes the debulking discussion. It also summarizes the other reason why I thought your part B was very good is because the idea is, hey, we've got this thing. We might be able to get this thing on the run if we treat this thing early enough and aggressive enough, if that's what you need. So sorry, I don't need to repeat your talk, but
well, there's one more part of that. So, there's a myth. The myth is if you're nice to a person up front, you've done them a favor. And that's just simply not true.
Yeah.
If you treat a patient with a very soft form of therapy up front and the cancer comes roaring back, that person's at a huge disadvantage down the road. Usually the best chance of being aggressive is right up front because they're not beaten up by the therapies, they're not diminished by the therapies. That's the best time. That's when they can tolerate the treatments. So that's why we tend to be aggressive up front.
So then before I go into my last several questions, it makes me skip over the questions I was going to ask you and come back to it. Because I believe, I don't know, again, you and I haven't talked about this. I think there's a tale of two cities going on, but you need to explain it. You have to be aggressive up front. That's very true. That makes sense because you deal with a lot of patients that have very aggressive disease. But then there's the other thing you've talked about through the years where you want to be a little polite, and that's with oligometastatic disease, where you go, this person doesn't have a million sites, they have a small number of sites. And so can you tell me how that philosophy goes with oligometastatic disease, where you just have a couple of spots and you don't want to do too much, but you don't want to do too little. And then people are able to go in remission by just zapping it with a little bit of radiation to a spot here and there. How do you work that out in your mind with oligometastatic disease?
Yeah, that's a great question. So with oligometastatic disease, I think that we're refining our thinking more and more every day. So in the beginning, the original definitions were, 5 or less metastases. I think 5 is too much. When I think oligometastatic anymore, I'm basically looking for solitary metastases or maybe 2 metastases. Once you get into 3 or spots that are diverse,
Yeah.
spread across the body, I'm like, this is systemic. So the reason that I think it's worthwhile to go after a solitary metastasis, especially if it looks logical, a good PSA number that correlates with the spot, it's super bright, it's discrete, it's not a smudge. The reason you go after that is because probably about 40% of the time you're going to get a really clean, durable response where the patient doesn't have to move on to anything else. And that's
Yeah.
bonus. That's bonus territory for any patient. So it's a high yield. And some of those patients, as I pointed out, I mean, some of our first those stereotactic cases that I pointed out in the video today, 11 years out, they have hormone resistant disease. We shot those spots at a time where the dogma said that those patients have castrate resistant metastatic prostate cancer and their median survival was 9 months, 9 to 13 months. We shot those spots and they got no other therapy. They're cured or they're doing well. So I tend to use targeted therapies for oligometastatic disease, especially when there's small volume disease, and especially when the compliance of the patients could be high for follow-up, where we can watch very carefully, did we get it or didn't we get it? If we didn't get it, then we're going to pivot to something more aggressive. But the upside is if you get, if you hit the ball out of the park, patients happy and they have good quality of life.
Yeah.
But we're not, I don't, I thought that this was, or the other area that we do use some targeted therapies are usually in combination with some more aggressive treatment, not just hitting the oligometastases and expecting everything to go away, but maybe in order to facilitate a better response to systemic therapy. But that's
Yeah.
a different story.
The question I get, and I still haven't been able to answer, and I get it from a lot of doctors who have prostate cancer, who have oligometastatic disease. You're more excited about a solitary tumor site that you can zap versus 5 or 6 spots and expecting a zap here and there to do the trick. The question I get is, okay, I have a solitary spot. I had it zapped. I had a great response. Now it's back somewhere near that spot. Do I now become more aggressive, not just hitting it with radiation, but also possibly adding some type of systemic therapy to it or chemo for a short period of time? In other words, when someone fails an initial solitary lesion attempt, which this is the number one question I've been receiving lately, and they still have a solitary lesion that was nearby, do you now step up your game and go, okay, we're not just going to hit it with radiation again, or do you tend to want to add other things in there and I know these are hard to answer generally, but what goes on in Kwanology? What goes on in the Quanosphere? Oh my gosh, I just patented another name, the Quanosphere. I get, again, royalties. They got to come to Moyad. So in the Quanosphere, how do they look at a recurrence? And then do you go after it a little bit more aggressively on oligometastatic disease?
When we hit a spot, let's say that you're on a rib. Rib's
Yeah.
kind of a long, skinny bone. You hit a spot and the guy comes back and he says, I got recurrence. You get the PET scan and you hit the spot, but it's out on the edges. So an edge recurrence is something that may be worth going after with a repeat treatment. Okay. That might be just that, the thing that you treated was linear and long and you just missed a couple of tips. So
Exactly.
that's okay. I would go after that with repeat radiation, and our radiation oncologists would probably put a wider margin when they treat the next time around. If it's in the same spot, then the question is, did it get the full brunt of the treatment? How many centigrade were delivered? Was it a palliative dose? Because a lot of insurance companies will only let you give palliative dose of radiation therapy before moving on to a therapeutic dose down the road. So palliative dose is whatever, 500 centigrade or whatever. So if we have a recurrence in the field that was shot, which only the radiation guy would know, you can't figure that out just by talking on, well, you can probably figure it out by talking on the phone. I would actually have to ask the radiation guy. If they look at it and they say it's in the field, then the next question is, can it take more radiation? If it cannot take more radiation, then usually those patients will then go to our cryo guys or our thermal ablation guys for either cryo or thermal ablation. If it comes back after that, then it's a problem. And, resection of a rib, I've seen a couple guys get ribs resected. The place that, is really tough is the sacrum. I've seen the sacrum be really tough. It's got a lot of interstices, a lot of cracks and crevices, pretty hard bone to treat. But, sometimes we use cryo, thermal, radiation, whatever. And then if that doesn't work, then you're stuck with systemic, you're stuck with, but systemics, the one systemic that really I think is maybe increasingly exciting. No one listens to me, but it's kind of one of those things. I think that the radio-ligand therapies are going to have a real role for in-field failures. That is failure inside previously irradiated area. Because you can get in there with a good dose of radiation without having to re-irradiate the whole field, So those are things,
I love it. We've never talked that much about oligometastatic disease and how to handle it, because you got to admit there's always exceptions to every rule. And the exception there with oligometastatic is maybe we need to be a little bit more polite, as opposed to a lot of other types of prostate cancer. You can't be so polite. And that makes a lot of sense to me. Edge recurrence. I'd never heard that term. Isn't that funny? Edge recurrence.
I just made it up.
Did you really?
I just made it. Yeah, I don't.
That's how a lot of radiation oncologists will talk to you. They'll say that there was along the edges of the periphery, the radiation didn't hit the entire tumor, and it extended out. Like people say, well, how did it extend? You ever spill water on the ground and it kind of has a finger effect, or you spill paint? I spill paint all the time and water. And so it goes out as a finger effect. So you can get most of it, but there's a tip there that you might have missed. That's really cool the way you look at that. All right. We've already gone over an hour and I've already completely blown apart my questions. I have a couple more specifics and then I'm going to do general philosophical questions to end the day.
Okay.
When I met you and you and I became besties, and I know you worshiped me from afar for a long time, and it was clear that you wanted me to be at Mayo with you and having time. You were talking about, you just love talking about immunotherapy. You would talk about it. You were excited about it. You ran one of the biggest trials in prostate cancer and immunotherapy. Can you repeat now? So we have Provenge out there, and we have what you described as, and this came out on March 20th, 2023, March 29th, FDA grants full approval to Keytruda for select patients with MSI high or dMMR solid tumors. Anyway, the point is, can you just give us the chronology again on where you are with immunotherapy? Because you used to be so excited. And I'll tell you, people get really excited about it. They don't understand all the pros and cons, but I just have to look at a course. I'm not going to sign up for it, but it was a course for other people working on oncology that said the use of chemotherapy in earlier stage cancers. And of course, it didn't list prostate. It listed other cancers. So there's a lot there, but where are you with immunotherapy in general? Then I have one question as far as the trial is concerned with immunotherapy.
For people that don't know, I started my career in the field of immunotherapy, and I worked with a guy named Jim Allison. And Jim Allison rightfully won the Nobel Prize for all the work he did with checkpoint inhibitors. Until Jim Allison did his work, there was no real super substantial evidence that immunotherapy was going to work for prostate cancer or any other malignancy. When Jim Allison did his work, it was the first time ever in the history of cancer that people were not only having longer progression-free survival and overall survival from things like melanoma and other forms of cancer, but some of those patients were getting complete response to immunotherapy. That was the first time in history. And for that reason and many other reasons, Jim Allison was given Nobel Prize. I was working on checkpoint inhibitors with Dr. Allison at that time, and the goal was to use it for prostate cancer. And we were very, very hot and heavy on the idea of using it for prostate cancer for a number of reasons. So we did our trials. The first trial we did, which interestingly got very close to approval for a checkpoint inhibitor, was BMS 043, which was immunotherapy after hormone therapy failed and after chemotherapy failed. So I sat around the table with all of the experts. Not Jim Allison wasn't at this meeting, but all the prostate cancer experts. And after we missed approval by 0.0032 or whatever, everyone at the table said, well, it's obvious why we didn't get approval. We didn't get approval because we used the immunotherapy too late. Let's use it earlier. So the next trial that just sprung up out of the blue, and we didn't decide this, whoever was in charge of the trials decided this, was BMS 095, which is a trial to use it right when cancer is becoming hormone refractory, but before chemo. And the argument was that patients that get chemo are too beat up and their immune systems are bad, and that's why we have to use it earlier. And we reran the trial, and we did terrible. We did 10 times worse. Yeah. So you're sitting there and you go, well, the patient's in better shape, the cancer is in better shape, everything's in better shape, and we did worse. So everyone abandoned doing trials using checkpoint inhibitors for advanced prostate cancer. So speed forward. Now we're 2023. Those studies were done 10 years ago. And I'm sitting around and I'm repeating genetic studies for our patients now. And one of the things that captured my attention while we've been repeating the serial genetic testing was a lot of these patients come trundling into the office and they have a tumor mutation burden of 2 or 4 mutations per megabase DNA. But then you treat them, you take care of them for 10 years, you give them chemo, you give them radiation, you give them hormone, RPIs, all this stuff. And over time, that tumor mutation burden trickles up. Yeah. So one of the first questions I asked the Guardant company was, what's the baseline level of mutation for a melanoma? How about for bladder cancer? How about for lung cancer? As it turns out, if you make the assumption that everyone's using Guardant tests on all these different malignancies, and all these malignancies are being tested because patients have stage 4 cancer, For the guys that have melanoma, for the guys that have bladder cancer, for the guys that have these other things, their stage 4 first test has a much higher level of tumor mutation. And the two lowest cancers, the two lowest are breast and prostate. So breast and prostate have very low levels of tumor mutation burden in the beginning. So what that means is that these two forms of cancers, for whatever reason, don't mutate as fast as melanoma or the other ones. So you have to be patient. You have to wait, but you have to also check. You can't use a genetic test that you did 10 years ago. You got to
Yeah.
keep watching. And we watch the tumor mutation burden of prostate cancer go up and up and up on some of our patients. And at that point, we spring into action. We say, now's the right time to give immunotherapy. So I failed at it 10 years ago, and I think everyone somehow blamed me for the poor immunogenicity of prostate cancer. And now 10 years later, I think I understand. It's a disease that acquires mutations very slowly, and it's not as insightful to the patient host immune system until later on. But then some of them do get to that point and it becomes a great target for immunotherapy. The only other thing that I want to say is if it ain't on that list, I don't consider it to be immunotherapy.
If it ain't on that list, if
The
it ain't,
systemic,
oh, I see. You don't consider it to be immunotherapy. But you put in your talk, you threw out a number, I think it was 12. They were looking at mutations.
Yeah.
So I'm assuming now that's a magic number that you picked, that when you give immunotherapy like
I think it was, I think it's been published that, I don't know if it was because of the FDA guidelines or what was approved or whatever, but
Yeah.
I think that people have been publishing kind of the thresholds
Yes.
for tumor mutation burden.
Yeah.
And I don't know if that's based on response rates or if it's based on FDA indications for treatment. But the bottom line is that we use a number around 12.
Yeah. Yeah, it was in the, it's always that needle seems to be moving in that double digits, 10, 11, 12 and higher. And now are you, okay, so this is all that we've learned, and that's a lot. So now, are you seeing some responses to these immune therapy drugs now?
Yeah, that's kind of, I actually, for the purposes of this talk, had gone backwards a little bit to see. I have a stack of immunotherapeutic responders in
Yeah.
my little baskets over here. And that's exactly, I mean, we see patients that hit a certain number, we give the immunotherapy. Some of them, Al is the example that I gave,
Yeah.
that's failed like 8 therapies or 9 therapies. Now he's at 22 tumor mutation burden.
Yeah.
Pow, he gets the immunotherapy, fantastic response. Yep.
That is cool.
Yeah, I
That is,
mean, I can't, I'm pretty jaded and I see a lot of patients, but I tell you, every time something like that happens, it just humbles me because it means that there's still discoveries and things that we're finding. And the patients are so grateful, that this is occurring and it's exciting,
yeah, that's really neat. All right, I have to give it some justice. This is a fast one. We were going to talk about PARP inhibitors, these oral agents that take advantage of certain mutations. Do you want to just give it your quick summary of what you're seeing from them? Are you excited about them? Seems like a lot more want to get in and get approved. Are you using them much, or are your oncologists using these PARP inhibitor drugs where a certain mutation
Yeah.
comes up, and then if the mutation comes up, you give the drug and boom.
Once again, it's a spectrum. So some of the patients you give the drug because you got a mutation, doesn't work that well. But occasionally there's patients that have remarkable responses. They're very durable. I don't think it's that predictable. I think that recently ATM mutations have been less thought of as being good mutations for PARP, but
Yeah.
certainly BRCA2 and
Yeah.
check 2 mutations, very strong mutations for predicting response to PARP.
Yeah.
But people forget though, the comparative trial looked at people that got a PARP for a known DDR mutation versus the ones that did not. This has been done in ovarian cancer. Ovarian cancer, you still get a 20% response.
Yeah.
So I think that I shared with you at one time, I can't divulge, anything about any details about the patient, but this is a patient overseas and he was from a prominent family and he had exhausted all therapies. And so I just basically told him, you've exhausted every therapy known to mankind. You've been able to lay your hands on everything. I said, have you tried the PARP? And have you tried darolutamide?
Ah.
And he said, well, I've done Abby, I've done Enza, I've done Erlita. I've never done a PARP because I don't have the mutation. And I haven't ever done darolutamide. I don't even know what that is. I said, well, get those 2 drugs, take them at the same time. I said, what do you have to lose? You've got the resources and the ability. It was the best therapy he had had. It literally took down his PSA from 265 to 45 in 2 weeks. And he had had actinium, lutetium, immunotherapy. He had had everything. Go figure.
Well, that's like what you talk about, going down your checklist, as I look at the huge checklist that you have, and that's the huge advantage of, at least understanding the opportunities. Yeah, I mean, you were around 15, 20 years ago. You remember the opportunity that was out there was nothing like this. So it's just a totally different game. It's absolutely fascinating. But anyway, okay. So we covered that for a second. Are you ready to go philosophical to end it?
Sure.
All right. My first, unless there's one thing that we did not cover at all in the DIY or the Mark Moyad world, because I think sometimes, and I bring this up with Scholz a lot. Do you want to just comment on the bone protecting agents at all? First it was all the talk was Zometa, then it's Xgeva, and the idea that we got to protect your bones, especially at certain stages of the disease. Do you get excited about these bone protecting agents that are out there that not only may prevent a fracture, but may do other things? Where's your excitement for those?
I will admit that I think that we don't give it enough attention. I think that patients do get really nasty compression fractures and broken bones because we're so focused on treatment. I don't administer anything like that through my clinic. As a matter of fact, you might ask, what the hell do I do in my clinic? It seems like all we do is pontificate and assign treatments. But we don't give any bone hardeners in our clinic. But I do think that there's a very important role for them. And I think that good medical oncologists generally keep track of the bone health of their patients.
Yeah.
And I respect that a lot. I cannot get into the weeds about this one versus that one because I don't know that much about it. But I think it's a very, very important thing.
But if you go down, all I was asking is general term. You go down the Kwan checklist of everything that I took a picture of. You go down there, and it doesn't look like on their chart as if they've had a bone drug. Is that something that immediately sends a signal?
I think it probably should send a signal more for us, but we're so preoccupied with what's the next therapy that we probably don't give that much thought to it in my clinic.
Okay.
Yeah.
No, I appreciate that. And by the way, I usually do a better job of this because I know a lot of the clinicians will mention generic names like darolutamide, and we're supposed to say the trade name Nubeqa and all that. I don't work with those companies. I'm just saying.
I'm glad you brought that up because for my talk, I flipped back and forth between the generic and the trade names. I served on the IRB for 11 years, and I swear to God that some of these drugs have names that were engineered to make me look stupid. So I cannot say some of the names for some of the drugs. I literally cannot. Is it olaparib? Is it olaparib? Is it, darolutamide? Is it Nubeqa? Is it Nubeqa? Is it,
Yes.
ipilimumab? Is it
Yes.
Yervoy?
Yes.
Yervoy? I
Yes.
mean, what Yervoy?
Yes.
What kind of name is that? I
It's
mean,
a made up name.
it sounds like something that happens if you drink too much. You
It's
Yervoid. It's just I find it almost impossible. So I apologize for that. I
Yeah.
didn't use just generic names. I used some trade names here and there because just saying some of the categories of the drugs. So I said RP, or you could call it
Yeah,
ARPI,
you
or you
call them
could call it
second
second
generation.
generation, or
Yes.
what do you call it? I mean, there's so many names. So I
You
tried to pick some of the easy ones for the
I know,
talk.
but the answer is yes to all of those names because it's a made up name. Unless it goes within generic class, then you can make, so you can say darolutamide, you could say bicalutamide. But when you start talking about trade names, these were organized names made up by groups sitting in a room to make you remember their name or for what other reason. So I find it so funny when someone corrects me when I give a trade name because I just have to write a paper on weight loss drugs, and all the new weight loss drugs have all these sorts of names. And I think that when someone corrects me, it's comical. I'm going, that was a made up name. So by you calling it Limparza or Limperza, I don't care if you're wrong. I think that they're both right. That's just my philosophy to get me through that kind of therapy. Anyway, sorry. All right. So here, now we're going to get philosophical. Oh, I can't get philosophical because you started with choline at Mayo, right? These PET CT options.
Mhm.
You're still using choline. Sometimes you use choline with PSMA. And will you you told me something in a private conversation that I just want to it's okay to switch to some of these if you're not finding it, but can you tell us some quick pros and cons? I mean, everyone's gaga over the PSMA product, which you should be gaga over. It's an incredible PET CT option, but what are the catches? Are the catches with all these PET CTs false positives, false negatives? What are you seeing as the catch? Because everyone wants to hug them and kiss them and go, they're great. They are great. They've changed medicine. But what are some of the catches people need to think about?
So first of all, I hope when you intro this talk and roll it out to the audience,
Yeah.
that you do a preface to encourage them to watch the previous combat manual
Yes.
lectures.
Yeah,
They absolutely have to. So my prediction in the beginning was when PSMA rolls out, everyone's going to go gaga over PSMA and they're going to say choline is yesterday's news. And choline is still here and we're not going to get rid of it. So it's very interesting. So before we go into that list,
Yeah.
originally there was only one form of PET scan that was used in general in the world. It was called FDG, glucose PET scan, FDG. So glucose PET scan was found to be pretty crappy for prostate cancer.
Right.
So the guys at Mayo decided that we're going to look for other things that work better than FDG. So we found choline, and choline was selected over acetate. There was a C11 acetate, and then there was C11 choline. Choline did much better than acetate and much, much better than FDG. Okay?
Okay.
So then choline is what we've been using since 2012 when we got FDA approval at the Mayo Clinic. The problem with choline is you cannot put it in a vial, you cannot package it, you cannot form a company. So that's why it's not available. We make choline on our campus using cyclotrons here for the specific patients we're going to study. That's not a business. That's just for each patient that comes in, we do it. So then PSMA came out. So PSMA looks at a marker on the surface of prostate cancer cells. So PSMA is easy to package, it's easy to send around. Everyone in the world is using it. And it's a beautiful scan. It's actually easier to read than a choline PET scan. So even our nuke med people are like, oh yeah, this is a lot easier on my eyes, PSMA. But here's the catch. Number one, there's a set percentage of patients you can't see their cancer on a PSMA PET scan. And some of them are the worst cancers, the cancers that I brought up that are PSA 0. They don't make much PSA, they're poorly differentiated, they lack the marker. I don't know what the exact number is. I've seen numbers as low as 7%. I've seen numbers as high as 20%. So somewhere between 7 to 20% of guys walking around, if they get the PSMA PET scan and they get run through, they're not going to see anything. So that's problem number one. Problem number two, if you accept, let's just pick a number. Let's say it's 13% of the patients don't have the marker. Well, then the statistical game that goes through my mind is, well, what if a guy has 130 spots in his body? And we know that those are all mutating. What's the chances that a good percentage of those aren't going to show up on a PSMA PET scan? Because we know the disease is heterogeneous. The same mutation that makes it invisible in some guys altogether is probably the same mutation that's going to make some of the metastases invisible in some of the patients. So I told Mayo, do not get rid of this choline PET scan. We're going to need it. So then we started treating patients with lutetium just like everyone else in the world. We've actually caught up with a lot of people throughout the world in terms of expertise with lutetium. And what's the first thing we're finding out? Well, sometimes the cancer is going away on the PSMA PET scan, but the PSA is not going down, or the patient doesn't seem to be doing that well. So why is that? Well, because then when you take that same patient whose PSMA PET scan is looking better, and then you put them in a choline PET scan, you see that there's a bunch of disease that doesn't have PSMA.
Yeah.
So the rest of the world is already waking up to this. They're saying, well, Dr. Kwan's not too bright. We're not going to listen to him. But I noticed that there are some guys that are not responding to lutetium. What should I do? Well, I think I'm going to get an FDG PET scan on this guy. So all of a sudden, FDG is becoming very popular again.
Yeah.
It's like, oh, FDG is the scan that you should get when the patient's not responding to lutetium. Oh, yeah, there's a lot of FDG spots that don't have PSMA on the surface. We're brilliant. We found the cancer. Well, here's the crazy part. That's where we started the story. We already know that some of the cancers don't have the markers, and you can see them on FDG, but choline's better. So we're starting all the way back at square one. People are saying, well, Dr. Kwan, that patient didn't respond to lutetium. Did you think about getting FDG? I'm like, why would I get FDG? We got choline here. No, you got to get FDG. It's kind of maddening. You go full circle. But the reality is that it's just like the therapies. There's no one therapy that's going to cure you. All of these scans have strengths and weakness. Sometimes a guy will not light up on a choline. They'll not light up on a PSMA scan, but they'll light up on FDG. Go figure. Sometimes maybe Oxymin is, I don't have that much experience with Oxymin. I haven't seen that much recently, but sometimes Oxymin also may be able to see things that the other scans can. I can't say the first word.
No,
so
you said it right.
No, the
flucyclamine.
Every time I say that, I spit out something. So
that's okay.
So the reality is, again, I keep trying to harp on this over and over. One drug is not going to cure the cancer. One scan is not the answer. Looking at things as A and B and C, that's not the way to look at this disease. You got to stay nimble. You got to keep a wide field of vision. You have to have your antenna up, and you have to be suspicious of everything.
No, it's well put. Can I recommend a future lecture that has never been given to my knowledge? I don't want to get in trouble because I don't go online or anything. You've talked about it, and I don't care how much you know about it. It'd be really smart in the future if you give a 5 to 10 minute lecture. Are you ready for this? Are you sitting down? Only on neuroendocrine small cell type tumors. Nobody is doing that. You can say, well, that's 2%. You could say, I think in your statistics, you said 4 and 1%. I forgot the numbers. It was very small. But if that's 5 of every 100, there's hundreds and hundreds of couples and families dealing with this. Why aren't we talking more about what is increasing in number, not just philosophically, but if you think about it, it has to increase in number in the game of prostate cancers, these neuroendocrines, these small cell tumors, these variants. Will you promise a lecture that's 10 minutes or 20 minutes in the future, since you can explain things well? PCRI makes fun of me a lot. And Alex and I talk about it, and Mark and I talk about it, because I just take the pathology sponge and I squeeze it too much, because I was obsessed with pathology in medical school, and I was obsessed after I graduated. I just wanted to learn everything about pathology and prostate cancer, and I did a lot of work in pathology. So I wanted to learn about interductal. I wanted to learn about cribiform. I wanted to learn about high-grade PIN. But so we've had those lectures, but we have these variants in pathology. So why aren't we talking about the variant that's out there that people don't know much about and how to treat it or what to do, these neuroendocrine tumors? Can we do that?
I think it's a moving target is the biggest problem. So
Okay.
I think that, I know that sometimes you guys feature, Dr. Epstein and so forth, and I respect all these guys. We have Dr. John Cheville here at our institution. He's top pathologist. I have to be very candid. I think that these are buckets and definitions that are from years ago. I don't think that we know that much about these things, and I'm not sure that the buckets are as cleanly defined as we think they are.
Yeah.
One of the things that came up recently, I have a lot of patients, it's like, okay, his PSA is undetectable. So you have a guy, his PSA is undetectable. So you say, what's the PSMA PET? So his choline scan lights up and he's got multiple spots. And you say, what's the likelihood that he's going to show up on the PSMA PET scan? So I had predicted the chance of anything showing up on a PSMA PET scan on a guy that's choline positive with an undetectable PSA. I predicted that there's no way that he'll light up in a PSMA scan. And over half of them light up in PSMA scans. So then you realize that your way of thinking about things is illogical. Nature's doing something different. It doesn't work that way. So then that raises the question, because anyone that's choline positive with an undetectable PSA, I say he clinically looks like neuroendocrine. And some of them you biopsy, it's neuroendocrine. Sometimes you biopsy, it's just Gleason 10, but it's lost the marker.
Right.
So you've already, but then you say, but it's got no PSMA. So, is it neuroendocrine? What we don't know. We just at this point don't know. And I think that every single permutation that your mind can generate, I think it's out there. Some have synaptophysin, some have chromogranin, some have PSMA, some have no PSMA, some have AR, some don't have AR. That's what the point of that one slide I made where I said, I'll bet you 45% of the cancers we see in our clinic do not fit into a classical description of prostate cancer. I have no idea what it is, but I know it's not exactly one of those. So, and I think that that's probably the biggest problem right now. And that's why no one is making a living out of just talking about pure neuroendocrine or small cell. It's a moving target,
I appreciate that. And that can be part of your 10-minute lecture of just what is it? Why does it happen? What do we know? What don't we know? Because you can explain it well. I agree. These things become gigantic umbrellas, and that's why I got obsessed with it in pathology when I just interviewed the last speaker, that when we talked about this variant, there's so many things now we're learning underneath the variant. I'm just, I just feel like you don't have enough work. I just think that you would probably do a really good job explaining what we know and what we don't know in your free time.
Sure. No problem.
All right, let's end on philosophical. These are only oh no, I can't. The question that I always get that you don't talk about, I don't know if you're a big fan of it or not, is the trials going on with bipolar androgen therapy. The idea that if you give a bunch of testosterone with another therapy, because in ASCO last year, they saw a benefit possibly to using an immune therapy with bipolar androgen therapy. So you're giving high dose, super physiologic, they call it testosterone, along with an immune therapy that maybe you can get a response. Are you excited about possibly combining or seeing in trials high doses of super physiologic doses of testosterone to try to reboot the tumor in a way to get it to respond to other therapies? Or are you're just waiting for more data?
So this is just a Kwanism, okay?
Quanism.
All
That's my
right.
word too.
So anytime that there's a therapy where you have to then couple it with another therapy to show that it might have some relevance or ability, I think you're already in trouble. I see that a lot. It's like, well, that didn't work so good, so now let's couple it with this. Or now let's couple it with that. Or maybe we have to tweak it this way or that way. I'm skeptical. A lot of people don't know this. So the reason I started treating with chemotherapy way back when was not because I was interested in chemotherapy. It was because I was interested in the concept of hormone priming of a response. So I met a physician at that time that says, "You're not using enough chemotherapy, it works." I said, "No, there's no literature that says chemotherapy works." No, Taxotere works, Taxotere works. I said, no one believes that. I said, the only thing that's guidelines and approved for prostate cancer is hormone therapy. He said, no, chemo. So finally I said, okay, I'll tell you what. I will let you give chemo to my patients, but I'm going to give them intermittent hormone therapy when we do it, because I think that we might be able to prime responses to chemo. So I looked up the literature at that time, and a number of, Johns Hopkins types and so forth had already done something called hormone priming to facilitate responses to chemotherapy, because the thinking was that if cells are sleeping, they're not going to be as vulnerable to chemotherapy. So you got to wake them up and then let them go back to sleep and wake them up. So I thought I'd come up with a brilliant idea. Well, just like all my other ideas, had already been done 10 times before by other groups throughout the world, and it never worked. And sure enough, it never worked. I mean, it didn't really do that much for our patients, but they responded to chemotherapy, so we stuck with the chemotherapy. I'm a little bit skeptical about the role of hormone therapy as a facilitator. So I ran a trial to use hormone. I mean, I'm not disparaging other people's work. I'm disparaging my own work. I wrote a grant. I ran a trial to look at hormone therapy as a priming agent for immunotherapeutic responses. Because at the time, the dogma was that hormone therapy triggers apoptosis of cells. Apoptosis of cells results in rapid uptake due to annexin 5 by antigen presenting cells, which then will present the antigens to the immune system in the proper way to facilitate a response to checkpoint inhibitors. So I wrote that grant. We could never prove it. We could never prove that facilitated anything. So I'm a little bit, I don't know that much about, I don't do bipolar treatment in my clinic. I don't do pulses of androgen. Other people have some experiences. I don't doubt that anecdotally it works for some people. But I also know, because I get patients that have been on some of those studies, that it doesn't work. And some of them have not had nice responses. Some of them have had side effects of therapy. So I don't know where I weigh in on it, but I'm a little bit leery about it.
What happened to your guitar? You played guitar last time, and this time, were you shy? You don't have it anymore? You don't, I guess you're not going to do a song, because a lot of people commented that your guitar playing wasn't too bad. I mean, most people thought you should keep your day job, which is a good sign. But I was more impressed by the comments. They didn't say you were bad at all. They said you were actually pretty good at guitar. So I guess you didn't bring your guitar today.
No.
Okay. Here's my next my first real philosophical question. I don't know why. This is me. I've written about it a million times. Maybe it's because of what happened in my own family. I don't understand. Maybe you can explain it to me. I don't understand what stage 4 prostate cancer is because the idea of stage 4 in the past through my whole life means, oh, you're terminal, pack your bags, that's it. Stage 4 today, like you said, prostate is so heterogeneous. Stage 4 could mean one thing to one person and a physician. It can mean one thing to another. A stage 4 cancer could totally go into remission in one case. It might not respond to treatment in another. What is with this using stage 4 to mean that there's doom and gloom? I mean, do you want to comment on that? Can we reword that? I mean, you're dealing with a lot of people who are stage 4 and they get robust responses in some cases, and sometimes you get miracles. But am I do I need to step off this horse? I mean, it's a pet peeve of mine.
Yeah, I think that you're exactly right, and I'm always shocked. So patients walk into our clinic all the time, and we don't have a single patient that's not stage 4. Um, what I tell them is stage 4 is a very old term, and that it was developed at a time where we used to see prostate cancer as a binary disease. It's either inside the prostate or it's outside the prostate. You're either going to be fixed or you're going to be doomed. So, stage 4 was a category for patients that there was cancer outside the prostate. So, when patients come to my clinic and they say, "What's my stage?" I say, "Well, a lot of those stages that were developed, the staging system, really refers to an old fashioned scheme of discussing prostate cancer. In the old terminology, you're stage 4, but we have stage 4 that's going to live 20 years or even be cured. And we have stage 4 that it's kind of serious and we have to get busy with treatment. But otherwise, it's just everyone's stage 4
Mm.
because once it's outside the prostate. And a lot of times, if you sit down and explain it to the patients, and I always tell patients where their educational age with the disease. So a lot of my patients, they'll come in PSA 5, PSMA PET scan or choline PET scan, saw one spot. They haven't been treated thus far. It's stage 4, but I tell them, well, yeah, you're stage 4, but you're in preschool for us.
Mm.
Okay. Another
Mm.
guy comes in and he's got 52 spots and he's failed 10 different or, 3 different treatments. And you tell him, well, you're stage 4, but, you're kind of in 7th grade or something like that. So stage 4 is a meaningless term there. And you know what? Related to that, I mean, I don't mean to slam any organizations or whatever, but there's a lot of attention that's given to the grade and the pathology of the cancer, the TMB staging, the stage, whether it's all meaningless. It's all, in my mind, I always look at good, bad, the ugly. It's either good or it's bad or it's ugly. And for the ugly, we have to work harder than the good. So I don't really get too much into the weeds. And then I also, like I said, I stay very pragmatic. You don't know what you're going to get as a response until you start something. So
Yeah,
I always
yeah.
tell patients, you don't know what you're going to get until you start it.
That's really well put. Because I'm not saying that the people commenting online or and the patient saying stage 4, oh, I'm in trouble. I'm not saying it's their issue. This is just, it's like chemo. It's an antiquated philosophy. And this philosophy started a long time ago that stage 4 meant you were doomed. But like you say, most of your patients are stage 4, and you see a lot of great things happen in stage 4. Sometimes you don't see great things, but the idea that this is just one pool of doom, I just hope we can continue to change that philosophy. What's the biggest mistake you see couples make when they come to your clinic? What's the biggest mistake you see just couples or men make just initially when they come to the clinic or you're talking to them that you see it's a preconceived notion and you just go, man, I just see that over and over again. I wish I could change that paradigm. Does anything come to mind?
I think not asking enough questions. I really do. I mean, and I don't think it's a mistake. I told you that I wanted to do a certain intro for the the combat manual.
Yeah.
And I sent you that one slide, the quote from Scent of a Woman. I think that the way we've set up our medical world is basically a patient gets a diagnosis, and then everyone's so busy and everyone is moving so fast and everyone wants to get to the next step. And what ends up happening is someone will walk in. I mean, even the stage 4 discussion, a doctor will walk in and say, "You're stage 4. You got to try this." I mean, it's pow, just pow. It's like, "What did you say?" "Oh, yeah, you got cancer, can't be cured. You got to take this agent. We better get started on it immediately." And then whammo, they're on a therapy. And it's usually a therapy that's not very well thought out. And I think that that's the biggest mistake, because a patient will come to me. We even tell our patients, do not come to us after you started the therapy. Wait until you get to see us. And they'll get the therapy. And I'll say, "Why did you get the therapy?" And they'll say, "Well, my doctor said I had to have it before I left the office." I think that a lot of times people are so shattered by the diagnosis. And I think that they're given such grave and foreboding information that they're scared out of their brains, and they get treated sometimes without necessarily thinking about it. And unfortunately, there's no way for us to go out and say, "Please watch these videos before you jump on therapy," because a lot of these guys never even get out of the doctor's office before they've come up with a strategy. They're just hammered right there on the spot. You need radiation, you need hormone therapy. If you don't do it tomorrow, you're going to be dead. You have stage 4 disease. I think that that's the biggest mistake that I see, is that a lot of people will launch on a treatment without really having a chance to dive into it. And I don't think that's a patient problem. I think that that's kind of the way we run medicine nowadays.
Kind of goes back to the philosophy. That's really interesting. When people understand in business, when they're the customer and then they go to a business, whether it's getting a car fix or something else, they'll ask questions. They want to make sure they're getting a good deal. They'll do a lot of investigation, and people forget that medicine, is pure and wonderful it is, it's a business, and patients are the customer. But the customer decides what business they want to go to, and the customer decides what they want out of their business, and they have to do a certain level of homework. And I like your answer. I didn't expect that. They don't ask enough questions. So then what's the biggest mistake that doctors make? Is it that they don't think about enough treatments? Based on your lecture, what's the biggest mistake docs make?
I think the biggest mistake that a lot of doctors make is that they tend to be kind of herd mentality. I mean, I think that they go around in herds. It's like, "What do you do for this patient?" "Well, I give, whatever the newest word is, I give flugelhorn, "Oh, really? You're using flugelhorn?" "Well, I used it twice." It's kind of, it kind of drives you a little bit nutty, because it's like, if we could do surgery using a PSMA PET scanner, we'd be doing surgery using a PSMA PET scanner. "Well, how'd you do the surgery?" "Well, I threw away the robotics and I used a new PSMA PET scan." It's like everyone just gloms onto the latest thing.
Yeah.
And like I said, I think that a lot of doctors are no longer thinking in terms of mechanism of action, goals of therapy. I think that they're thinking in terms of, market, not market in the sense of making money, just marketing. What did
Yeah.
they hear most recently? What rings a bell? What are their neighbors using? This kind of
Yeah.
stuff.
Yeah.
And I think that there's, limitations to what you can get out of that.
Yeah. That's well put. By the way, I'm on flugelhorn. It's doing me wonders.
Yeah, and I was about to say, it's really improved your complexion
My-
quite a bit. Yeah. I lost 12 teeth because of it, but it's just a side effect. It's all
I have
right.
a pen that says flugelhorn.
Yeah. Yeah.
If you had $100 million and you could, besides using it on giving me some of the money, and by the way, I have to make a side note. For you to say I live in a mansion, you should have seen me roll my eyes when you said that. The
I
guy,
thought
you know,
I had some. I thought I had some pretty good jokes in this
you
one,
had
even though
really
it's,
good jokes, but you learned from the master. You need to start giving copyright because of all of our
yeah.
private conversations. But I laughed so hard behind the scenes when you said bigger than, like Moyad's mansion, and I'm thinking I'm sitting in an office that's basically my house. I'm the public health guy.
Yeah.
I'm the guy who wishes he had the mansion of those, those busy urologists and oncologists. But of course, I got to get defensive when you say that. Okay, if you had $100 million and you could run any trial or do anything with it, you could run a trial, you could build some kind of center, you could make something happen magically, $100 million check, you won the lottery, you won the Powerball, and you won the Mega Millions. What are you going to do in prostate cancer with it, and why are you going to do that?
I have this theory that we're still splashing around in the shallow end of the swimming pool. So if you look at hormone therapy, second generation hormone therapy, chemotherapy, immunotherapy, radio-ligand therapy, there's still a killer form of prostate cancer that does not get picked off by these treatments. And I have a theory about that. My theory is that the form of prostate cancer that is killing off patients does not have any identifiable markers that we understand. So this comes back to that 45% of the cancers, we don't know what it is. The reason I know it's there is because I see it on our choline PET scan. On our choline PET scan, we have guys that lose their PSMA, they lose the PSA, they lose everything. They don't respond to immuno, they don't respond to, and this thing goes like a bat out of hell, going back to Meatloaf, bat out of hell. So to me, so the analogy I have being a Midwestern guy is that it's like the old days when we had our Camaros and we wanted to make our Camaro faster than everyone else's car. So we took out the seats, we ripped off the antenna, we shaved the antenna, we take out the radio, we lighten the car, and we have this turbocharged engine in it. I think that these cells are primitive. I think they're primordial. I don't think that they have PSMA. I don't think that they have this. I don't think they have that. I don't even think that half the world even knows they're there, but we can see them on a PET scan. So if I had the $100 million, I would sequence those cells that I can see on my choline PET scan. I'd sequence them and see how their genetic sequence looks compared to all of the cancers we're treating. But more importantly, this is where my theory gets bigger. My bet is that the cell that kills the patient in the end is also the same cell that kills a woman with triple negative breast cancer or lung cancer that failed, cisplatinum, PD-L1 immunotherapy. I think that there is a lethal phenotype that no one's ever seen. And the reason we don't have drugs is because we're only focusing on the cancers that are defined by the nomenclature of the disease. PSA, PSMA, neuroendocrine, whatever. These cells have nothing. And no one's looked for them. No one's biopsied them. We can see them on a choline PET scan. So I'm thinking that if we could biopsy the lethal disease of breast, the lethal disease of prostate, the lethal disease of lung cancer, and then look for a consensus sequence amongst those lethal forms of cancer, we're going to discover a new set of genes that mediates the end game for cancer in general. And I think that in and of itself will be another generation of therapies, another drug company, another everything. So if I had 100 million, that's what I would throw it at. Or I would I'd buy some guitars,
Yeah, you'd take me to dinner more often. You haven't bought me. I've known you 15 years. You've never bought me dinner. It's embarrassing.
Well,
that's a whole other lecture. The reason I think that 100 million answer is so good is because you touched that button in my head, which is, I've talked to you about this privately, the idea of building neoantigens, personalized antigens that can ultimately be used in a form of vaccine therapy that is applied to cancer patients so they get better immunosurveillance, is what's going on in melanoma now. And the reason that's such a good idea is because how are you going to know what markers to go after and which markers to develop an immune response to or whatnot, unless you know what those later game markers are?
See,
So
the
that's
big
very profound. And I had nothing to drink before this lecture or nothing to smoke, but I'm telling you, that is a very profound comment.
well, the weirdest thing, the weirdest thing about this discussion is, even when people are watching this discussion, they're still not going to understand it. The reason this hasn't been done is because no one knows where to stick a needle to
Yeah.
sequence the lethal phenotype. Because if you use a standard imaging device, a lot of times you put a needle, MRI, CT scanner, PET scanner, whatever. If you're not looking at a live cell, you're going to biopsy it and you're going to get garbage in, garbage out. So the reason the choline PET scanner is so good for this is choline PET scan lights up like crazy when the cancer is getting angrier. So you can know exactly where to put the needle. And I know, based on a lot of my patients that walk in with 2 other cancers, that choline will also light up those other cancers. So I think that one of the impediments has been no one knows where to put a needle to get a sequence. Second part is no one knows what to sequence. Everyone is doing everything based on our old education about what is cancer. But
Yeah.
I don't think that cancer is like that. I think that all these nomenclatures, prostate cancer, breast cancer, all this stuff, I think that's kind of old school thinking. I think that we should be thinking more in terms of, kind of genomic designations of what the cancer really is.
Yeah, but I think that's a pilot trial, and that's not $100 million trial. That pilot wise, that could be 250,000 to maybe $1 million. I mean, you could just do something pilot wise with choline and some biopsies and start the process, don't you think? I'm throwing
You
out a
know,
hint there into YouTube land. I'm
well,
giving.
I think that the problem is that, you know, doing the actual work, seeing the patients, doing the biopsies, we would have to write for special IND for choline PET and all that stuff. That all costs money, but you know where the money goes? Do you want to really know? So doing the sequencing is so cheap now.
Right.
So doing the sequencing, doing the biopsy, doing the processing, taking
Pilot
care of the patient,
trial.
you know where the money goes?
Well, hopefully it goes for your pilot trial.
Statisticians.
They get paid if you can find one.
So if you hand them the data set from a genomic comparison
Yeah.
sequencing, if you have $100 million, you'll spend $10 million doing the grunt work and all of the important stuff, and you will spend $90 million doing statistical analyses. That's the
Yeah.
way this works. But I do think that when I talk about kind of the most important studies that have not been done, that's one of them. And I
That's
think that it's one of the most important.
that's awesome. Hopefully, someone watching this in the next year or 2 years will figure out a way to do a pilot study with you. I mean, some of my favorite studies I ever did was a pilot study. Then we'd learn something else and we get all excited. I'm exhausted. Do you realize that is the longest Q&A in the history of my 15 years of PCRI? That is a 2-hour Q&A. I am virtually spent. I don't know if you're exhausted. I feel
But
like
we
if I
haven't done the intro yet. You haven't
no,
done the intro for my
no,
talk.
but they're going to do the intro. We're going to do the intro. And Alex is going to do the intro because we're spent. She can do the intro much better than we can do the intro. So I'm just saying, can I just say, before I say thank you, can I just I'm just going to prove to America that I don't believe that you have any life beyond hanging out with your wife and reminding her that you're married once in a while. And also working all the time and with patients. And by the way, I'm not going to ask you the question philosophically, what are you most proud of in your career? Because You're the one clinician I know that's so proud of being a clinician. You just ooze of it. You just love seeing patients. You love to be all about the patient, which is very refreshing. But I got a couple quick questions for you. During last weekend, Minnesota Golden Gophers football team, they played the University of North Carolina. Do you know who won?
I didn't even know Minnesota had a football team.
Oh my God. Okay, let's try something different. The Vikings played last week against a certain team. If you can name the team or the score, I will buy you a large, healthy pizza.
I actually like football. You're not going to believe what I've been doing. I have literally not watched a football game because I've been preparing this damn talk. I've clicked on the TV in the background.
Yes.
Making this talk was a bear.
No,
this
it was a
a
monster.
bear. This
Right.
was one of the, I think that I wanted to make sure that I got the details in there for the patients. And it was not kind of one of my glib kind of, oh, this is fun and this is, this is this. This is more of an instructional video. I started this, I mentioned that I wanted to do this last year to
Yes.
you. And I actually started in earnest putting the slides together in June. In June. And every single day and night that I had a moment, I'd work on these slides. And so I've missed the first part of the NFL season. I don't watch college anyway, but I haven't been paying attention because I had to get this done. But now I promise I
You're
will
gonna watch
watch
football.
some football here and there. Yep.
Okay, the Vikings had a problem with the Eagles. I'm trying to help you. Okay, now my final question is, I will not buy you again a healthy large pizza.
I'm not a Vikings fan anyway.
Okay, but you went to a college called Grinnell, and Grinnell has a football team, and they played last weekend against Beloit College. Do you know if they won or lost? If you can tell me if
Probably
they won or lost, they
Probably
lost?
lost. So let me tell you why I would guess they lost. So I
Okay.
received my Grinnell alumni magazine last year.
Yeah.
And the headline in the magazine was Grinnell won its first football game in the last 1,000 days.
Yes. Okay.
So when I was at Grinnell, during the 4 years that I was at Grinnell, number one, they won 2 games in 4 years. The second thing that I can tell you is while I was sitting in the stands, they were trying to get me to put on a uniform to be a running back.
No, that's scary.
One of the guys got hauled off the field, and I could see them yelling at the coach, Kwan's really fast. Kwan's really fast. We can use him. So they came to me while I was in the stands and asked me if I would play running back for that game so that we could get through the game. So I was thinking about it because I was a pretty good sprinter when I was in high school. I ran 100-yard dash, and I was also a 400-meter guy. So I was thinking about getting dressed and trying some running back there on the spot for the game. And on the very next play, they hauled Mark Conrado off the field on a stretcher. And I'm like, no, I don't think I'm going to do this. So
Yeah.
I didn't help Grinnell's very poor at football.
Well, first of all, I'm glad that you didn't play in that game because maybe I'm wrong. Maybe you would do so well that you'd be playing pro football now, and then you could have never helped so many patients. So maybe that was fate. But I think part of your message today was just when you think you know stuff, you don't know stuff, which makes sense to me. So the reason I asked you this question is, yes, your team is very bad in football in college, but they won. Grinnell won 33-23 against Beloit College. I think it was their first win of the year. And so now, Dr. Kwan, you can be optimistic about your Grinnell Pioneers having a winning season potentially, and you being a proud alumnus.
So did Beloit get all its buses to Grinnell, or some of the buses got lost? Something must have happened. Something, it could have been salmonella at the truck stop. Something
rampant. Maybe they
to
forfeited. Maybe there was exams the next day. Anyway, so you did exactly how I thought you would on my quiz. You got 0 for 3. And I try to tell people that is a testimony to the fact that you work too much and you need more free time because you need to follow football again. But it also shows you your dedication to patients and the mission. And I'm telling you, I have known you a long time. This series of what you just did, they said you're going to bring in 197 slides. I almost said, oh my gosh. But every time he does that, it works out. It not only worked out, you got a 10 plus from me, 2 hours of Q&A. I'm exhausted. Brilliant. I appreciate your friendship and I appreciate what you did here. I really appreciate the amount of work you did. It was unbelievable.
Well, I think that at a minimum, I am all about kind of trying to give back to the patients. This is a two-way street. I learn a lot from my patients. I probably learn more about life than, anything else. So that's a gift. When patients are telling you about their life, that's something that you can't learn anywhere. So the exchange is I try to take care of their medical situation and they try to help me understand life. And so that's the exchange there. And I'm very dedicated to this because I can understand how patients feel. I literally am miserable thinking about what they must go through, the humiliation, just sitting there waiting in a lobby for some doctor to go, including me. I mean, we're always behind. It's really humiliating. And then to have someone just say, well, you don't get it, I don't have time, that's horrible. It's insult to injury. I don't know how patients deal with this. I honestly don't. I mean, I melt down if something minor happens in my life. I find it almost intolerable. But then to be given a diagnosis that you may not live very long and you got a family and I mean, I can't understand how human beings tolerate that or deal with it. So I want to make it as easy as possible for the patients. I think that they deserve at least that. And so that's why I make the slides. That's why I work on it, because I figure with a little bit of my effort, I might be able to clear up some of the misery that these patients have to go through. And I'm not trying to say that everything I say is gospel. It's an opinion, but it's what little I can do to help these patients that I think are suffering terribly. Going back to the presentation, Bob Dylan, Neil Young, Al Collins, Mark Knopfler, David Gilmour, those were the names for the guitarists on the video for the cases. But I didn't think that, I can just see now I'm going to get a lawsuit from Bob Dylan because he didn't like being used as part of a prostate cancer video. I hope not. I hope he understands the spirit in which this was all done. But that's where I got the names for the characters. Yeah.
No, that makes sense. That makes sense. So
yeah,
love it. I'm just going to stop there. I think it's been a great day.
Thank you so much, Dr. Kwan, and thank you, Dr. Moyad. That was very helpful. Our next segment is a sponsored talk from Bayer Pharmaceuticals, and they're going to be talking about living well with prostate cancer and sexual health in prostate cancer. It's going to be presented by Kelly Gingrich, and she's an oncology nurse educator with Bayer. She's spoken for us before and done an incredible job. I hope you find this informative.
Hi everyone and welcome. My name is Kelly Gingrich. I'm a nurse practitioner and oncology nurse educator with Bayer. We want you to have all the tools to manage your disease so you can live well with prostate cancer. This video specifically focuses on sexual health and how it relates to the disease. Before we begin, it's important to know that this is intended to discuss disease state education only. There'll be no discussion of any prescription medications by name or other therapies. I will not be discussing specific patient experiences or medical advice. If you have any health-related or medical questions, please make sure to consult your doctor. Throughout this video, we have included gray bars on the bottom right corner with useful questions for self-reflection and to help start a conversation with your loved ones and doctor. Sexual health is an important part of your overall quality of life and includes not only your physical ability to have sex, but also mental, emotional, and interpersonal aspects of sexuality. Prostate cancer can affect your relationships with your partner. It can decrease your desire for sex and cause feelings of embarrassment or shame. Experiencing changes in sexual health during prostate cancer is common, and there are various medications, counseling opportunities, and medical devices, as well as resources available to help manage these concerns. I'll share more details about these resources throughout this discussion. It may feel embarrassing to talk about, but it's the first step toward improving your overall quality of life. Most men, even those who do not have prostate cancer, experience symptoms related to sexual health at some point in their life. In fact, 7 out of 10 men with prostate cancer have difficulty getting or maintaining an erection, and half report that they no longer have sex after receiving treatment, including medical or surgical options. Experiencing changes in sexual health is common with prostate cancer. Some of the more common symptoms associated with sexual health include erectile dysfunction, decreased desire for sex, orgasms that are dry, painful, or weak, and incontinence with ejaculation. I'll go into more detail about each symptom later in this discussion. Although many men with prostate cancer experience symptoms related to sexual health, many avoid talking about their symptoms or asking about treatment options. It is important that you speak up and start the conversation with your doctor and partner so you can get the help that you need. Changes in your sexual health can affect your quality of life. Address those issues to get the care that you deserve. Physical and mental health symptoms can impact your sexual health. Changes to your body can include a decreased desire for sex or intimacy. This might come from bowel and urinary dysfunction, which can affect not only your day-to-day life, but also your sex life. This can also come from feeling anxious, depressed, or overwhelmed with the changes that are happening when undergoing treatment for prostate cancer. The psychological strain can impact your desire for intimacy and sex. Over time, physical changes can improve or become less noticeable, and there are many mental health resources available that can support you, your partner, or caregiver. Just as physical and mental health can impact sexual health, the reverse can happen, where sexual health can impact your physical and mental health. Some medical and surgical treatments may cause men to feel less masculine or less like a man. These feelings can be made worse by other physical side effects that impact day-to-day function, such as fatigue, weakness, or incontinence. Some men have felt like part of their identity was lost when experiencing erectile dysfunction or decreased desire for sex, which commonly leads to frustration and lower self-esteem. Changes to your sexual health can impact your relationships, especially with your partner. It's important to talk about these changes and how they affect you and your partner. You should encourage your partner to seek additional support if needed. Luckily, many men experience an improvement in their sexual health over time. Some might even notice that as one symptom or side effect improves, other health aspects improve along with it. It's important to mention that prostate cancer can affect populations differently, such as the LGBTQIA+ community. If you identify as part of this community, you may have additional questions when it comes to your sexual health. Let your doctor know your sexual orientation and gender identity so they can provide you the care that you deserve. Don't wait to bring up these questions and concerns with your doctor. I'm going to briefly go through the common sexual health side effects related to prostate cancer that we mentioned earlier, starting with erectile dysfunction. Erectile dysfunction is the inability to get and keep an erection. This is common among all men, and not just those with prostate cancer. Erectile dysfunction is particularly common with prostate cancer treatment because the nerves and blood vessels that trigger normal arousal and erection are located along the prostate. During standard surgery and radiation treatment, these nerves and blood vessels can be affected, which may impact the ability to get and maintain an erection. Ask your doctor about nerve-sparing techniques in surgery that can help prevent these symptoms, or about newer treatment options that may have a reduced risk for erectile dysfunction, such as high-intensity focused ultrasound or cryotherapy. Fortunately, most men experience an improvement in their erectile function over time. Be patient with the recovery time associated with surgery and radiation treatment. It can take time to see meaningful improvement in your erectile function. There are many treatment options available for erectile dysfunction. Some treatments include medications, penile injections, urethral pellets, and devices such as implants and vacuum pumps. Pelvic floor and penile rehab might also help your recovery. You can also ask your doctor about being referred to a provider who specializes in sexual health and prostate cancer. A decreased desire for sex, or libido, is another common sexual health effect you may experience. Similar to erectile dysfunction, decreased libido can occur as a side effect of medical or surgical treatments for prostate cancer. It might also be impacted by changes to your physical and mental health. It's important to highlight that libido is different from intimacy, and talking to your partner can help you find new ways to be intimate. When considering an appropriate treatment option for decreased libido, it ultimately depends on the underlying cause. Talk to your doctor about what treatment options are available and which one might be best for you. Sexual health with prostate cancer can also include changes in orgasms. After your treatment for prostate cancer, you may notice that your orgasms are dry, weak, or painful. You may also experience some degree of incontinence, which can present as leaking drops of urine during or after sex. Standard treatments such as radiotherapy and prostatectomy can reduce your body's ability to store urine, so it's not uncommon for men who receive these treatments to experience incontinence, especially during orgasms. These symptoms can be bothersome or uncomfortable for you and your partner, but they are not dangerous. As your body heals, the muscles that control your urine tighten, and you will likely notice improvement of these symptoms during sexual activity. To help reduce the effects, physical therapy exercises that strengthen the pelvic floor muscles and pelvic floor rehab can help improve the incontinence. Make sure to discuss this with your doctor and get more information. You can also ask your doctor to be referred to a specialist. Some men with prostate cancer wish to father children and wonder if fertility is even an option. Even though prostate cancer treatments can cause your body to produce less semen and have lower sperm counts, fertility is still possible. Some men look to sperm banking for fertility preservation. This is when men choose to freeze their sperm before their prostate cancer treatment and store it for later use. Another option for fertility preservation is radiation shielding. This protects other parts of the body, including the testes, from the radiation used to treat prostate cancer. Having radiation treatment does not increase the risk of birth defects. If you have difficulty conceiving naturally after treatment, you can consider testing your sperm's viability. If sperm viability is affected, your doctor might try using assisted reproductive technologies to help you still have children. Have your doctor help advise you on when it's safe for you to conceive based on your treatment. It can be difficult to start a conversation on sexual health, but being prepared can help. Starting conversations earlier with your doctor can make later conversations easier. Here are a few example questions that you can ask your doctor. What are the risks and potential side effects associated with my treatment? How might treatment affect my sex life? When is it safe for me to have sex during and after my treatment? As well as the other questions listed here. It's also helpful to start conversations early with your partner. Although it can feel uncomfortable, sharing your worries and your fears can make you feel closer and reinforce that you're facing these challenges as a team. When starting the conversation, you may want to consider the time and place. Make sure your partner feels heard and speak honestly and openly. There's no right or wrong way to deal with changes to your sexual health. The important thing is you find what works for you. Thank you for joining. We hope you're able to better manage your disease by understanding how sexual health impacts prostate cancer.
So before we get to our next presentation, we, the PCRI, are going to take a moment to honor somebody that's very important to the prostate cancer community. His name is Howard Walensky, and we're giving him the Harry Pinchot Award. Now let me take a moment to explain who Harry Pinchot was. He was really the original founder of the helpline that we have here at the PCRI. You know, people can call and get their questions answered, and we can help build up their education on a more personal level so that they could have better outcomes with their medical team. It's not advice, it's information. But what Harry did was when he met our founders, Dr. Mark Scholz and Dr. Stephen Strum, he went to the UCLA library. He basically immersed himself in prostate education as a patient himself, and then decided that he was going to turn his personal journey, which was actually quite difficult with prostate cancer, into something that he could give back to the community. He could, really build out education for patients. He could share experiences and have other men talking to each other. And this is really before the internet was a mainstream source of information. So Harry was able to help thousands of men through our helpline, and our helpline still continues today. He is, in my book, a prostate cancer legend. He was Helpline Harry, and he died from prostate cancer 13 years later. But from the time that he decided that he was going to dive into that library and to learn, and by the time he passed away, he helped thousands of men learn about their disease and have better outcomes. Now, very similar to Harry, the person that we are honoring today is Howard Walensky. Howard was a journalist, and Howard always had a lot of tenacity and a lot of passion, and he's extremely smart, but he knows how to research. So when he got prostate cancer, he decided that he wasn't just going to go with the normal run-of-the-mill, system. He was going to research his options, and he did. And because of that, he ended up going on active surveillance and became an active surveillance advocate. But the thing about Howard is he not only had the tenacity to kind of go against the norm, he also had the tenacity to tell other people, hey, this is the information you should know to have a better outcome. Howard has taken his entire life and basically been a, passionate advocate for prostate cancer patients all around the world, and he's still doing it today. He is an incredible person. He's extremely funny and talented. He runs a active surveillance blog called The Active Surveiller, so if you would like more information, you can check that out, and I'll put it in the description box below. But Howard is somebody that the PCRI is honoring with the Harry Pinchot Award. He was nominated by other people in the community, so other prostate cancer advocates. And today we get to share just how incredible Howard is. So you're going to see some of the headlines, some of the amazing work that Howard has done, whether that's in the AUA, whether that's through his blog, whether that's working with ASCO. He is advocating for patients. He runs webinars where he gets the top experts in their field to answer patient questions, and he keeps it very realistic, and he keeps it very down to earth, and he just explains really intricate things very simply so that we can all understand. I've learned so much from Howard, and I'm so excited that we, the PCRI, are honoring him today, and I invite you to honor him as well. So today, here we're going to have Dr. Moyad and Dr. Scholz and myself give him his award, and I'm very excited that we get to do so.
Well, thanks, Alex. When Alex told me I had been nominated and selected as the recipient of this award for advocacy from the Prostate Cancer Research Institute, I experienced a rare moment. I had no words. And in fact, I've kept my mouth shut about it for months. So you brought a lot of silence with this. Now, I didn't get into the support, quote, business, end quote, for the glory or recognition. And I'm happy to receive some, but I didn't do what I did alone. I can name several people who I think are as worthy of receiving this award as I am. And I have to say that with this award, I am coming full circle back to Prostate Cancer Research Institute. I had originally come from a place of anger. I nearly underwent an unnecessary prostatectomy because of a Gleason 6 lesion. And back in 2010, almost 13 years ago, I like to say this is my pros mitzvah, I was urged by a doctor, by a urologist, to undergo either surgery or radiation. And I had already done my homework. I knew there was something called active surveillance, but only 6% of the men back in 2010 opted for that. So I asked this doctor about active surveillance, and he said, no, he didn't support that modality. So lucky enough, I found somebody at the University of Chicago, Dr. Scott Egner, to put me on active surveillance. But thing is before, in the midst of all this, even before I got diagnosed, I encountered a book called The Invasion of the Prostate Snatchers. The book came out in August 2010. It was almost as though it was published just for me. And the book kind of helped me frame how I was going to attack this problem where I was being scared into treatment, as it turns out I didn't need. And so I'm grateful to Dr. Mark Scholz, co-founder of PCRI, and his patient, Ralph Bloom, co-authors of the book, The Invasion of the Prostate Snatchers. Dr. Scholz's book showed me a path to active surveillance. And through a series of other things, I advanced along this path. After I was diagnosed, I started a Facebook mini blog about my experiences as a patient. And as a result, I started hearing from friends, brothers, fathers, friends of mine who were going through the same rigmarole and were looking for some guidance. And, I'm not a doctor. I didn't pretend to be a doctor. I was a medical writer. And I told them about my journey, and I hope it helped. And as a result of that, one of the lurkers in my blog was the editor of MedPage Today, the founding editor, Peggy Peck, who was an old friend of mine, and she invited me to do a column called A Patient's Journey. And I started that in 2016. And next year, I was invited to speak to the American Society of Clinical Oncology's Genitourinary Cancer Symposium. So that was 2017. I was the first patient given that honor, if you will. Trouble is they forgot me on the stage, and so I got pissed off again. And I wrote about it. And Throne Thorvaldsson, an attendee from Iceland of the PCRI conference, heard about me from other patients. I was part of I guess you would call an underground. People realizing that they could stand up and speak for themselves. Throne and I decided that we were going to start a group that we called Active Surveillance Patients International. And again, you don't do these things alone. And we did this with Mark Lichty and Gene Slattery, two other active surveillance patients. At any rate, I'm honored today, having gone full circle with PCRI, to receive the award and named in the honor of Helpline Harry. And I appreciate being recognized for my advocacy for active surveillance and low-risk prostate cancer patients, and also through my newsletter, theactivesurveillor.com.
So we're sitting here with Dr. Mark Moyad and Dr. Mark Scholz and Howard Walensky. I'm so excited that the PCRI gets to present this to you. You have had such an incredible history, not only advocating for yourself, but for so many people. So Howard, we heard your speech and we really appreciate everything you said. I mean, we're just so grateful, aren't we? I mean, we really appreciate you, and it's an honor to be able to give it to you.
Well, as I said, we stand on the shoulders of giants, and I consider Scholz, the Scholzes and the Moyad giants. I still, I'm sorry I can't be out there in person. I'm stuck in Chicago. I just started graduate school a couple of weeks ago at the University of Illinois for working on an MPH of all things. I don't know if I'll finish it. I wrote an essay to get in, and it's why I want an MPH before I turn 80. So,
well, can I say something? I think there's no one better deserving of this award. And I decided to make you a sign that I was going to use during the Q&A of the conference, but instead I'm going to show you early. It says the Active Surveillance Howard Walensky Club. So I'm going to change Active Surveillance, the words, and I'm just going to call it the Howard Walensky Club. And I always said to people that you're an educational tour de force. So if anyone ever steals that, I told Alex that years ago when we had the conference in person. If anyone ever takes that, I get royalties because I was the first one to say you're educational tour de force. You've been a card. Everybody should carry this card. You've been a card-carrying member since when of active surveillance? Can you remind me how long you've been a card-carrying member?
Well, in December, I celebrate my pras mitzvah. It'll be 13 years.
So I mean this sincerely. And there's a lot of discussion at this conference of possibly renaming Gleason 6 and all of this. And all I tell people is, look, first you got to join the Howard Walensky Club, which means you have to make sure, and I think you've done a really good job of this, you have to make darn sure that you have all the check boxes and criteria to actually join that club, because it takes some criteria, and it's getting longer and longer, to know that you're actually in that club. So I just, look, I don't want to sound too much like an Academy Award winning speech here, but I mean this. I mean, what you've done, not in active surveillance, but just raising awareness. I think you're the definition of advocacy. And so I couldn't be happier that you're getting the award, and I couldn't be happier that you're getting an MPH. So just to remind everybody, an MPH is the greatest master's degree in the world. It's a master's in public health. Now, I was humbled long ago with my son when he said, does an MPH mean miles per hour? And I said, no, it means Masters of Public Health. So sometimes you got to remind people that what degree you're getting. But I'm excited you're getting that degree. I'm excited for you in general. And thanks for everything that you do. I really, really mean that.
Harry Pinchot really showed us the way. When the PCRI was founded, he was the first employee. And he spent hours in the medical library figuring out what was best for him and what was best for other patients with cutting edge information. Active surveillance, sadly, has been on the cutting edge now for 15 years because of its glacial adoption in the medical community. And you've done a huge service in bringing awareness to the fact that this is an excellent option for many men with prostate cancer. So we're very grateful for what you've done, and we're so happy to honor you with this reward.
I appreciate it, but I mean, I have to say again that you were holding my hand in the beginning with your book. And without you and Dr. Egner at the University of Chicago, I mean, it wasn't until I went to your meeting in 2017 that I met anybody else on active surveillance. So, I mean, so I'm accepting this, but I'm giving it back to you. So thank you.
So, educational tour de force, Howard.
Well,
I'm telling you, just keep that column going and everything. I just, that's the power of advocacy. I can't say it enough. It's the power of advocacy.
I appreciate what you said. Dr. Klotz calls me what does he call me? Force of nature. So similar sort of thing.
No, I like this better. Forget Klotz for a second. This is a better tagline.
Hey, I call him the legend, my legend in every email. I think my tagline.
Legend's third or second, Klotz is second. Educational tour de force is impactful. That should be a movie name.
We need to put that on the activesurveiller.com, right, Howard?
The membership card? Well, yeah. Email it to me.
I will. Well, Howard, thank you so much for being with us. I know we couldn't be together in person, but Zoom is definitely a good solution here. But we really appreciate you. I'm so glad we got to get, the ability to do this with you, and we got to award you finally after all this time. Many, many people nominated you, and they're very happy, alongside me and Dr. Scholz and Dr. Moyad. So. Next up, we have our Q&A session with Dr. Mark Moyad and Dr. Mark Scholz. Dr. Moyad has done an awesome job moderating this conference, and we're so incredibly grateful to him, not only for his moderating, but the research that he's done and the clarity that he brings. I'm also excited to have Dr. Mark Scholz with him. He's the executive director of the PCRI, our organization, and he's a full-time medical oncologist who specializes in the treatment of prostate cancer for over 30 years. Now, together, we have the medical oncology side and the urology side, the men's health side and the private practice side, the university side. All of it is coming together to give us a unique view from two different vantage points on prostate cancer topics. And I'm very excited to hear what they have to say. So without further ado, here's Dr. Mark Moyad and Dr. Mark Scholz together.
Hey, Dr. Scholz, I want you to guess the theme of this year's conference, and I'm going to do that by showing my dog. And this is the first time we ever had him try human ice cream at Dairy Queen. There's a baby cone here. He didn't even know anything about ice cream. We decided, because he was such a good boy, we decided to give him one small cone and watch his reaction of how much he likes ice cream, and then watch me pull away the cone, and he wants to believe that the cone's still there, so he keeps licking. So watch this for a couple of seconds. This will make you happy. All right.
When Grazie's a good boy, he gets a cone. Yeah, vanilla cone, his first one from Dairy Queen. Are you happy with that, Grazie? He's still licking. How about some more? Yeah, you love Daddy now. You love Daddy now. Yeah, you're a good boy.
All right. Do you understand why this has importance to the conference?
I don't know. You're torturing us, I guess, because we're supposed to be on these stringent vegan diets, and you're letting your dog go wild.
No, you can be on a vegan diet. You can be on any type of diet you want, but at the end of the day, once in a while, it's okay to stray because quality of life also counts. Grazie Moyad, circa 2023. Everybody talks about. Even today, when I go to dinner, everyone's talking, how can I live to be 100? I don't know. If I knew the answer, I'd share it with everybody. But I just wish we'd have more discussions. And I think this is kind of emblematic of the PCRI, that quality also matters. So if you've been really good, you've earned the right to be bad once in a while. If once in a while you want to stray and have an ice cream, big deal. I get nervous about people following a strict set of rules and they never deviate from those rules. And I find that to be very stressful. So I thought my dog taught me. That's the only ice cream he's had in 3 years. I thought my dog taught me what our theme is today and the rest of the conference, which is we're always going for quantity, but quality also matters.
Well, I think it's a wonderful way to illustrate that. I do. Perhaps you've never struggled with sugar addictions the way I have. So just having one potato chip is quite an art. So there's a balance there in allowing myself to indulge in Cinnabons, ice cream. It seems that if I am completely apart from it, I somehow can stay apart from it. So I don't mean to get too deep. I know you want to illustrate the quality of life theme, and I'm just talking about my own personal failings. But and I appreciate your making that a theme for the conference. I think that is the hard thing for people to conceptualize when they're afraid of a possible early demise from something called cancer, and that is. It seems very abstract, and it seems sometimes like you're not taking cancer seriously when you emphasize quality of life. So good emphasis, and we'll be returning to that same theme, no doubt, throughout the conference.
Yeah, no, I appreciate that, because it's also, when these treatments are very harsh. I always say that if someone doesn't think hormone therapy is difficult to go through, just give yourself hormone therapy for a couple of months and see how you like it. So the truth is, we're always striving for quality, and whether you're in terms of preventing and treating side effects. And I think that's an art also. And I just wish it would get more attention, because the goal is to get quantity with quality and vice versa. And my dog had to remind me.
Yeah, let me jump in there that they are not mutually exclusive. It's not an either or thing. Perhaps exercise illustrates that best, how when people exercise, they will live longer. That is a scientifically proven fact, but you will feel better too. And,
that's right.
And that it comes at a price, but it definitely improves quality of life. And there's a lot of things that, if you think of things that delay mortality, by extending life, you're improving quality of life as well. So it's not an either or thing, but if you're just thinking about quantity only and just throwing caution to the winds to say, cut it out tomorrow, survival at any cost, you're making a big mistake.
Some of the most stressed people I've ever met in my career are absolutely hyper focused with wanting to live to be 150. And I look at them in present day and I'm going, well, you can also live right now, living now. But, a good example that they're not mutually exclusive is if you hanging out with me. With you hanging out with me during the Q&A, it's clearly extending your quantity and your quality. Had you not been hanging out with me during the Q&A, both of them would suffer dramatically, and we don't want to see that happen.
Well, let's see how this ends. We won't boast at the beginning, Mark, but if we finish strong, I'll agree with you.
Okay, just so you know, I've got my decaffeinated green tea, and so I'm doing well today. I know it looks like a urine sample, but it's not. But it's decaffeinated green tea. So I'm ready when you are. Let's get this party started.
Well, of course, first thing we want to do is be so grateful for the amazing speakers that we've had and how brilliant and wise and timely and hardworking they are. And it's evident just seeing the presentations. And thank you also for bringing out that character and the specialness of each one of them. And it's fun to go back now and cherry pick some of the high points and talk just a little more depth about the things that caught yours and my attention during these presentations.
Okay.
I think we'll start off with Dr. Mulhall. We're so glad to have him back after a number of years. One might argue the preeminent sexual recovery expert, perhaps in the world, and passionately dedicated to his craft, running a huge clinic at Memorial Sloan Kettering that tries to help men restore their romantic life, or at least maintain it, recover it. And there's so much to cover, and his candidness about a very personal area of our lives is much appreciated. It's something sometimes a little difficult to talk about. It's very personal, and it's a high stakes thing. He had endless useful comments. A couple of things that came to my mind. You can share your thoughts as well. One, he several times repeated the phrase, "You're only as good as your last erection," and I think what he's doing in that short phrase is helping recognize the psychological component of sexual activity. It's sometimes talked about very mechanically. You take a pill, you take a shot, get erections, everything's fine. But the higher levels of the quality of your relationship, creating space for this, finding libido. We didn't talk about that as much. The hormone treatments that you mentioned before completely eradicate libido. Libido distinguished from potency. Libido is the interest in sexual activity. Potency is the ability to get an erection. I think the one I'd like to turn to is the issue of injection therapy to recover erections after treatment for surgery. And I think this is a hugely neglected area. And his policy, of course, is he's giving people Cialis and Viagra right after the surgery. We all know that it takes a while for men to get erections back after surgery, if they're going to get erections back. And so if he doesn't see these men getting erections within a couple of weeks after surgery, he starts them on injection therapy immediately.
I want you to repeat that, because I made him repeat that, because there's not a week that goes by I don't talk to a friend or somebody else, patient of a friend, or you name it, and they don't understand that the threshold is that low before you start injection therapy. Can you repeat what you heard again, please?
Yeah. So after the surgery, if Cialis and Viagra aren't bringing erections back, and they usually aren't, it's time to start injections into the penis a couple times a week so that erections can be created, so that the muscles don't atrophy during this shock period that can go on for 6 to 12 to 18 months after the operation.
Yeah.
And during that shock period, if erections are not stimulated in some fashion with this type of methodology, there's going to be atrophy, and the recovery rates are going to be much lower. Obviously, this should be told to people before they have surgery, so they should be forewarned that this will be part of the recovery process for everyone that doesn't recover immediate erection function within a couple of weeks after surgery. And how often does that happen? I mean, you and I both know that that's pretty uncommon. I would say that 5-10% of men may recover erections within a couple of weeks. Most men are going to need injection therapy.
Yeah, I thought that was critical. He was talking about he was talking about weeks, just weeks and weeks after taking the pill. I know there's some different protocols, but you're not supposed to wait 6 months, 9 months. You're not supposed to have this conversation 12 months. You know, in my dream world, when men are being consulted for radiation and surgery and ADT, they should be talking about penile rehab before the intervention occurs. And they should walk them through this. What are my lifestyle options? What are my over-the-counter options? And then what are my pharmacologic options? And when are we going to start these? And if A doesn't work, when are we going to use B? If B doesn't work, you know, I don't like this philosophy, and you know either. We'll cross that bridge when we get to it. Man, that quotation makes me wacky.
That's
like, no, why don't we just cross that bridge right now? Why don't we expect the best but plan for the worst?
So let's talk about an even higher, a more challenging situation, and maybe one that I'm even more involved in as a medical oncologist who can give hormone therapy, testosterone blockade. Imagine the difficulties you have in men that have no libido, have no interest in sexual activity, who are also not getting erections. We put all these men on Cialis, and we hope that the nighttime erections that keep everything functional are happening, but in many cases they are not when people are on Lupron and these medicines. And it's certainly prudent for people that have hopes of regaining their romantic life after the treatment wears off, when their libido comes back, for these people to be doing injection therapy as well. And it's a very high bar for these people because they don't have a libido. I mean, they have to intellectualize, project into that future day when they're going to care again about their romantic life. Very challenging, very difficult, but I think it needs to be mentioned that many of these people should probably be getting injection therapy once a week, twice a week to get erections. They don't have to be sexually active. They don't have to have intercourse. It's just a matter of making the muscles do their job.
Yeah, I find it interesting that if anyone has a neurological insult, and you know, treatment is a neurological insult. If anyone has a neurological insult anywhere in the world, it could be a boating accident, it could be a football injury, you name it, there's immediate talk of rehab. There's always but when it comes to the penis and it comes to that area, it's kind of like giggle, giggle, but we're talking about neurological insult. Now, the second reason I was always trying to push Mulhall is that we're starting to appreciate that these wires cross between erectile function and continence. So preserving your neurovascular bundles, preserving your neurovascular area down there, not only can pay off in the area of erections, but can also help potentially with continence because there's crosstalk. And so sometimes people will say, well, I don't want to do the injections, I don't want to do the pills, but I don't know anyone that wants to be incontinent, right? So I think that has to be appreciated too. The other thing that I had to ask him, because I don't know that a lot of men knows this and their partners, is that, you know, when the average person takes Viagra or Levitra or Stendra, they take it and then there's psychological, you call it, there's visual, or there's manual stimulation, and then that forms an erection. What people have to appreciate is that if a man's taking a pill for penile rehab, it doesn't mean he has to have sex 7 days a week when he takes the pill 7 days. He just takes the pill and it helps blood flow down there. So I can't tell you how many times someone did penile rehab and said, well, we just don't want to have sex 7 days a week. And that's how the drug works. And you know, you try to go, well, no, in this case, you're just taking the drug like you're taking an aspirin or a Aleve. You're just letting it do its thing. You don't need stimulation for that. The rehab is separate from that type of thinking.
To make it really clear, what you're saying is correct. It's we're not trying to stipulate intercourse on a schedule or anything like that. But most of us guys, either known to us or not known to us, are getting erections at night while we're sleeping. And this is God's exercise program, so that the day that you're out, do want to be sexually active, you're functional. And that nighttime erection pattern certainly disappears after surgery, and often disappears for people who are on Lupron and hormone medicines. So the absence of any exercise is what we're trying to counteract. So people don't have to, in fact, may not be able to have orgasms, have intercourse. But at a minimum, if they're hoping to get their romantic life back in the future, they need to manufacture erections at least once or twice a week. I think Dr. Mulhall recommended twice a week.
Yeah, and the other thing that I told him too is that we have to appreciate that taking these pills are great. They help in a lot of things. They help with perfusion and increasing blood flow in a lot of areas of the body, probably the brain. We know definitely the lungs. And so that's all fine and good. But the FDA never approved any of these drugs, including Viagra, for libido. It was to make your equipment work better, but it didn't help you want to use your equipment more, right? So
Right.
one of my favorite studies I had to review, then I've lectured on for 10 years, is there's been multiple studies now showing when men take Viagra and exercise versus men just take Viagra and don't exercise, they see a dramatic difference. And the dramatic difference is the drug not only works better when they exercise in general, but they get that libido impact with exercise, which the drug doesn't give you. So I used to always joke around when you and I would have coffee or behind the scenes at the PCRI, I would say, you know, in the days where Viagra was making a lot of money, what they should do is they should give you a prescription along with the treadmill. And then people would stay on their drug longer. And, you know, I was kind of tongue in cheek, but I'm sort of serious about that.
Yeah, well, I'm glad you brought this topic up, Mark, and I think you might be able to give a few insights for the our listeners. That is the other component. You're able to get an erection, and of course, when you're on hormone blockade, you have no libido. And as we get older, people's libidos go down, and having had previous hormone therapy can leave people with a lower libido even after they get their testosterone back. For us, of course, in men that are running low testosterone and it's time to end the hormone treatment, we will give some testosterone. Testosterone is the engine of libido in both men and women. Sometimes we refer spouses of our patients. So our patients recover their libido, but their spouses are postmenopausal and they're not really that interested in sexual activity. So I typically say Google for a bioidentical hormone doctor in your neighborhood. And there's creams and whatnot that women can take. And often it has a small component of testosterone. So testosterone is the easy thing. But there are people who have normal testosterone and still have a low libido. Is there something that you counsel? Are there any other pharmaceuticals, herbals, things besides, you know, a lovely candlelight dinner with, you know, what are the resources that people have to say, hey, I can get an erection. My wife's interested, but my sex drive just isn't what it should be.
Yeah, well, I mean, Mulhall's part of something called the Sexual Medicine Society, and if you go to their website, they have you know, we could take 4 hours covering this topic, but they cover a lot of these different options. But you know, libido is a funny thing, isn't it? Because I've had to review a lot of research too, where you think you're doing the right thing, but it's actually hurting your libido. So what I mean by that is a couple of the papers I've had to review in journals the past few years are people that actually listen to you and me, but they over listen to you and me. They exercise too much. And so, for example, a surprising impact on libido is for over exercisers. So people over exercise, we call it a energy sink. So it drains their energy. And so there's not energy applied to whatever impacts libido. Another thing is there's a couple of compounds urologists can take. One is prolactin. They look at a number of different blood markers to see if that could be impacting your libido and can they do something to help improve that overall. You know, we looked at
high prolactin could be a bad thing, and you can take a pill to lower it.
So to high prolactin, yeah, and what, you know, can we do something? Can you work with you? This is why seeing a sexual medicine expert like Mulhall is so critical, because it might all come down to libido. This and we discussed this. The whole idea of testosterone replacement therapy, although personally, I think it's $1 billion business that gets way too much attention, so embellished. Everybody's supposed to be on testosterone. Give me a break. So the obesity epidemic and the diabetes epidemic is riding the heels of the testosterone. And those are the two greatest killers of testosterone in men, diabetes and obesity. In fact, the last paper I reviewed for doctors was yesterday. It was a meta-analysis on the top 10 things that impact your testosterone. Clearly, number one was BMI, was just carrying more weight. It by far and away has the greatest impact of bringing your testosterone down. Number two was diabetes. Diabetes clearly inhibits or has an impact on testicular function and producing testosterone. That was number 2. Number 3 was just older age over 70. Number 4 was being treated for cancer. And then 5, 6, 7, 8, 9, 10, you could argue back and forth. But you need someone who's going to walk you through this checklist to see how you're actually doing, because sometimes we're doing too many things right and we're overdoing it, and that's also impacting drive. But I think you bring home the key point, which is
it's a deep subject. Yeah, it's
deep,
and that is something I think that people need to be aware. Thank you for the referral to that website and the resources that are there, so that people know that there's a stepwise process that you go through to figure out, is it because I'm taking an antidepressant medicine? There's a variety of different things that can cause our waning libidos as we get older to get even weaker and weaker. So
so let me answer the question that you originally asked me, which I still believe that bringing your heart disease risk and being as heart healthy as possible is being as libido healthy as possible, but also in moderation. The reason I mentioned the exercise thing is because in the days of where I used to do triathlons, I can't do triathlons anymore because PCRI works me like a dog. So I don't have time. I don't have any life anymore, but that's a whole other argument. What they did was they looked at the Ironman triathlon in men, and they found that people that were doing this excessive amount of exercise, a number of them were becoming hypogonadal temporarily. That when you were being that excessive in terms of exercise, they've also looked at military boot camps, that somehow the body responds with a huge drop in testosterone, just like with when you gain weight. So I think you should be as heart healthy as possible to help your libido overall. We've been looking. The place where I might differ a little bit with all the experts is that I think the over-the-counters look interesting. And I don't think they should be negated just because they're over-the-counter. They might have quality control issues. We've already talked about how to get around that, and now you can look for quality control. We looked at Panax ginseng when I was in Korea. I had given lectures in Korea several times. Some people use it there in urology for libido. I think if there's something over the counter that's a clean product that you work with your doctor that may have a quote unquote libido effect and is not going to encourage tumor growth, of course, I think that should be looked at. Because it's so comical when I talk to some physicians that say, well, that's over the counter, that's not regulated. And I always like to remind people that some of the biggest selling over the counters in the United States are prescription drugs in other countries. It's all perception versus reality, right? So melatonin is a prescription in Europe that sells very well. So my point is, just because it's a dietary supplement doesn't mean it's already off the table. That's ridiculous. There's another supplement called citrulline I've written about for over 10 years. Citrulline's converted to nitric oxide, and some people use it. In fact, UCLA published a paper several years ago, and I have walked through with some of their doctors that part of their penile rehab program in going into surgery was not only doing everything Mulhall said, they were also taking L-citrulline. And then when they looked at the group that were doing all those things, including the dietary supplement, which can be of low cost, they found that they were doing better with the supplement than without in terms of erectile function. So part of the message today is ask your doctor about what's the latest and greatest. I brought up something with him that I think he was surprised, but I'm glad. I like to keep people on their edge of their seat. So I brought up a compound called Eroxon, E-R-O-X-O-N. And this is a gel, and by the end of this year, it's going to be available over the counter. And he was part of the consulting with this. It's called Med 3000. It's not cheap, but it's a gel you use for erectile function. And there are patients starting in 2024. This is going to be available at all your pharmacies over the counter. They're going to be asking doctors, can I use this Eroxon Med 3000? He thought it worked okay. I don't think he was blown away by it, but he clearly sees it as a potential option, and it's over the counter as of the next few months. In fact, I know people who are ordering it overseas, and I'm not encouraging people to do that. They're paying a lot of money. We have to wait and see how this happens, but they have a couple trials. It's called Med 3000 Eroxon. I don't work with any of these companies, but I think it's an exciting area. It's an exciting time over the counter. What else did Mulhall talk about that we should talk about?
Well, it should be exciting if we're talking about sex, erections, libido. I think in your response, it's easy to see how we can't really separate erections and libido. When I first started talking, when I got into the urology space, talking about sexual things was a brand new thing to me. And I was a little surprised. This is back in the 1990s when men had had surgery, become impotent, and And I discovered that when men were impotent, they didn't want sexual activity. The sensory nerves that allow you to get all the delightful sensations with sexual activity do not depend on erections. But men were basically embarrassed or insecure or whatever, and 90% of the men, because they were impotent, would not get involved in any sexual activity of any kind. They just withdrew from it completely. And so we're talking about the desire to have sex, the ability to get erections, as if they're separate things, but they are very closely intertwined, because of the way men conceive sexuality is through intercourse with an erection. And that's why I think that as we jumble all these different moving parts together, that it really does come back to that if men aren't functional, most are not going to be sexually active. So shots right after surgery, no brainer. Shots during hormone therapy, probably a prudent idea if you're going to be on it for more than 4 to 6 months. All right, let's
but I'll tell you the one thing he was not a big fan of, but some people like it. So I don't know. I love them, but doesn't mean once in a while I don't want to say, hey, why not? The vacuum erection device, some people like the VED, and I understand it brings mostly venous blood in, and it can be an unnatural erection, but it's been there for a reason. And some people just don't want to get too invasive, and that's their choice. So we didn't really talk much about.
He's concerned because you're not getting any muscular activity. Right. But you're right. You can get functional erections and allow you to have intercourse and have restore your relationship.
Yeah, so I think that's important. And low intensity shockwave therapy, we're just kind of watching, and you can talk about it. I also brought up, it's tough for him because he's in this position of power and authority, and he can't go too off kilter, right? I mean, as we move up in the world administratively and with responsibilities, we try to keep it PC. Right. There was all this excitement with stem cell, and I felt like he was still excited about the future of stem cell. So he thinks that people should still be asking about it, and he thinks it might develop. So I was actually surprised how optimistic he was in some of these futuristic potential options coming up, and I thought that was nice. So anyway,
I wish I could share that optimism. Of course, he sees 100 patients for every one that I've seen, but so far, and I don't know if you've had clients that have either gone through shockwave or stem cell that have come out of that and said, "Hey, I'm really a lot better now." Have you had clients like that? I haven't.
I mean, the number of people that shout to us in the PCRI that have been blown away by it is, I don't want to say slim to none, and slim just left town, but but the reality is, I just think they haven't developed the protocol, even if it's going to work. How many of these cells do you inject? Where do they come from? It hasn't been tweaked enough to just want to get behind it. The other thing we have to admit is that I like to use these two words. It doesn't mean they don't work. A lot of these things are still a cash cow.
Oh, it's big business, and it's not cheap to do these things. And I think that kind of punctuates my sadness. I mean, if they were doing these on clinical trials and say, hey, we're in our learning process, it's not going to cost you anything, let's give it a run. But, these are kind of expensive interventions. And so, hey, I want to see some results for this kind of money. And I'm not seeing it.
Yeah, no, I think the fact that you're not seeing it is highly significant. I don't think a lot of people are shouting it. I'm seeing papers where there's a little bit of an effect, but you never know with those. But, we're going to find out soon whether or not any of those avenues are working. But the amount of cash involved is just unbelievable. It's also why I brought up with Mulhall. I didn't mean to do it, but there was this big trial called the Traverse trial. TRAVERSE, and everybody's been waiting on the trial to make sure testosterone replacement therapy is heart friendly. And even though it turned out to be one of the messages was heart friendly, it also had some minor concerns. But what he didn't bite on, which I think you would bite on, is I said, that the average man in the testosterone replacement therapy trials, the average man in that trial, his BMI was 35. And then the average ones that got the drugs approved were in their 30s. And people go, well, that's not surprising. And I'm going, but you're missing the point. The point is, what would happen if they just dropped a significant amount of weight? Would they get some of their testosterone back in their libido? And some people argue, well, they're not going to get 200 or 300 points. Well, maybe they don't need 300 points. In bariatric surgery, there are plenty of men in the literature that get a 100-point increase from losing that kind of weight. And that's enough to bring back their libido. Yeah. So I don't know. I just wish
I mean,
that,
I don't know if we're going to have time to talk. Maybe at the end, we'll circle back and talk about these new miracle weight loss drugs. We covered that pretty well in our last conference, but that really does open up that alternative. But let's go on and talk about Kurtzman, unless you have anything else on Mulhall.
I have one more, which you're going to love. You had to take physics in pre-med, right? When you were at USC?
I didn't do well, but go ahead.
Yeah, no, I looked at physics in a funny way. I just thought nobody really does well, so I need to study the most there because it's easier to do well. It was a weird way of thinking, which helped me on the MCAT.
Makes sense.
Poiseuille's law in physics. Learn it and love it. So what I showed Mulhall, as I showed him my straw from one of the airlines, this is a coffee stir. And he admitted that this is the size of the arteries that feed the penis. They're so tiny, they're much smaller than a coronary artery. Yeah. So his argument was cardiovascular disease shows up here and damages the penis long before it damages the heart. Yep. But what you have to understand is that comes from Poiseuille's law. Poiseuille's law in physics has a lot of things to say, and people can look it up. But the reason I love it so much is that when you see a straw this tiny, and if you are to double the size of the diameter of this straw or the radius, the flow, are you ready for this? The blood flow increases by 16 times. So there's a great experiment done by Harvard. It's on YouTube, I believe. It's a scientist showing 16 small tubes and then one tube that's twice the diameter of the 16 small tubes. And they drain a bucket. They both drain the bucket equally. In other words, the one straw that's a little bit larger than the 16 small straws drains the bucket of water just as fast as the 16. What does this all mean? It means when you keep this healthy and you allow the tissue to expand, to get larger by being heart healthy, by taking Cialis, by taking Viagra, maybe who knows if your doctor says you can take citrulline, by exercising, which increases nitric oxide, weight loss increases nitric oxide. You can thank Poiseuille's law or Poiseuille's laws. I can't, my French is not good. Because your erections will work better. Your body works better because when you increase the size of your straw, the blood flow increases to an exponential power of the fourth power, which is 16 times. Yep. Is that a beautiful physics equation or what?
I think I could get it now. Maybe I could get a B on that test.
That's okay. I mean, I don't know if Poiseuille is happy that I explained that his equation is related to erections, but
well, if you look at, I mean, for us and us Americans, half of us are going to succumb to some complication of vascular health, whether it's a stroke, a heart attack, peripheral vascular disease. So yeah, we probably need to start a PCRI for vascular health. We're going to save thousands of lives.
We'll do a Scholz, Moyad, Poiseuille's Institute. Poiseuille, I know my mom is just going to clobber me because I'm not pronouncing it correctly in French, but he was a French physics guru. And it really makes you appreciate that these little straws, if they can just expand to twice their size, the flow of oxygen and blood that goes to the heart, that goes to the leg muscles, that goes to the brain is profound. And that's why you want to keep them healthy. And I wish, see, had someone explained that to you in physics, you would have gotten an A, but someone didn't explain that in terms of sexual and overall health, so you didn't probably do as well.
Well, that is kind of frightening how tiny that thing is. I don't know. I might have a nightmare over that. But let's talk about seed implants. It's just as important. Okay. I'm very grateful to Dr. Kurtzman and Agarwal for giving us an update on the latest thinking. You know, seed implants have been around for 30 years. And at one time in 2004, it was the most popular way to treat prostate cancer in the United States. And then the robot operating machine came out, and then IMRT came out, which where the radiation therapists get $30,000 a patient to zap people with beams. And people forgot about brachytherapy. But the brachytherapists have continued to refine their technology and their techniques. And thank God there's a few holdouts, a few world experts, and you only need one good one. You don't have to have a whole school of them. You just need one.
Yeah.
And I thought the remarkable things about their talk, which I think is truly on the cutting edge of where brachytherapy is a couple points. Number one is that the seed implants can be used by themselves as monotherapy. There's a lot of hangover from pre-PSMA PET scan era, just 2 years ago, where it's always radiation and hormones, radiation and hormones. If if you do surgery so you don't have to do hormones. That is such baloney now, because it has been well established that the local control, the cure rates in the prostate, where the disease is now confirmed to be because the PSMA PET scan shows no spread, the cure rates are as good or better with radiation as they are with surgery. In fact, the comparative studies show that the best cure rates are with brachytherapy. And that's because the brachytherapists are able to crank the dose a little higher in the prostate because they're not beaming it through healthy tissue to hit the prostate.
Yeah, good point.
So the idea of effective local control, a one-day procedure, no need to add hormone treatment, and unless it's a very high-risk situation, no need for beam radiation either. So one-day procedure. So you're not sacrificing anything in terms of cure rates. And I hope that came through clearly in Dr. Kurtzman's presentation, that this is it's kind of my number one go-to treatment if someone has to have whole prostate treatment. You covered a little bit about focal treatment, which could be an even more desirable methodology where they just treat where the tumor is instead of the whole gland. But take-home message, you covered a little bit about the bounce phenomena in terms of monitoring PSAs afterwards. It didn't come up in the discussion that in the past, yes, we would grit our teeth if the PSA went up and we'd wait and hope, and then the PSA would go back down again in most cases. That problem has been solved. A PSMA PET scan can be interjected at any time and make sure there's no active or growing disease anywhere. So the ambiguities that are surrounded with a PSA rise from artificial radiation inflammation, so-called bounce or bump, can now be, all those fears can be assuaged by just doing a PET scan if you're really concerned to make sure there's no cancer anywhere. In most cases, there won't be. It's just a transient PSA rise.
Yeah, I got to give you credit. I hadn't heard of these guys, but then again, I just didn't think anyone was doing brachytherapy anymore. It's not that I didn't think they're not impactful, but when he said that he's done 7,000, I thought, man, where have you been my whole life? I mean, 7,000, that makes you an expert, but it just shows you. And he kind of laughed at my joke. I thought it was actually brilliant because it was my joke. I said, the word brachy should have a new meaning. Brachy means short, but it should imply to the short number of doctors that now do it, because of the financial, the reward's not there. And doctors have been honest about that, but it's so hard to find people that have done thousands that are still actively practicing. And so I was really grateful you found him. Now, he threw me a curveball. He brought his partner there. So it was like a 2-on-1 tag team event. It was like the World Wrestling Federation, let's tag him and get Moyad, tag him. I'm thinking, how am I going to deal with these two brachytherapy experts? But I felt like they were very honest. I felt as if the part we talked about, the people that have IBS or the people that have inflammatory bowel disease, I liked the fact that we touched on that in the old days, they wouldn't touch these individuals, but now some of them they can treat with possibly Crohn's and ulcerative colitis. And so getting into the weeds there, I think, was extremely helpful. I like that overall. I also like that he was honest about something that some people don't hear in surgery all the time, the dry orgasm. That, some people don't realize that they're going to have a dry orgasm the rest of their life. They're not going to make any more fluid, and the radiation does that to them too. So he was one of the first radiation oncologists or radiation oncology teams that just came right out and said that.
Oh, yeah. People need to be warned, as they do with all treatments. Another thing that didn't come up, maybe I missed it, in brachytherapy, you talked a little bit about how people that have pre-existing urinary problems, they should get that fixed first if they're going to do any type of radiation, brachytherapy or otherwise, beam radiation. But another thing is that the men with really big prostates, when you talk about the things where you start saying, well, maybe brachy isn't right for this individual, some men have prostates that are over 100 cubic centimeters. The average for someone in my age group in the mid-60s is about 40. So you start going up to 100 cc's, 150 cc's, whether it's beam radiation or seed radiation, that's a lot of radiation to a rather big area, and complication rates go up. So that is another partial contraindication to brachytherapy. I'm not sure it came up in their discussion. However, more and more, we are moving people toward focal treatment. When they have, with these great MRIs and PET scans and biopsies, we know that the cancers stay only on the left side of the prostate. Guess who's the best candidate for focal therapy. A big prostate, because you have a lot of tissue around that tumor where you can put a halo of protective, an extended field without having to encompass the urethra, the rest of the prostate. And so big prostates set up nicely with brachytherapy or brachytherapy in particular for focal therapy. So big prostate could be advantageous for brachytherapy if it's focal. But if it's a situation where they've got bilateral disease, the whole prostate needs treatment, that's one relative contraindication to brachytherapy or even radiation. When they start getting these really big glands, they start talking about taking hormones to shrink the prostate, to make it a smaller target, but it's problematic. And this is the one area where seed implant radiation, beam radiation might be a problem.
Yeah, no, that's a really important point. I think, I don't remember talking much about big prostates. I do. In fact, one thing I wish we would have talked about too is even if you have is there such a word, a semi-big prostate, that sometimes when you get radiation from the outside in, and a lot of people can't appreciate this unless they're told, or they get radiation from inside out, ultimately the prostate will shrink when you radiate the prostate, and it can shrink as much as 20, 30% or more. And so that's a huge advantage of radiation, I think.
Yes. So people after they have the radiation, their urinary symptoms will go up for a few months, and ideally, or a few weeks, month, go down. And then yes, a significant percentage of people will be left with fewer urinary symptoms as time goes on. There's a test at UCLA where they can look at how well your body reacts to radiation called Prostox. It's semi-investigational, but you can Google Prostox. And they can test your DNA and see if you're predisposed to poor radiation healing. So this is a very useful way for to find out if not only people with big prostates, but people who are genetically predisposed to slow radiation healing. Those are the types of people that you wonder about. It's been proven more, this test has been done more in beam radiation than it has in seed radiation, but it's still radiation and it's probably applicable.
You're never going to, by the way, I'm still kind of smiling because you used the word baloney. I've never heard you use bad language before. Baloney is about as close as I've heard you use bad language. So you need to take it easy. You've had too much coffee. I've never heard, baloney is, I always try to get you to use one bad word once in a blue moon, but baloney is as bad as I've ever heard. Well, you're never going to believe the happiest thing I heard from Kurtzman all day. You're never going to believe what he said that made me so happy. Let me set this up. When we were at our spring conference, I asked the experts, I said, listen, I know there's this thing called space OAR, this gel, right, that can reduce complications from radiation. It's an insert, right, this hydrogel. And I said, well, I've been reading a lot lately about this. I said this, you can go back on the tape, the hyaluronic acid. So hyaluronic acid is found in the human body. It's part of the extracellular matrix. It's used a lot. It's the goo that kind of can keep things together. It's used a lot, for example, in orthopedics where they give hyaluronic acid injections for osteoarthritis. So they have also, it has an established role in cosmetics too. So what he brought up, and it was in one sentence that made me the happiest, is he brought up Barrigel. So Barrigel is the new one. That's the hyaluronic acid injection or spacer. So now patients have two options. If they want to protect themselves from the side effects of radiation, they have the one that's been around for a while called Space OAR, and then they have a new one called Barrigel that's hyaluronic acid. And so now there's no excuse anymore not to talk about this subject of whether or not you qualify when you're going to get radiation treatment. That's what made me the happiest. Isn't that bizarre?
Yeah, you do have funny taste. But the, it's funny that doesn't come to mind anymore because I consider that so routine. It'd be kind of like, when you go in to have your seed implant, he mentioned they put you to sleep, kind of like for a colonoscopy. It's very brief and very, very effective. So we don't usually talk about that because it's just part of the protocol. But you do find there are many centers that are still not doing this. If you have one patient in your career who gets a burned rectum, so-called proctitis, which is a non-healing wound of your behind for the rest of your life, then you say, all my patients are getting space or Barrigel, period. So I don't even consider, of course, all the doctors that I refer to all routinely use this, and we don't even talk about it. It's just assumed that they will all be treated with this.
I know, but you live in La La Land. And I mean LA land. I don't mean that you live in some weird land. I mean, you have very educated patients. You guys are always cutting edge, sometimes too cutting edge. I mean, you have a lot of things that Michigan doesn't have, especially you have a lot more plastic surgeons than Michigan doesn't have. Sorry, that was
we need it more. We got a lot of sun out here.
So I talked to a ton of men and their partners who have never heard of this. I would be willing to take a survey of some practitioners and people watching this event this weekend, and they're going to say, what is Barrigel, right? And I am not saying who qualifies and who doesn't, because there's also some intricate decisions made of who actually qualifies. My concern is that the conversation doesn't even come up.
Yeah. Well, I appreciate your mentioning it. And the only people that aren't getting these, sometimes people have been through a previous treatment and we're doing a mop up. It's a sad situation. It usually means that someone picked the wrong treatment the first time, and that happens. Sadly, or maybe the practitioner wasn't on his best game that day. But in those people, there can be some pre-existing scar tissue between the rectal wall and the prostate. And the question arises, if there's any tumor cells in there, could this gel push the cancer outside the radiation field? It's a theoretical concern, and it's on a case-by-case basis. But on all our newly diagnosed, it's routine.
That's interesting. Remember, we go back to the theme, Dr. Scholz. Quality of life counts.
Amen.
For my dog. And so Barrigel space OAR, just the discussion is a quality of life discussion. Yep. So I don't know if there's anything else you want to talk about when it comes to seed implants. I know you're a big fan. You're a big fan of the HDR. The type of temporary brachytherapy.
I think it's good to mention in this context that the type of seed implant that doctors Kurtzman and Agarwal do, the permanent seed implants, it's actually the most popular and has been the most popular form of seed implants. But the other type of seed implants, so-called seed implants, sometimes I call them temporary seed implants, and people go, they don't. It's HDR brachytherapy or high dose rate brachytherapy. And it has to be high dose rate because the seeds are left in your body during a one-day hospitalization and then they're removed. And so it's a different methodology, and different practitioners have expertise in that type of methodology. I tend to look at the LDR treatments that Dr. Kurtzman and Agarwal do as a very straightforward, simple, one-stop shopping treatment for intermediate risk prostate cancer, favorable high-risk prostate cancers, localized focal disease. And I see the HDR, the high-dose rate seeds, for the patients that have more problematic. They'll come in, maybe they weren't getting screened properly, and their PSA is 40, and they've got seminal vesicle invasion and a large tumor, and you want to make sure you get a lot of punch. Those are the ones I kind of push toward, the HDR or the so-called temporary seeds. And these are really intense radiations, equally effective, and in the hands of experts such as Kurtzman and Agarwal, great results. Oftentimes, they're both effective. In fact, you can argue in many cases, even you look at the beam radiation options, they're very effective too. These are the distinctions between these different forms of radiation is not that great. It is, I think, a little bit better with seed implants, and it's certainly more important who you go to than what you do, because having high-powered radiation put in your body is a skill, and you want to go to really super skilled people. But thanks for mentioning that. There are actually two types. They've both been around for more than 30 years. Andy Grove, the CEO of Intel, 30 years ago popularized HDR radiation. He was treated by a guy named Tim Maid up in Seattle long ago, featured on the cover of Fortune magazine. And this alternative seed implant methodology is also available for focal treatment, just as the permanent seed folks can do in select patients that have unilateral disease and are interested in, which it's a somewhat more potency sparing methodology. That's really the last problem with whole prostate treatment. The idea of treating the whole prostate with surgery or radiation or Cs or whatever is for thoroughness and optimal cure rates. That's been the mentality for the last 30, 40 years. And it was a very logical mentality when we had poor scans and we were uncertain as to where the cancer is. Now we have much better technology, and we are able to see that when the cancer is localized in one area of the prostate, that we can start thinking about maybe just treating in the area of the tumor. Because when you treat the whole gland, it's an age-dependent phenomenon. If you look at, say, your average 60-year-old who's not taking any Viagra or Cialis, he has absolutely no issues getting erections, undergoes whole prostate treatment with a seed implant, IMRT, any type of radiation, there's a 1 in 3 chance that he's going to become impotent, and the Cialis and Viagra won't work. It's impotence in the real world. If you take you take a pill and it's fixed with Cialis and Viagra. In the prostate cancer world, we only define impotence if you take full dose Cialis or Viagra and you don't get an erection. Then you're on to shots, plastic implants in your penis, and other really dire issues. So this is the attraction now of moving from whole prostate treatment, when feasible, when people have unilateral disease, to some sort of focal treatment, because preliminary studies seem to indicate the risk of ED in a healthy 60-year-old will probably drop from about 35% down to less than 10%. So there's a big difference in the onset of erectile dysfunction when you don't have to treat the whole gland.
Why do you keep saying healthy 60-year-old? Are you trying to refer to me because I'm almost 60? Are you putting me in the equation? Because I'm old already. I'm old already. It's okay, but quality of life counts. That's what I say. But I don't want you to leave radiation yet. If you're repeating yourself, I don't mind. Because the question comes up at every conference. If you look at the questions, Alex looks at all the questions. I try to look at all of them, but I get tired and I need to take a nap. There's so many. And I appreciate that. But SBRT, right? Can you just talk about pros and cons of SBRT? Because SBRT, the reason it's getting so much attention is because you used to hear about 40 plus treatments. And then you hear about hypofractionation, 28 or so treatments. And now you're hearing about 5 treatments. Well, look, unless something's wrong with you here, everybody likes the idea of 5 over 44, right?
Yep. Oh, yeah.
So I know you're touching on that, and we're talking about HDR and all that, but can you just again give us a quick education?
I think it's very very appropriate in the context of you're mentioning Spacor and Verigel.
Yeah.
I was reluctant. When it comes down to seed implants versus beam radiation, I go toward the seeds because they don't have to beam the radiation through your healthy tissue to hit the target. Right. So that's a theoretical thing. You can't really point to big problems by that radiation. I mean, we go through CAT scans and bone scans and we do just fine. But that's just sort of a theoretical issue. But the practical issue, prior to the advent of those Spacor Verigel things that could move the rectal wall out of the radiation field, I didn't use SBRT. SBRT looks so cool, except for the fact that it had twice the incidence of proctitis because of the big dose of radiation. And that disappeared when we put the Verigel in or the Spacor in. So all of a sudden, it looks super convenient, very practical, and very effective. So who do I start thinking about? Well, maybe an elderly guy, a 75-year-old that wants to have his, is no longer sexually active, wants to get a whole prostate treatment, doesn't really want to go through a procedure where they put you to sleep. I don't like any kind of anesthesia in my patients unless you absolutely have to do it. So SBRT is very attractive. 5 visits over 10 days, very effective. So I tend to think of that type of an option, maybe if someone's getting a little older, doesn't want to go through anesthesia, doesn't want to go through a procedure, all outpatient and very effective.
Yeah, that's a good point. Good point. Okay, I'm glad. But, in summary, Kurtzman and Agarwal, I mean, they did a good job. I'm really impressed by the number they're doing. And so, and I think I was most impressed by their candidness. Whether I agreed with some of the stuff they said or not, at least they were candid about it. And even they were candid about which office could take them in faster versus their other offices. So all of that made for a good shtick. And I'm really glad they came on. I'm glad you invited them.
Yeah, they have, it's an unfavorable financial environment for the radiation therapists. Radiation therapists have a really good deal. They work, from 9 to 3 in the afternoon, and their technicians take care of everything. They get very well paid for beam radiation. And this has discouraged. They're all supposedly trained in brachytherapy as well. That's a form of radiation. But they all their skills atrophy quickly after training, and they just don't implement it because the beam radiation doctors get paid 4 to 5 times more than the seed implant doctors. Yeah. Now, a clever and entrepreneurial guys like Kurtzman and Agarwal, they say, well, okay, we're not getting paid very well, but if we have a booming business and we treat a lot of people, we can make a good living. And of course, it's good for us people that are thinking about getting treatment, because you're looking at people that are doing this day in, day out, practicing constantly and have excellent skills. And that's what you want in your radiation therapist, whether it be a beam or a seed doctor.
What percentage of your patients now are you doing by computer? They're not coming in to visit, but it's all virtual. Can
3 out
you
of
put
4? Yeah.
3 out of 4.
Yeah.
The reason I asked you that is I didn't know it was that 3 out of 4, really, because Kurtzman was telling me how many people now he just does that before they come in. That's their whole shtick, the whole thing. I thought that was kind of cool that if they're going to travel across the country or from out of the country, they do a virtual and they come in and get treated. And I thought, well, that's one of the positives of virtual medicine, right?
Yeah, a lot of the services that are being provided with modern prostate cancer care are cognitive services, educational services, and the old having to do finger exams. I mean, that came up in your discussions about digital rectal exams, and Dr. Cooperberg will get into that in just a minute. So, yeah, we don't have, people will need blood tests, but they can go to a local laboratory facility, and then we can receive the reports via email and save people a lot of travel time. It's very efficient. It's been one of the good things that came out of the COVID craziness.
Yeah, that's really interesting. Anything else about radiation? I mean, we covered a lot of stuff. It's kind of cool.
Yeah, I think, well, these are like the big issues in the prostate world. We've talked about sexual function recovery. We've talked about radiation, which I really think supersedes surgery. We won't go into that hot button topic. I know your dad was a urologist, and I want to respect that and not say really nasty things about surgery because I have so much respect for you. But now I think we can move on to the other really big issue.
Before we move on, I'm going to put in my disclaimer. Moyad disclaimer. I think surgery is as good as radiation. I think both options are good. Okay, go ahead. You think it just has to do with
that's been repeated for the last 40 years. And
thank God you have me around to provide you with some of that objectivity. So
it seems like I'm the only voice in the country, but mark my words. And that's
no pun intended. Mark my words.
Mark our words. All right.
I gave you a tennis ball during the conference. It says, I love the surgery. And I'm asking Alex that she brings this up during this back and forth. So let's give a quick pause, 5 seconds. Please, Alex, put in that picture of me and Dr. Scholz where he's holding up the tennis ball I gave him that says, I love surgery. The look on your face is clearly subconscious. You love surgery. I know you do like me. So don't worry.
I love surgery for people who need surgery. And there are a number of things, gallbladder, appendixes, knees, hips. Those are great options for surgery.
Come on, Grazie. He doesn't. I like radiation for people that need radiation. We know that, Grazie boy. Anyway, it's all about quality of life and choice. I think we agree on that.
Right. So which is, as we move on to talk about Dr. Cooperberg and his beautiful and interaction with you on active surveillance.
Yeah.
I was so thrilled with his balanced approach. It's really my place to say, is there anything that I would disagree with from him? And obviously he's just world class, and I'm reticent to disagree with anything just because I don't want to look bad in comparison. The only thing that I would say is a little different. They've started moving, as you could see, much more towards using MRI for monitoring people in active surveillance than regular biopsies. They do still apparently have a deep commitment towards something called a confirmatory biopsy, which means that after you've had a biopsy, it looks like it's good, that you should get a second biopsy to make sure that nothing was missed. And that's been around for 20 years now. And there's plenty of logic behind it until you consider how much more accurate the MRIs are. So I don't want to imply that I wouldn't be against a confirmatory biopsy if the original biopsy where it's showing where the cancer is, and the MRI don't match. So, so if you've got, there's a grid pattern in the prostate: apex, midgland, base, left, right, lateral, medial. So when they describe the biopsy, they say left lateral midgland shows where the cancer is. And then you look at the MRI report, good quality MRI. He wanted to emphasize, you got to make sure your MRI is good. You can have them overread at UCLA or UCSF, make sure they're good. Now you've got a good image that you trust. And it says also, spots on the left lateral mid. They match. I don't go back and re-biopsy those people. They've been biopsied. And the idea that random biopsies, sticking needles around here and there, is going to help get you closer to the truth. No, it's going to help find more low-grade disease and confuse people, a very principle that he was espousing. So, so that's my one difference from all the other brilliant, wise, experienced, articulate, wonderful information that was shared in that conversation between you two.
I wonder if his confirmatory biopsy speech was more so that he's seen a lot of bad stuff out there.
Well, I think it's a policy it's another layer to protect you. And if for some reason you don't trust your MRIs, you don't trust your biopsy people.
That's what I mean.
And they're seeing people coming in from all over, maybe there's been some slipshod work done somewhere. Yes, if things aren't matching up, the MRI says there's a spot in the left base and the biopsy is positive in the right apex. Yeah, you got to go back and biopsy the left base. You didn't stipulate in your talk with him whether that confirmatory biopsy was just a targeted biopsy of the abnormality or another random biopsy. I hope he didn't mean another random biopsy. I would just biopsy any spots that are seen on the MRI that don't match the original biopsy. That would be an appropriate role for a confirmatory biopsy.
Yeah, I mean, that's how I interpret it. But, in the moment, you have to also understand that maybe you know this, maybe you don't. A lot of times he does slides. Well, we got to the moment of his presentation. He goes, let's not do slides. You just ask me things. And I went, okay.
This is like our dream speaker.
No, this is our dream speaker.
About this all the time.
But he didn't inform me of his dream until we were filming.
Yeah, well, it's perfect. I thought it was so apropos.
No, but it was. But you know what? I was so hopped up. I was so energetic that day. I had done my running. Everything was good. My energy was good, and I just thought, let's do this, because I was just ready to sit back, and he was going to go 90 minutes, and I was going to go 20-minute Q&A. I was not ready for the Cooperberg going, I might show a couple slides. You just throw out whatever you want. And I just went, okay, let's make this interesting. So I just have to let the audience know that I didn't know that until we started filming, which is.
And the slides that he brought in were so apropos and helpful. I think that presentation is going to be a classic.
I think it will too. I also love printing out pictures of him where it says cancer surgeon, husband, father, runner, skier, music lover. I mean, this is what we do now. And then this is a nice picture of him. He's a public health guy, just like me. So let's reemphasize two other things. One, which I think is appropriate, his understanding of PSA screening. It's not really active surveillance, but there's some similarities between screening and surveillance. Yeah. And the idea that young men let's say young men, 45 to 55-year-olds that have PSAs over 1 should get an MRI. That's new, and I agree with that. Yeah, that was cool, wasn't it?
Yeah, that's why I said, new. You're not hearing that.
I tried to test his brain. I went, what about 0.9? Anyway, I'm making myself.
No, that's so that I would agree with that. It's just, and then you went on. You posed the question of, do we just do MRIs? Skip the stupid PSA. And he was reticent about that, and I'm reticent about that, because you're going to find stuff that I think I like the idea of the one very low threshold for the 45 to 50-year-olds. Then he said, you start getting them 60, 65, the threshold becomes 3. Well, that's lower than the usual 4 that you hear about. So that's a very aggressive stance. And the reason you can have that aggressive stance is that you don't have to jump into a random biopsy. You can do an MRI.
Yeah.
Thank you, Dr. Cooperberg. That was awesome.
No, I mean, he was one of the, I'm trying to find this other handout. He was a big highlight. I mean, he was just, and I was serious when I said that we need to continue this Q&A after hours. And he said, sure, because there was so much more to cover, you know, and yeah.
Well, let's go on to the next deep well, which was, so this is all you guys
is this within
really on the
Cooperberg?
cutting
Don't
edge.
leave me. Don't leave me. I want to stay in Cooperberg for a
No. This is more Cooperberg.
Okay.
So there's no harmless treatment. So you're going to take a hit, whether it's, you know, radiation or surgery or whatever. So since it doesn't spread, 3+3, okay, black and white, do active surveillance. You saw his statistics. It's still only 2 out of 3 men that get active surveillance. So about a third of men, maybe 30, 35,000 men a year in the United States have radical treatment for 3+3, a sad state of affairs. It's better than it used to be, but come on, this started 15 years ago. How long is this going to take? All right, enough about that. Let's talk about,
how do you feel about that?
Let's talk about
I just, if you brought it up, you brought up SAP, whatever that is. How do you feel about this idea that they're trying to change Gleason 6 into a non-cancerous call?
Makes a lot of sense.
So
you're perfect sense.
You're in favor of that.
Yeah, that word cancer. Oh my God, I spend so much time all day long telling patients this cancer ain't a bad one. It's a difficult argument. Anyone knows that cancer is bad. Lung cancer, bone cancer, brain cancer, pancreas cancer, these things are horrible. How can prostate cancer not be horrible? It's very difficult to explain to people how different it is.
So that's what I kept asking him. If we're not going to call it Gleason 6 cancer, what are we calling it?
Abnormal prostate growth.
Okay, abnormal prostate growth. Okay, so I don't know if you watched that exchange. I'm not saying I'm for or against it. That's not my job. I'm just saying I wanted to play devil's advocate there, that I don't mind that you change the name from Gleason 6 to non-cancer Gleason 6, whatever you want. I use the word the thing, right? But the reason why I think Howard's been so powerful, and I know he's a big fan of that, is my only argument is, and I want you and Howard to do more of it, that would make me happy, is that I don't mind what you call it, but I just want to know exactly what your criteria are year after year as to how I joined that club, because we got into the discussion of pathology.
Yep.
And all these pathologies.
That's where I want to go too. That's where I want to go.
Here's my fear. My fear is not whether or not we call it the thing versus cancer. I just want to know for sure that I made it into that club or I didn't. And what worries me today is some men think they're in the club when they're not, and vice versa, right?
Let's talk about that.
Let's talk about that.
Yeah, let's talk about that. So the really cool thing about what we call prostate cancer is, unlike other cancers, thank God, it's slow growing, slow metastasizing, easy to monitor, and treatment is highly effective.
Yeah.
So you've got layer after layer of safety nets that even if you don't do everything perfectly, you're going to emerge. In fact, you know, you say, why is prostate cancer the only cancer still managed by surgeons? We need cancer experts for all the other cancers. If it's just handled with, even by amateurs, things are going to generally turn out well as long as it's monitored. So it may not matter so much how well it's monitored, you know, the quality of the monitoring. What really matters is that it does get monitored, that people do PSA checks, they do get an MRI every year. And that, because the disease evolves so slowly, even if you screw up one year, you'll catch it the next year or the next year, and it won't have spread during that very extended time period. So what are the criteria that we use for even getting into the club? That's what your question was.
Yeah, and this, let me tell you, I'm not happy with this. I'm not saying I'm not happy with the criteria. I think all of us, you, me, PCRI, all the experts, they can do a better job of every 6 months updating the criteria. Because last I checked, the list is getting longer of what it takes to be in the club. It's not getting shorter. So
yes, thank God. It's being more inclusive. We're inviting more people into the club now.
We are, but if you don't know the club rules, you're going to run into trouble.
All right,
this is the problem I'm having.
Yeah, let's make it clear. It really comes down to two things: the grade and the amount of cancer. When you don't even get talked about in the club if you're concerned about something outside the gland. Okay, doesn't matter what the grade is. So with PET scans now, you know nothing's outside the gland. And so the issue, first and foremost, is the grade, the way it looks under the microscope to a trained eye, because it is an art to get the right grade.
Yeah.
And then once that grade is assigned, let's go to Gleason grade. So there's basically only 2 categories of Gleason grade that are routinely considered for active surveillance. We've already talked about 3+3. It's kind of a no-brainer. But now 3+4 is coming into the equation. 3+4 means that there's a little bit of grade 4, and yikes, that's the stuff that in theory can spread, and not in theory, actually in practicality can spread. And it's spread that defines the danger. If it doesn't spread, like 3+3, it's not dangerous. The gland can absorb an enlarging benign tumor, no big deal. But if it spreads, metastasis, that changes the whole picture. So grade 4, grade 5 can spread. So it turns out that studies are starting to show that small amounts of 4 have such a low incidence of spread that you can watch it. See, this is because it's a forgiving thing, and see if it's something that is growing or not, because it's going to initially grow in the gland, not spread. It's not going to jump quickly. It's going to initially grow, and you can observe that with annual MRIs. And if you see something that is growing on a continual basis, that warrants another biopsy, another targeted biopsy, to see if the grade is changing. And this is how the threshold is for treating people. If the grade becomes unduly worrisome, too much 4 starts to appear, you treat. So the reason it's a little confusing to outsiders is because the criteria for getting on active surveillance is to have 3+4 or less. The criteria for staying on active surveillance is the absence of growth over time. And so that observational thing is what separates the sheep from the goats. If it's just stable, then you keep watching. So the power of active surveillance is not only the ability to forego treatment right now, it's to use the natural history, the slow-growing natural history of prostate cancer to your advantage, to find out if you're in the subgroup of that has a variant that will grow or potentially spread someday by watching it, rather than just jumping in and getting rid of it when it may never spread or grow.
So that brought up all the talk of pathology and markers. And I know this makes people uncomfortable, but I'm just telling you, I sit on my prediction record. I might not know football prediction very well, except for Michigan football, which is the greatest football team in America, but disclaimer. But I am still, because you see a lot of advanced prostate cancer patients. You know darn well, when I first met you 15, 20 years ago, the average man with advanced prostate cancer wasn't being, for example, BRCA tested, right? They weren't looking for that mutation, BRCA1 or 2 or ATM or any of these others. So I've asked him again, and it makes people squirm a little bit, and I'm going to keep asking it. If active surveillance is a special club, and you want to feel confident that you're in that special club, then why isn't everybody diagnosed, just tested with some of these markers like BRCA, just to make sure that they can make the decision? I know what the counter argument is, and it's not good enough for me. The counter argument.
Let's talk about genetics. Let's talk about genetics in general. Important question.
Let me add B for you. Here's the counter argument. Well, it doesn't necessarily change things in the short term. That's not the point. I just want to know my genetics. Back to you. What's the downside of knowing my genetics?
There's several layers to the genetics. One would be, do you want to know if you have your genetic history, number one. Number two, do you want to know your genetics so that you can talk to your children and tell them about future risk problems?
Right.
You want to know your genetics because of, could you forestall or detect some other health problem earlier because you've been forewarned? And then do you want to know your genetics because it might help you guide whether it's safe to be on active surveillance or not? It's not a small club. Active surveillance, of the 200,000 men that are diagnosed every year, at least 100,000 are eligible for that. So it's not a high bar for getting into this club. So I just counsel people in terms of genetic testing is if you're comfortable possibly being told you have some deleterious mutation that you may not be able to do anything about, and you want to live with that reality, go ahead and do genetic testing.
Right.
In terms of monitoring for danger for spread of cancer in an active surveillance patient, the level beyond just doing Gleason score, Decipher was mentioned in your talk with Dr. Cooperberg. That's a type of genetic testing that's much more focused on predicting the future possibility of spread. Whereas BRCA does also show some prediction for the possibility of future spread, but it's not focused particularly on that question of whether it's going to spread or not, like Decipher, Prolaris, Oncotype, these genetic tests. Lately, I've become a little bit more pessimistic about these genetic tests, and let me explain why. The concept, of course, is very attractive because we all want to know the future with precision. And this is maybe one step closer to how risky this cancer is. It sounds like a very useful and practical idea. And they have databases that they've looked at over time with different genetic permutations that do show that this group of genetic changes has more likelihood of spread than this. That's great. The problem is that these tests are from men that were on watchful waiting 20 plus years ago.
Yeah, that's true.
And the testers, instead of just saying this is a more worrisome genetic thing, no, they go out and they say, so, you have a 9% chance of dying in the next 15 years. Well, that is ludicrous with modern technology, with MRIs, early diagnosis, PSMA PET scans, all this. So when I get these reports, and I have a very involved clientele, they look at these reports, they try and understand these reports, and then I'm explaining away how that we did a test on a database that's 20 years out of date, just because the overall milieu of the genetics is interesting and relevant, but most of my clients are not sophisticated enough to set aside those horrible prognostications, which were based on people that were diagnosed in England and put on watchful waiting and told, come on back if your bones start to hurt. That was what they called active surveillance. It's ridiculous.
Look I'm playing devil's advocate. I am not, you know me, I am not a fan of people running out and knowing their genetics in general, because it comes with a lot of anxiety. And then a lot of what we're telling people, it's not an actionable item.
That's it.
Right? You've got this X, Y, and Z gene, and you might have a higher risk of this, but there's nothing I can do about it. But I always found it funny in those cardiovascular risk and some other these genetic scores that will say, you have a higher risk maybe for a heart attack. You may have a higher risk for hypertension. And I'm going, well, shouldn't I try to be reducing my heart disease risk to as close to zero as possible anyway? So what have you really done for me here?
Right.
I mean, so I understand that the darkness of the genetics testing, I understand that. And I was just, and I think you've addressed it for the most part, I'm just concerned in the active surveillance realm that we're still concerned about where, like, for example, a BRCA goes if you were born with it, like a BRCA2, because now we're not only linking it to ovarian, breast, aggressive prostate. Now there's enough data to suggest it's playing in the area of pancreatic maybe. So if I'm on active surveillance, I'm trying to understand the argument of why I wouldn't be at least offered the test and what we know and what we don't know in this scenario. Because if I was an active surveillance patient that was BRCA positive, BRCA2 positive, for example, maybe I might want to be monitored more closely. Maybe I'll do something differently. But I want to reemphasize to our audience, just because you have a mutation doesn't mean that mutation is going to be expressed. The mutation can be there, but there are many different factors that express the mutation. That's why countless studies in prostate and breast for people that have mutated genes, when they take better care of themselves, it's less likely that that gene does damage. Now, of course, there's exceptions, but we're learning now that just because you have a certain set of genes doesn't mean you're destined to end up like your parents or a friend of yours. You have power over that. But I just go back to the question. I don't want you to leave it. I'm in active surveillance. I'm in the club. Shouldn't there at least be a discussion of a germline test for BRCA, or have I lost it?
No, well, let's bring us home. You and I, let's disclose our own personal. Have you been genetically tested, Dr. Moyad?
I have gone through a pretty extensive analysis for a reason. I don't
care if you have a reason. So I'm going to disclose.
But I had multiple deaths in our family from breast cancer very early. So nothing came up positive that was interesting. But I'm just saying that
even if you didn't have those things, it's such an easy test.
It's such an easy test. But a germline test, you have to go through the pros and cons. But, you know, staying within the Cooperberg realm, This is all the criteria that gets a little bit more complicated. So we also talked about the cribriform pathology, which I'm obsessed with.
Wait. So I've also been genetically tested, and I'm BRCA negative and all that sort of thing. I think that it's where they're to be tested for things that there may be an action item to follow it. It seems a little irresponsible not to do it. It's like we do colonoscopies. The lifetime risk of dying of colon cancer for Americans is 3 out of 100. It's not a high risk, but it's a preventable death, and it's a bad death. So you get a colonoscopy every 5 to 10 years. So to do the genetic testing, there's certain actionable, and you do take a risk of getting non-actionable diagnosed mutations. Right. That's you do take that risk, and people need to be explained that. All right, so back to your cribriform. All of these things, there's so many variables in the active surveillance, and the reason it doesn't come down to really sharp things is you can imagine doing active surveillance in a 55-year-old is very different than a 75-year-old. Multiple reasons. We do active surveillance for one primary reason, and that is to not risk the onset of erectile dysfunction from intervention, from treatment. If we had a treatment, and focal therapy is getting close, but if we had a treatment that could always get rid of the cancer and not cause erectile dysfunction, I think we just do it. It's simple. But that's not the case. And so we're always looking at that push-pull between whatever danger there may be associated with this cancer spreading and really ruining someone's quality of life, or undergoing immediate treatment and ruining someone's quality of life by taking their romantic life away. That's always the push-pull. And you can see how that changes over age. Some people they're no longer sexually active as they get older. So that may be less of a concern undergoing therapy. And then the risk of the disease, it's not like there's a threshold and all of a sudden you fall off. It's the risk of it spreading, more grade 4, larger tumor, cribriform, BRCA positive, multiple cores positive. And it's a constellation of how much and how bad does it look, and then how motivated are you to stay on active surveillance, and how practical is it to treat it and just get rid of it. So all 4 of those things have to be put in the equation, and you have a conversation, and you find out from people, what are their priorities and what is their risk tolerance? Don't they do that in the investment world to say, are you willing to have 20% drop in your portfolio over the next year, or is that going to end you? Other people say, I can endure that risk. Other people say, that's ridiculous. Okay, we're going to put you in government bonds. There's a different risk tolerance from patient to patient, and a sophisticated physician will go through these risks and help them understand what the risks are so that the client can make the decision.
Yeah. And I think that's what really came out in the talk, that, we need to look at all these variables, and including the cribriform. And I tried to make it like a pizza, that these introductals, these other types of aggressive phenotypes. And I think the reason I really am obsessed with it is not only because I thought I was going to be a pathologist and I was going that direction, but I'm just obsessed with the fact that we're learning about all these new important markers in pathology, which brings up the idea of a second opinion should not always be rare, but it should be common. Yep. And the other thing is, if I had a dime for how many, let's just talk friends, okay? Can we just talk friends? Because I'm at the age where plenty of my friends have had prostate cancer. If I had a dime for every time I read a path report from a friend that didn't even mention the presence of cribriform or not, I'd have a lot of dimes.
Or even percent grade 4.
Or even percent grade 4. I'd have a lot of
dimes. I see it all the time. Yeah, someone tells you have 3 + 4. How much 4? Is it 5%, 30%? Yeah. 50%, 49%. That's in my mind, that's the number one thing I look at. First, you want to make sure it's a quality path report. Second is, what is the percent grade 4? Yes. Third is, how many cores have glycine 7 in them. So let's say you have 10% grade 4, and you say, oh, that's pretty good. But you've got 5 cores with 10% grade. And I'm not talking about biopsying the same spot 5 times. I'm talking about distributed around the prostate. So what's the percent grade 4? I would say in the newly diagnosed patients, I see hundreds of new patients every year. I'd guess it 1 out of 4, 1 out of 5, the pathologist doesn't even mention percent grade 4, which is the number one thing I look at in a 3 + 4 to determine if it's safe to do active surveillance.
Yeah.
Amazing.
Yeah. So that's why the concept of second opinion has to be a common, like I'm saying. So, well, I mean, I think a lot of this came out. 2 other things came out. Do we have time to cover them? I know we're running late and we only have about 20 minutes left or so, 30 minutes, but because we still have to cover your talk and Kwan's talk, which you know,
I think both of those talks. No. Both those talks were so good. I don't really think there's anything further to say. I think
you mean the Scholz talk?
Yeah.
Oh, no, we have to go after that. We have to go after that. You have to be the piñata of the conference. We're gonna have to go after that talk.
Well, it'll have to be you because I was so impressed. It was.
No, it is impressive.
It was really impressive. There was no response. That
no, I know there'll only be my response. So I just want to talk about 2 more things that came up, and this kind of touches upon my pet peeves besides pathology. So when it comes to active surveillance, a second opinion on pathology from an expert. I mean, I think we agree.
It's a no-brainer.
It's a no-brainer.
Yeah.
You know, and what still shocks me is the cost of these second opinions. Wait, let me explain that. The shock in terms of how low cost some of them are, $100 to $200. Yeah. And so, you know, this to get an opinion from a pathologist is unbelievable. A second pathologist when you need it. The 2 other things I brought up with Cooperberg is I brought up a trial called the MEAL trial where people on active surveillance, it was a randomized trial. They increased their amount of mostly plants, but ate healthier. And after 2 years, they didn't see any change in their active surveillance. Just as many people came off of it for pathologic reasons. And so as of 2 years, the suggestion is just eating healthier. And that's why I talked to them about the weaponization of diet, that I just want people, when they sell diet, especially in active surveillance, the idea is we don't know in the end what it really does 10 years down the road with active surveillance. What we do know is if you eat healthier, the chances of you dying of competing causes of mortality or cardiovascular disease goes down tremendously. I think the goal, if active surveillance, is not just that you don't die of prostate cancer, it's that you don't die young of anything.
Right.
And so I was glad he put that in perspective and didn't just get on there and go, well, if you do this diet, it's going to change the course of your cancer and you're going to go into full remission. And so that made me happy. The second thing, do you want to comment?
Let me comment on the diet, because I agree with you both that thankfully, the type of cancers that we pick or select to monitor are harmless enough that you're going to do well, even if you eat a bad diet. I know I'm not supposed to say that. You're not going to do well cardiovascular wise, but you're going to do well from a prostate cancer point of view. The people that I start getting a little more weaponizing about for diet is the people who have advanced metastatic disease. Those people, I counsel them to do rigorous vegetarian approach to not feed the cancer, because we're fighting for our lives with, and that it's like a different illness. These people it's so sad that we use the same name for these people with local disease. We call that prostate cancer. And then people, which was addressed in my talk and Dr. Kwan's talk, that have advanced metastatic disease, have life-threatening disease. It's opposite ends of the spectrum.
It is opposite ends, but let me take you through my teaching points of why I'm excited about diet and advanced prostate cancer. Okay, or just becoming heart healthy.
I think it's good. Let's kind of put the Kwan and advanced prostate cancer Scholz talk into the same bucket.
Well, I will, but I got to bring up one more thing when it comes to Cooperberg, which you and I have never talked about. So of course you want me to get to that, and then we'll go back.
Let's get that out of the way, and then we'll go on to advanced, and we'll call it a day.
I don't like, and I've heard from plenty of patient advocates who want me to advocate for them. I don't like that many institutions only allow you to get one versus the other. And I love that Cooperberg addressed it, that they like the ultra-sensitive tests, but the not so sensitive, what about that? And so he said, ideally—
Let me make it simple. I heard your guys talk. It's very simple. You want to use, I don't care which one you use, unless you're coming out right after surgery, you have to use ultra-sensitive. But
that's right.
Other than that small subgroup, it doesn't matter. What you want to do is use the same one every time, because you're comparing. PSA is a very powerful test, but it's much more useful if you look at trends. It's the trend. And if you have tests coming from different labs, they're going to bounce around because they're not calibrated with each other. When you go to the same lab every time, they are calibrated with each other, and the trends are going to come out more clearly sooner if you use the same one. So use ultrasensitive if you want, use not so sensitive if you want, but keep using the same one. That's the bottom line.
That's a great point. But my point is a lot of people never get the choice unless they speak up, because there are plenty of people that get PSAs that are ultra sensitive.
But they can advocate for using the same lab every time.
Yes, they can. They can. But there are plenty of people that are stuck with an ultrasensitive that don't realize the anxiety of following that ultrasensitive number, and they're just not made to be ultrasensitive PSA people. And there are other people that love the
You're talking about a subgroup of people, and let's cover this because there's so much anxiety in this business, and maybe we can help a little bit with this.
Yeah.
The people that have had a radical prostatectomy, some of them, they say you're supposed to have a 0 PSA. If you don't have a 0 PSA, your cancer's back. Okay, that's a simple concept. The trouble is it's not always true. And the ultrasensitive PSAs can pick up small amounts of prostate gland tissue that the surgeon didn't get out at the time of surgery.
It can.
The difference is that those folks, that small amount of measurable PSA doesn't keep rising all the time. So this is why I say sequential exams are really what tell the story. So someone could have a PSA of 0.18, which you say that's a lot of PSA for someone that had surgery. But if it's 0.18 5 years in a row, they don't have prostate cancer.
Exactly.
So yes, you and I have had some patients in common that live and die by the changes. It went from 0.14 to 0.16, Dr. Scholz. That's a 10% rise. My cancer's grown 10%. And the anxiety that it can induce it can be terrible. So we have to remember that not all small amounts of PSA after surgery actually even come from cancer.
No, exactly. It's the trend. Sometimes it's the speed, right? If the thing rises quickly, we call it the kinetics.
Yes.
So the kinetics can be, velocity, doubling time, all these things. So as long as you're repeating with the same company and the same product, because the reason I bring up PSA ultrasensitive too is that you're seeing a lot of my friends who have had surgery, but now they have oligometastatic disease, or it could be in any scenario, and they've kept with the PSA ultrasensitive, and their ultrasensitive went from 0.02 most of their lives or during their process, and now it's suddenly 0.08, and then sometimes they're getting imaging and they're finding a tumor. So so I don't know if you want to comment on that, but I think people have got to know about this.
Well, if we order a PSA through our office, and I hope I don't lose your friendship for this, we always order an ultrasensitive PSA. We do it primarily for uniformity. We want the same thing. The bottom line as to why they have a detectable PSA, but I understand that it does create more conversations, and it can create some confusion because these powerful tests will detect very minuscule amounts of prostate tissue that are not cancer and create unnecessary consternation in some cases.
Exactly. So I think that's just important. So what I've always I've just had so many patients, advocates around the country going, why can't we choose? And I would try to say, you can choose. You just got to have a frank discussion with your doctor that says, this is the PSA I want. And you bring in a good point that this is the one I want going forward. Boom, 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 every time. All right. Do you want to now go back to
Let's talk about advanced disease. I think I didn't know what Dr. Kwan was going to talk about. I think it was kind of nice.
I didn't either.
There's a lot of crossover with the principles that I shared and the principles he shared. I was obviously really impressed with his ability to focus on the things that are important. He talked about very regular and stringent follow-up. He obviously emphasized that when you have effective therapy, using it earlier. I would say the thing that interested me most was your discussion about immune therapy. Dr. Kwan, he talked about his relationship with a Nobel Prize winner and his research. He headed up a trial in several thousand people giving ipilimumab for advanced prostate cancer, and it got this close to FDA approval. And what he learned from that about the number of mutations that you pick up from these genetic tests, another genetic test, different genetic test called Guardant 360 or Foundation 1. Let's embellish. Maybe he covered it. If he did, I'm sorry. But these tests look at cancer DNA floating in the blood of people who have advanced prostate cancer, and they can look for mutations in that cancer DNA and design treatments based on that. It's fantastic technology, and the total number of mutations means that it's less and less like your normal tissues, and your immune system is more likely to recognize the cancer and attack it. One of the funny things that people believe that when they get cancer, they think they have weak immune systems. No, they have nothing of the sort. They have blind immune systems because the cancer is so close to who they are, it doesn't want to attack it because it thinks it's you. And the immune system doesn't want to attack you. If it does, you have things like rheumatoid arthritis, you have lupus, you have pulmonary
autoimmune disease. Exactly.
It's horrible. So the immune system is very careful about not attacking you. But as the cancer accumulates mutations, he said a threshold of 12. He gave an example of a patient who had 22 and had a beautiful response to ipilimumab. And I thought that was really helpful to try and define where these magnificent immune medicines belong in the prostate space. They become mainstream in lung cancer, melanoma, and many other tumor types. It's been revolutionary in these other cancer types, but it's lagged in prostate cancer because the mutation load only comes toward the end of the disease. So, so that was a great discussion about where the role of these fabulous medicines fits in prostate cancer patients. I don't think he covered Provenge. I don't think he's much of a believer. Dr. Kwan sees a pretty advanced stage of prostate cancer. A lot of people are going to the Mayo Clinic when they're at very desperate straits. I think of Provenge as sort of like a vaccine, and vaccines are to be given at a time when you're not sick, where your immune system can then mount a response to keep you from getting sick. Well, that doesn't really happen in advanced prostate cancer, but the studies have clearly shown that when Provenge is given to people with low PSAs, particularly less than 20 or less than 5, that it has much more benefit in getting the immune system involved and helping those people. And it does relatively little if someone already has very advanced disease, which is sort of the profile of patients I think that Dr. Kwan sees on a regular basis. Ideally, Provenge would be approved in people who have hormone-sensitive disease, but it's not, and it's a very expensive drug. So there's this very narrow window where Provenge can get covered by your insurance when the hormone, the Lupron, stops working. And then what happens in the real world is most of the time Lupron stops working and people are put on chemo or they're put on second generation hormone therapy. The Provenge gets forgotten, which I think is unfortunate. But it is another form of immune therapy that I think is useful in prostate cancer. So Provenge for earlier stage, earliest possible stage, checkpoint inhibitors like ipilimumab, Keytruda, Yervoy, these that is ipilimumab and nivolumab are, those are the types of things that could be useful in someone who has a genetic test that shows a lot of mutations or has multi-satellite instability, another type of multiple mutations. If you have MSI, the really cool thing is if you give these people Keytruda, you're almost guaranteed to get a response. Where do you hear about that? I mean, we give Taxotere, 2 out of 3 get a response. You give a hormone treatment, truly maybe 100% get responses. But in advanced disease, to have almost universal responses, the problem is MSI is fairly rare. But when it occurs, and it's what a sad thing if someone hasn't tested for it. So
microsatellite instability. You know, it was a press release came from the government this year that said, this, if you have this, you can get this drug, you can get Keytruda. So this is not just prostate specific anymore. But yeah, how many people know MSI and test for that, and the number of mutations and number tumor mutation burden, they call it, right? So these things have to be discussed. Another important thing, which I wish I would have talked about with Kwan, and you and I can talk about in the future, is that you really have got to have a discussion of a quality lab, one that a facility that does these kind of tests on a regular basis. And the reason I'm bringing this up is because I also work in the over-the-counter world, and people are trying to make a lot of labs equivalent in the over-the-counter world to the prescription world. And the problem with that is that some of these companies like Garden 360, who I have no relationship with, or Foundation One, they've now done countless thousands upon thousands of these tests, showing not only their accuracy to find these things, but then to use them in a research setting. So you can't just have some company over the counter called like Joe's Labs, you know, promise to do these kind of tests. And I'll tell you where this comes up a lot. This comes up a lot with BRCA, because a lot of these things, they're looking for variants. You know, we use the word BRCA, but there's hundreds of variants in breast cancer alone. And so you got to be testing for all these variants and then talk to a genetic counselor. So it's really, I'm really glad you're bringing up some of these top-notch companies that do some of these testings that you mentioned. And, that's Garden 360, that's Foundation One, and there's a whole bunch of others, but that's also an important part of the discussion with your oncologist.
Yeah, I think Dr. Kwan emphasized that repeatedly because the mutational world can evolve over time, especially with these advanced cancers. There's another useful thing that can come in with these tests, and they can actually measure quantitatively how much of the mutational DNA is present. And sort of like as the PSA goes up, we expect that the cancer is growing. And if the amount of these if the amount of this mutated DNA goes up over time, then we're suspecting that our treatment may not be holding the fort. Maybe it's time to switch treatment to something else. And if it's declining, maybe we're on the right track. We should continue that same treatment.
Yeah, a test is not only qualitative, it can be quantitative. How much? Do I have high cholesterol? Well, what's the number, right? I mean, a ton of people have high cholesterol.
Did it get better after you started your cholesterol pill? How much better did it get? Did you get your LDL down below 60? Yeah.
So
same
you
idea.
mentioned something very important. People will get these reports and they'll get home and they'll get these from you, and they'll show a quantitative number that is very difficult to understand if you don't know how to read it. And what happened when I first got one of the reports that actually came from your office, I called the company and I said, what in the HE double toothpicks does this mean in terms of quantitative? And the geneticist said, this is very high. This is much higher than normal. I wouldn't have known that exactly unless I would have called the company and they would have walked me through what the latest thinking is. So you bring up a very good point. Don't be scared to consult the company that did your test and talk with an expert about what those results mean in terms of qualitatively and quantitatively based on what they know now.
Yeah, usually they're very available for those sorts of discussions. They have highly trained people that will get on the line, physicians that are employed by these companies, and talk you through it. You're right. It's impressive the kind of access that you can get once you've done the test.
Yeah, because most of your friends they're not practicing anymore. They're not like you anymore. I mean, you're a dinosaur. Most people are being administrative.
I want you to invent a new word for our new problem that's appeared in the last, 5 years in the world. It's not just medicine, it's the whole world. And the problem is the danger of us getting yesterday's treatment, not because we have a bad doctor, an evil doctor, a stupid doctor, but because we have a doctor that's so overwhelmed by so much new information, it's humanly impossible to keep up with everything. Yeah. What are we going to call that problem? The problem of you getting 5-year-old treatment, which everyone is calling state of the art. Yeah. 5-year-old treatment used to be just fine. When I was practicing in 2010, if you got 2005 treatment, it wasn't that big a deal. But if I'm practicing in 2023 and you get 2018 treatment, it's a big deal now.
You're right. It's right.
Really big.
That's right. I always argue people that want to get a hold of me. I say, look, I'm doing all public health. That's all I do now. Scholz sees the patients. If I'm not keeping up with the information and I'm not talking, he's not helping me, I'm not helping him. There has to be a communication between all this information that's flowing.
It's got to be a team.
It's got to be a team.
And it's also got to be the quarterback of the team has to convert to being the patient.
Yeah, that's a good point. But Kwan used the word edge recurrence somewhere in his talk when we were talking about oligometastatic.
No, wait, you didn't give me a word. You didn't give me a new word.
I'm
I want you to create a neologism for this problem that we have in 2023 of getting 5-year-olds.
15 years. You trust me, I'm going to take you right down that path. He used the word edge recurrence, right?
Yeah. Okay.
So maybe we should use the word edge. We should call it edge regression. Maybe you're looking for an edge, but it's actually regressing. You're not actually moving forward. You're regressing in terms of knowledge.
Yeah, I don't know. Too complicated. Go back to the
I'm just saying we can come up with a word, but not off the cuff. But it's what it's called is antiquated medicine. Maybe that's what it's called.
But people don't know it's antiquated. We'll talk about it more because I think it's a real problem and it's going to get worse. It's going to get worse.
Yeah, no, I couldn't agree with you more. But
let's go and talk. I think your talk about edge recurrences is good just because that was a very important component of your dialogue with Dr. Kwan.
I know, but we're going to ask Kwan maybe we're going to take a vote on what the word should be, because I said, what's the biggest problem you see in the clinic? He said, not enough questions. So maybe this is part of the problem, that people are not asking enough questions to realize that they're getting medicine from 5 years ago. I don't know, but all of this kind of goes in the same barrel, right?
Well, you assume you go to the Mayo Clinic and it's 12 stories tall and Dr. Kwan is incredibly articulate and brilliant. And people want to just delegate the responsibility. I think that's where the patient has to start becoming the quarterback.
Yeah, I can't, I'm at dinners every week and someone's mad. I mean, there are people that love their doctor and someone's mad. My doctor didn't tell me this or didn't know that. And I always say these words, and I know people get mad at me. I go, the doctor is the business. You are the customer. When you go pick up a new iPhone, or when I'm going to look for a new car, I've already gone through 20 different dealers. I'm exhausted.
Yep.
We have to begin to think of this the same way.
Yep.
Except this is the most prized possession you'll ever want to invest in, which is your body and mind.
That's right. It's the highest stake game.
The highest stake game. So if I'm going to 20 different places to buy a new car, because I only buy a new car like you every 15 years, I'm just trying to tell people at dinner, you have to use the same mentality, except even go further when you're dealing with you. The idea that the doctor has time to cover it when they're being told to see 60 people in a day, or they're being told that computer side manner is better than bedside manner.
Mm-hmm. Yep.
Come on.
No, you're, thank you. I really appreciate your sharing that. And that is going to be an ongoing problem. And if patients will start to realize that they're stuck, I mean, it'd be nice if the world was professional enough and able enough to do all this heavy lifting for them. That'd be great, but it ain't happening. And if you allow this to just take its normal course, people are going to get 5-year-old treatment.
Yep. Okay.
All right. Just one more thing about Dr. Kwan Advanced. He emphasized a medicine called carboplatin, which is FDA approved for lung cancer, not for prostate cancer, but now is well known to be effective in prostate cancer. Maybe we should just talk briefly about who should get that. Taxotere has become very mainstream, but carboplatin is certainly an effective and tolerable medication that works nicely in conjunction with Taxotere. So I'm not advocating that everyone who gets Taxotere should get carboplatin as well. What comes up is, what do you do when the Taxotere stops working? Or let's say you've had a half a dozen treatments and you need more treatment. Maybe you've gotten a partial response, but you're not all the way there.
Yeah.
Well, typically, many of the oncologists will switch you to something called Jevtana. Jevtana, which is a Taxotere-like medicine, which nicely seems to have somewhat fewer side effects, equally effective. But since it's so similar to Taxotere, the yield is not going to be good because that patient's already been exposed to a taxane. Jevtana is a taxane as well. But I think that's where you bring the carboplatin in. So you're in a second line situation. The Taxotere by itself didn't get the job done completely. You need some more horsepower. That's when I start thinking, someone mentions the word Jevtana to you. I think the question to your oncologist, should we add some carboplatin to my Jevtana to try and get better results? That's where we typically bring the carboplatin in. And it's effective medicine. It's been around for more than 20 years, used in ovarian and lung cancer. And we've been using it in prostate cancer for over 20 years. It's very good medicine, inexpensive. So it's not going to be an issue battling with insurance companies. And it can really juice up the response rates in people that are doing second line taxanes with Jevtana.
Do you want me to go over the quiz I went with Kwan in terms of chemo? I think we should do it with you too. Are you ready? I want you to answer.
I don't know. Honestly. I don't know if I can match.
It's not a quiz to make you look funny or bad. It's a quiz.
No, I know.
It's to give a perception, because there's a perception of chemo that continues to be ugly in prostate. And we're trying to change that perception, even though I'm not a fan of chemo, but you have to be a fan with it of everything that it does in prostate. So what I said to Kwan was, and I was being serious, and I would ask you the same questions. Does chemotherapy reduce PSA?
Easily, absolutely. Routinely it does.
Okay. Does chemotherapy improve quality of life?
It does in people that have any pre-existing symptoms from uncontrolled cancer, because it makes the cancer go away and improves quality of life.
Does chemotherapy go after some genetic mutations that can be ugly out there? You know, I know we're going to talk before we end today about PARP inhibitors, but does chemotherapy also attack some of these mutations that you don't like?
Yes. Do you mind if I say, with the word chemotherapy, we have the same problem that we have with the word cancer. We have the same problem we have with the word radiation, because it's a grab bag term for hundreds of different medicines given in hundreds of different ways to hundreds of different cancers. So Taxotere for prostate cancer specifically, the really only common Taxotere and Jevtana, the only commonly used chemotherapies, on the scale of ugliness, so you have bone marrow transplant chemotherapy at the top of ugliness, and then you have some, mild pills for CLL for the easiest type of chemotherapy. And then where does Taxotere fit in that ugliness schema on the scale? And the answer is it's way down here. Yes, it has side effects. You could have some hair loss. You can feel some significant fatigue for 3 to 5 days after each injection. But when you compare that to the devastating high-dose multi-combination chemotherapies that are given to lung cancers and melanomas and ovarian cancers and these sorts of things, and Taxotere compares favorably to the most of what we think of as chemo. No, it's not a cakewalk, but it's a lot milder than most of the really serious stuff that those folks don't have a hormone treatment to fall back on. It's all or nothing in those people. And so the chemo gets pushed to the max. It can help them, but what we give, the medicine, not the chemo, the medicine that we give for prostate cancer.
I'm happy to go. Okay, Taxotere,
It's not nearly as serious as most chemos.
Good point. And is Taxotere, Jevtana, the chemos, are they covered by insurance?
Routinely.
Are they pliable? And by pliable, I mean, let's say you're going every 3 weeks or you're on a certain schedule and the person's not tolerating it as well, and you want to just change the schedule up. Is it pliable? Is it workable? Can you change dosage? Can you change frequency?
Thank you, Dr. Moyad. I'm going to tell you a profitable story. Early on, long before Taxotere was FDA approved, we had a patient who came into our office with a PSA of 1,000. And we gave him Taxotere because of the good results that were being seen in lung cancer. We said, we should try this in our patient with bone metastasis. He took a standard Q3-week dose of 75 milligrams per meter squared. And he said, I can't take it. I cannot do that. And so it wasn't practical. And this man needed it. He was, he's hormone resistant and he was out of options. And so he, for whatever reason, we said, well, maybe we can give him a small dose weekly, like you're describing. Can we change it up somehow? Turned out that small amounts weekly, he tolerated just fine. His PSA went down to 2, and it stayed there for several years. And during that time, we've been telling him he'd been having some blood in his stools. We've been telling him, get a colonoscopy. Turned out he passed away from colon cancer 4 or 5 years later, not from the metastatic prostate cancer, all because of low-dose weekly Taxotere. So thinking creatively, and people, when you run up to a roadblock, is there a workaround? In that man, it saved him, many years of additional life.
Yeah, so that's why I went through that checklist. It's a sort of a remarkable checklist of all those things that it can potentially do. And I think the last thing on my checklist I never got to with Kwan was, do you have something in your office that can prevent or treat many of the side effects of chemo, or what we want to call them, Taxotere, Jevtana, Carbo? Do you feel comfortable that you can prevent and treat the majority of side effects that occur with these agents?
Yeah, that's an art form, and it's let's start with hair loss. Effective ice caps, which unfortunately are not covered by insurance for men. They are covered for women who have breast cancer.
Yes.
Can totally prevent hair loss by icing the blood flow to the scalp during the infusion so that the chemo doesn't get into the scalp and people don't lose hair. That's pretty cool. The anti-nausea medicines are almost 100% effective. So we don't really talk much about nausea anymore because they get a squirt of some medicine, that's fixed. Medicines to prevent infections. It used to be that we'd push the dose up to what your immune system could tolerate. And sometimes we went too far. People ended up in the hospital with infections. That's been stopped by injections that boost the immune system. And make sure any of you out there that are taking Taxotere, talk to your doctors about this. There is a policy in some oncology offices, to save money, they wait till the first infection occurs before they start using the anti-infection medicines. And it's covered by insurance. So I admire their desire to be frugal, but going to the hospital with a life-threatening infection is a bit much in my book. So Neupogen, Neulasta, these types of medicines will stimulate the immune system and essentially prevent infections, putting ice chips in the mouth during the infusion. So not only you want to get the blood flow away from the scalp, but you want to get it away from your taste buds. The chemotherapy can affect the taste buds in a way that makes food taste poor and bad. And keeping some ice chips in your mouth during the infusion shunts blood away so that you keep your normal appreciation of food. You want to keep exercising. People that are on hormone therapy universally are told to exercise, and then they get on the Taxotere and they feel more tired, and they stop exercising, and then their muscle mass goes down real quick. So this is a brutal prescription, Dr. Scholz. I'm so tired, I can't exercise. Go to the gym and lift 5 pounds. You're telling your muscles you like them, you want to keep them. You're not trying to wear them out. Just go through the motions. Make sure you stay on your exercise during the chemo. It's been shown with radiation, chemo, hormone treatment, the people that exercise feel dramatically better than those that don't. Those are just some quick high points.
Yeah, one of my favorite papers I had to review was in, I think it was JAMA or JAMA Oncology. It was from the author of MUSTIAN. It was 2017, I believe. This is why I have no life. And it was a huge, one of the largest meta-analysis to look at cancer-related fatigue. And you know that, CRF, it occurs throughout the spectrum of prostate and other cancers. You know, how do you go after the fatigue? So they did all this analysis. It almost looked like an AI thing. You can go back on the paper. It's a beautiful paper. And at the very end, it basically says, I'm paraphrasing, it said, after looking at all these things, it looks like exercise is one of the best option, if not the best option.
So it's true for hormones. It's true for life. It's true for chemo. It's true for radiation. Same prescription.
But the reason I bring that up and I kind of laugh is because there was you remember this, you and I have been in this game so long. There was so much excitement about using stimulants and all these different drugs to change the fatigue game. And it turned out, you know, some of them, if they helped, they came with catches or helped a little. And then you'd put all this thing in a computer and you do this massive meta-analysis. And what a beautiful paper that team wrote. And that basically said, exercise looks like actually one of the best things.
And it really does work. It's not something like, hey, you're in a bad situation, this will make it a little bit better. It's amazing how people report back in terms of it's just almost like a flip-flop from darkness to light. People really, they're really shocked at how much more normal they feel when they do their exercise. I mean, we all feel good, you know, we don't have these burdens of some cancer diagnosis that you and I are fighting. We feel better with exercising. It's cool. It makes a big difference. But it seems to make an even bigger difference in these patients for some reason. And it doesn't take like weeks and weeks of exercising to build into something. They feel better immediately as soon as they start doing it.
Yeah, and it helps them so much cognitively when they're going through all these cognitive insults. But it's, you know, let's just go back on 2 of my favorite sayings. You're only 1 workout away from being in a good mood. There's a lot of truth to that, right? So if someone's
that's a great saying, and I'm not sure I've heard that before.
Really? If you need to collect all the Moyadisms and then publish them. You'd either win a Nobel Prize or make a fortune.
Repeat that one. That's a beautiful one.
You're only 1 workout away from being in a good mood. And I used to say that to my kids when they were cranky. So when anybody was cranky pants, or somebody in my family, my brother was cranky pants, my sarcastic pushback was, you know, you're only 1 workout away from being in a good mood. So why don't you work out and then we'll go talk about this subject. And then we'll have a different spin. But there was a lot of truth in that because of the mental health benefits.
I see it. That's beautiful.
Then there's the jaded response that we don't think about, which is, you'll hear this all the time. I'm sure you hear it from patients or everybody else in the family. You know, I never regretted a workout after it was done. That's because your mood changed. You looked at things differently. You may have hated it during, you may have hated it going to the gym, but when you're done, like when I did my 8-mile run this morning, I was in not a great mood this morning. I had to get fired up to deal with the King Scholz again. It's not easy. This is a lot of pressure. I'm dealing with a lot of experts. I got to look good in front of you. And so I finished that 8-mile thing, and I'm kidding you. I'm not kidding you is what I wanted to say. Within 30 minutes, I went, bring this on. I am so excited to see Scholz. I'm so excited to see Alex, Peter, and the team. Let's just have some fun today.
Thank you for that disclosure, Dr. Moyad. You mean even guys like you sometimes have doubts. That's I'll tell you, I wrestle with doubts constantly on an ongoing basis. And I'm gonna write those Moyadisms on my wall because I have a workout machine. I should have taken a picture of it. Maybe I will, and Alex can stick this in right next to my bed. if I get out and I hop on that baby right at the beginning of the day, it happens. I'm much better off. If I don't do it right away, it's gone. One more day without exercise.
You're only one workout away from truly, I should be changed to being in a super mood, because it's not just even good. It's a super, it's a different level of confidence. It's a different, because what's really difficult in the cancer world and what's really difficult dealing with disease, and patients know this better than anyone, is the word catastrophizing. It's so easy to go down that hole where one negative thing you think is going to bring another negative thing, which is going to bring another negative thing. And we think of that way as humans. It's easy. But to snap out of it, to reboot, it's one of the only things that helps us snap out of it and start being.
You're talking about expecting, believing that there's something bad around the corner. That's what catastrophizing. Your mindset is, I know something bad is going to happen. I don't know where it's going to happen.
Right.
But it's going to happen. I know it's going to happen. Today's one of those days.
Yeah.
And the ability to break that mental pattern is so precious.
It is precious, because it happens so much in life, because one thing begets another, and you just keep thinking the negativity is going to continue. You're going to get this piece of bad news here and another piece of bad news there. And this is our only way of combating it. And I also think what exercise doesn't get enough play on is that if you can exercise, you exercise also for your partner, because your partner is not only a witness, but they are helping you go through this process. They are suffering from the same stress and the anxiety and the fears. And you owe your partner your best, because they are a volunteer in this very difficult game of life, and they owe you their best too. That's why I get really excited when I talk to couples who are doing stuff together, in terms, they don't have to do it in the same, they don't have to go to yoga together, but they're both working out. They're both paying attention to detail when it comes to lifestyle. And you can just see a difference in those couples, right?
I think I think we ought to call it here, Mark, because that is so powerful and so practical for all of us. This is the battle, the emotional, mental battle that we all go through every day. It's a choice each time. Am I going to embark upon this fitness thing that I know is going to make me feel better, or am I going to kind of postpone it? And the sad thing is, I postpone it one day, then it's easier to postpone it the next day. And then all of a sudden, it's no longer a pattern. And I tell people that are starting to exercise, I don't care how hard you exercise. I just want you to have a sacrosanct time every day that you do something called exercise, so that you can have that non-negotiable space that is normal, just like you brush your teeth and you try and go to sleep at the same time. That's normal for you. And then on that foundation, someday, if it's in 6 months, 12 months, 18 months, you may want to try and go up a notch. But if you never do, you're still doing yourself an immense favor.
And I can't give enough simplistic advice. Preparing for the moment, because it's not easy to get into the moment. What I mean by that is, every night when I go to bed, and I hate to admit it, but it's helped me, and I think it's helped a lot of people, friends, patients, other people. I put out my running shoes, I put out my shorts, I put out my favorite t-shirt to work out in, I put out my favorite running hat, and it's sitting there right by my bedside. And so when I'm tossing and turning at 7:30, it's staring at me. And it takes me just seconds to put it on, because you got to admit, sometimes early in the morning or during the day, you start looking for your workout stuff. You start looking for the right tennis shoes. If you lay that all out the night before, you anticipate the moment. It's easier to get into the moment. People don't know this about me, but when I did this conference and I saw you in person, I try to tell people what I did in terms of the equivalent of flying. I did the equivalent in the past 5 days to 6 days of flying to Europe, like Italy from Michigan, back, flying to Europe again and back in 5 days, plus working out all 5 days. It's just wacky. In all of those cases, in the hotels that you guys put me up in, that, Alex and the others, I knew exactly where the workout room was. I knew the hours of the workout room. My clothes were laid out. There was going to be no excuse to getting up when I didn't want to get up. I'm not saying this is easy, but there are things that you can do to make it easier on yourself. I want to finish there, but I can't, because I had 2 other requests, and you can handle one of them, and then we'll both handle the last one. Is that fair?
Yep.
What do I do with all these drugs getting approved in combination? This one just got approved. I think there's even a lecture. I don't work with this company, Akiga. This is a PARP inhibitor plus abiraterone for BRCA mutated metastatic castrate-resistant prostate cancer. This was approved on August 11th. I keep getting some of these. I mean, what are we supposed to do with these? Do you want to have a take-home message about?
Sure. And thank you
these
for letting
kind
us.
of drugs?
I'm glad we didn't skip over that. Super important. Brand new, effective anti-cancer treatment needs to be mentioned and discussed briefly. So historically, the process in prostate cancer has been a sequence of you take Lupron, that didn't work. You take a second generation hormonal medicine like Zytiga, Xtandi, Nubeqa, or Leta, that doesn't work. Then you go to Taxotere and perhaps then to Pluvicto, the injectable radiation. Well, if you're BRCA positive, we've been talking a lot about genetic testing, which you can now detect just with a simple Guardant 360 or Foundation 1 blood test. Everyone should have it. If they are BRCA, you should know it. It's really plausible. Instead of if your second generation hormone medicine isn't working, you have a rising PSA, disease is progressing on the Zytiga, Xtandi, Nubeqa, or Leta. Instead of going right to Taxotere, why not take a PARP inhibitor? And Akita is one of them. It is actually a combination PARP inhibitor plus Zytiga, which is fine. I don't stop the second generation hormonal medicines when I start a PARP inhibitor. But for the BRCA patients, 1 and 2, ATM, there's a few other mutations. These are just pills. In my judgment, there's less hair loss. They're well tolerated. They are chemotherapies. They should be given not by a urologist, but by a medical oncologist who's supervising your blood tests and everything. I think that this is the next step rather than Taxotere. Convenience, but remember, this is only for the BRCA patients. You have, if you're on one of these second generation hormone therapies, you should be thinking, what's the next step if this stops working? Well, the next step is get your genetic testing, find out if you are BRCA. And if you are, a very logical next step is one of these PARP inhibitors. I don't have a list of them. There's actually 4 of them, Lynparza, and I can't remember all 4 names right off the top of my head, but there's no reason to think that one is better than the other, but you should be thinking in terms of not should be, but it's very logical to consider thinking of a PARP inhibitor if the Zytiga, Xtandi, Nubeqa, or Leta are no longer working.
Yeah. No, that's a good point, because there's a number of PARP inhibitors now, right? Like you mentioned. And you can see
there's 4 of them that are FDA approved.
Yeah.
And there may be insurance may steer you toward one or the other, but they have to be just like Taxotere. They have to be supervised by a medical oncologist. I'm sure there will be a urologist. Dr. Kwan's a urologist. He could easily give PARP inhibitors. He functions like a medical oncologist. He's doing it all day long. But many urologists aren't giving any chemo, and I wouldn't want them to be learning on you for their first PARP inhibitor. So, because you have to monitor blood counts closely.
Yeah, no, the list is going up. Rucaparib, Niraparib. I just can't. They just keep increasing. Okay, so I'm glad you covered that. Do you want to cover the thing that we always get? And 2 last things. I showed this in the last conference that these weight loss drugs. This is the one that's approved, Wegovy, semaglutide. It's giving an average about 15% weight loss. Again, let me emphasize, this is not for the Hollywood elites. This is for people that need immediate weight loss, that they have unhealthy weight, and it's a life or death situation, and they're seeing tremendous amount. The next drug that's going to be approved is going to be tirzepatide. We're expecting approval in the next 3 to 6 months. That's not a stock tip. It's what people are anticipating. And then we just found out recently in a phase 2 trial, retatrutide gave 24% drop, and that's a triple agonist. So again, the news is 3 to 4 years out now. It's still good. The catches, we're still learning about the catches. The latest catch to come up is that if you're going to get elective surgery and it takes a while to empty your gastric contents, you need to stop these drugs before many surgeries. Now you have to work with anesthesiologists because you can aspirate food contents, and that can cause a lot of problems, not the type of pneumonia. It can cause a lot of lung damage. It can be life-threatening. So now the philosophy is, if you are electing to do a surgery, you have to have an immediate discussion of when to come off the drug and for how long, because they need your digestive system to be working properly so you don't bring up contents while you're under anesthesia, and then those contents will go into the wrong pipe, the trachea. So we're learning of the catches, but that makes sense that that's a catch. But we're also learning that people continue to do fairly well while we're waiting for the other shoe to drop. I don't know if you have any comments. I'm just telling people, keep watching it. This is a fascinating story. I just find it so interesting
how people are turned off by this, but yet we've come to accept the fact that when it comes to the other major measurements, there's no problem in being on blood pressure medication your whole life. Great. If you need it, you need it. There's no problem being on cholesterol medication your whole life. If you need it, then you need it. There's no problem being on a blood sugar medication your whole life. Whatever happened to weight? Why can't people get help with their weight? Are you telling me the only option is to go on a restrictive diet or get bariatric surgery? Hey, these are decent options, but look, I don't like the fact that there's too much conflict of interest here. I don't like the fact that this is potentially a lifelong treatment. I don't like the fact that they're charging too much for these drugs, but I do like the fact that this is a new option, that you're seeing good responses. We have a lot of doctors getting good responses. And I think I just published a paper on PubMed that I showed you called Embracing the Pros and Cons of These Drugs. And it got a bunch of attention. I just want people to understand that, you know, there's a lot of good here. So what I brought up at the very end of our last talk was I said, here's one of the biggest catches. We know that it helps you lose a tremendous amount of weight and you seem to become heart healthier, but we don't yet have a trial that reduces cardiovascular events. So even though you appear to become heart healthier, so what I mentioned in the paper, and I mentioned in our last conversation, is there's a trial called the SELECT trial. And the SELECT trial is actually going to look at over 17,000 adults of getting the drug or not to see versus placebo to see if it reduces the risk of cardiovascular events. Because if it does, it could be a big game changer for these drugs because they're really heart healthy potentially. Here's the company announcement. Just came out in August. It didn't make my paper. Let me read it to you. They announced today the headline results from the SELECT trial. It's not even published yet. The double-blind trial compared with subcutaneous once-weekly semaglutide versus placebo as an adjunct to standard of care, blah, 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 17,000 adults. The trial achieved its primary objective by demonstrating a statistically significant and superior reduction in major cardiovascular events by 20% for people treated compared to placebo. This paper is going to get published.
Surprise, surprise, losing a lot of weight is going to be good for you.
So I'm just saying that some people will email me and say, well, not everybody loses 15%. And, you know, when they lose this weight, they don't keep losing weight. You know, yeah, there's a threshold to how much you can lose, but it's definitely surprised people 4 years in. I'm sure there's going to be more catches. And I'm just happy that in this world of processed food and unhealthy food, which stimulates the same part of the brain that addiction centers exist, where people become addicted to unhealthy food. Yep. They need a way to fight back. It's not easy. And this gives them a way to fight back that I'm excited about. And, but as I wrote in the paper, diet and exercise with these medications look as good as ever because the best results they're getting are the patients who do diet and exercise. And this is what the endocrinologist will tell you. The best results they're getting with these drugs are the people that maintain Scholz-like behavior. They're very busy with exercise. They're very good with their diet in general, and it is synergistic with the drug and makes the results that much better.
You know, one of the fascinating things that we've been dealing with we mentioned before that people are in danger in this modern era of being 5 years out of date just because people can't keep up. The other thing we have to overcome is in our age group, we're old enough to have seen so many false starts and so many promises that looked like they were going to be the solution that never panned out. And we get a little bit jaded. My experience with these new medicines is this is the real deal. These are medicines that genuinely suppress appetite to the degree where people lose a lot of weight and they feel very, very happy about the results. But these people, they've been trying to lose weight for 20, 30 years and have failed over and over and over. And now they're losing 20, 30, 40, 50 pounds. These are patients that I see in my clinic, and this stuff works. And it's such a breakthrough because there's never really been anything conclusively effective like this before. It's a brand new paradigm. It's the real deal.
It is. I was looking at all the trial data for the publication that I published recently, and people were cutting back easily 33 to 50% of their calories. Can you imagine just cutting half your calories and then just being okay with it? But I emphasize again, you know, this debate has become so weird. It's become about, hey, I want to lose an extra 5. we're not talking about, this is not for who needs these medications. These are people that need bariatric surgery. These are people that need immediate weight loss to preserve their life. They're not just their quantity, but their quality, right? Yep. And that's what we have to accept. I never thought in my lifetime we would see it. I'm still waiting for the other shoe to drop. It's possible, but I have been pleasantly surprised. And I think, you know, what's really interesting, as more players come in and then the years go by, you're going to start seeing some generics not too long from now, and they're going to get price competition. And I can't wait till all of them are generic, like statin drugs, right? We got 6 statin drugs. So anyway, I'm excited. And it kind of leads to the final message of the conference, which is you and I were talking about cancer patients and all of this and being heart healthy. And so what I'm arguing, and I think what we're both arguing now, is you see a lot of advanced patients. Another reason to be so heart healthy, and just in general in prostate cancer, is I just go through the steps in my brain. Cardiovascular disease is the #1 killer of men and women for over 100 years in a row. It's the #1 killer of prostate cancer patients in general. There are many men with advanced prostate cancer that suffer and die from cardiovascular events still, right? And then what's so ironic, what's so amazing is almost all of our systemic therapies, the ones that you use all the time in the office, ironically either have no impact or increase the risk of a cardiovascular event or cardiovascular problem. They can make you hypertensive. They can create all sorts of issues, right? So that's step number 4. Number 5, which has not been appreciated, and I hope you can make people appreciate it more, is cancer itself, as it progresses, is an inflammatory event. It creates cardiovascular events. Forget the drug treatments, forget the statistics, but cancer as itself, we're beginning to appreciate, as it progresses, it increases the risk of thrombosis, embolism. It's an inflammatory event that increases the risk of a cardiac event. Yep. How many more reasons do people need than those 5 and more? That the goal is to be super heart healthy, whether you've been just diagnosed or you have advanced disease.
Well, let's take that opportunity to make a short pitch. You've talked about SAM in the past. That we'll just talk about the statin component. There's a number of studies. You talk about heart healthy, eat right, exercise. Yeah. But, it's sometimes a sort of an uphill sales pitch to get people to take a cholesterol pill. The cholesterol pills, I think, sometimes will nudge them towards their reticence. You know, cardiovascular seems like an abstraction, and I like to get heart scans to show people, hey, there is plaque brewing here. Let's deal with this. But that reticence sometimes will be overcome when you tell them there's also an anti-cancer effect from lowering cholesterol, whether it be through diet or statins, right, or preferably through both. That's right. There are a number of studies that validate this. So with that last...
reason number 6, exactly right. It's an anti-cancer effect. But I told you what I was reviewing for doctors, and I'm going to just remind the audience. Yesterday, for people who don't know, I review for medical journals. I review papers for doctors to try to tell them the pros and cons of what the papers I reviewed yesterday for doctors all around the country or world was a trial of atorvastatin for patients with lymphoma who were getting an anthracycline chemo drug, which can be cardiotoxic. It's also used in bladder and other cancers. So chemotherapy can be cardiotoxic, and they put people on a statin versus placebo, and lo and behold, it helped reduce the risk of cardiac dysfunction. Then there was a phase 3 trial this summer in the New England Journal of Medicine. You can look at it right here. It's called Reprieve by Greenspoon et al. This was placebo versus another statin that's well known in HIV patients because they get these antiretroviral therapies that, somewhat like prostate cancer, can increase the risk of metabolic problems. It reduced the risk of cardiovascular events, including cardiovascular death. So they have to stop the trial and tell everyone, oh, you know, this statin that we put you on, it's making this group so heart healthy, the placebo group needs to know. So you know why I was so upset yesterday and I wasn't in a good mood? We have known about this for 30 plus years in prostate cancer, that our treatments and the disease itself is can be heart unhealthy. We should have been doing these trials where men are being put on a cholesterol-lowering medication the moment they start medication for cancer that can increase the risk of cardiovascular problems. I don't think the trial needs to be done anymore. These shouted this year, but I don't know if you want to comment. I think I think this should be imperative now that if you're going to go see Scholz, you got to give me a reason why I'm not being put on these medications.
I agree. The last point being, you've talked about the inflammatory situation, is that sometimes patients will say, well, my cholesterol is already good. I don't need to be on a cholesterol pill, not knowing that these medicines also have an independent anti-inflammatory effect apart from their cholesterol lowering abilities. So, so yeah, they have to be given expertly, and 10% of people get muscle aches, and you have to watch that. You can't just pop a pill and forget about it. You need to be supervised. But these are powerful measures for people that want to be around. We're enjoying this wonderful life. We want to stay around a while and live as long as possible with a good quality of life.
And you know why these are also so darn powerful? Because I think one thing that we don't have in common is I get inundated with the other questions, right? And I deserve to, because I love it. What about vitamin D, Dr. Moy? What about vitamin C? What about this herbal? I don't mind that. And I love answering that question. But at some point, we have to accept the fact that we need to triage these other ancillary products and what is the most important thing I can take. And many times in all of these discussions, including with a number of doctors, I'm going, wait a second, before we even talk vitamin D and calcium and these herbals, can I just tell you about this data of cholesterol lowering while you're being treated for prostate cancer? That should be at the top of the repurposed medication list or ancillary question list, because these are life-altering moments during treatment. And I can only tell you so-and-so stuff about these other pills over the counter because they have so-and-so data. It's an important discussion, but we have to triage. We have to prioritize who we're going to invite in our pill cabinet. And so to invite a cholesterol-lowering drug or a weight loss drug or something that controls blood pressure, we have to prioritize them in our pill box and at dinner. We can only invite so many people to dinner. So this is another reason I get fired up with you, because you and I have been talking about this for 15 years, 15 years. And it's about time that in prostate cancer, we embrace this concept globally, that we're going to reduce the cardiac risk to zero.
This translates into fewer heart attacks, fewer strokes, fewer secondary cancers, less impotence, all kinds of beautiful things.
And here's another weird thing. You're more likely to stay on your treatment for prostate cancer because you didn't suffer a cardiac event.
Yeah, that's right. All right, Marcos, you've worked really hard for the last few days. You've done a lot of traveling.
Let me show you my buddy who's been here for 2.5 hours. 2.5 hours, Scholz. 2.5 hours. My boy was sitting right next to me.
He looks fresh as a daisy. He can go another 2.5 hours. That's
because you know what all three of us have in common? We all have a prostate. Right. So,
Mark, I just need to take a moment. Thank you. You get better and better at this. You've obviously highly practiced and been around this many, many times. You're getting higher and higher quality speakers all the time, myself excluded. But we've got more and more new, wonderful stuff to share with people. And our problem is a lot different than it was 10 years ago. Now we've got so much in the way of new breakthroughs. How can we package this into a short conference? And I think you've done a beautiful job of prioritizing and managing the speakers, inviting fabulous speakers. So we all want to just thank you.
Thank you.
It's always done, and it's enjoyable as we go through this. I think Alex will probably have an announcement about our plans for next year. I think we're going to try and do it in person again, go back to our old ways. And that'll be very exciting. But thank you so much for the beautiful
thank you
work
too.
you do.
I love you like a brother from another mother. You know that, and you know that despite our disagreements and despite all these other things, we came together in a spiritual way. I think there's a spiritual bond. And some people always email me and they go, you get really soft at the end with Scholz. If I get soft because I've always loved our partnership. And, I love the staff that you've brought on. I love Alex. I love Peter. I love all the staff, the editing folks out there, hey, he knows who that is. And all these members of the team, which Alex is going to talk about, I find we really gel well. It's really working well. And I can't wait. Alex is going to talk about this. I'm actually excited to do the conference next year in person that we know Alex is going to announce. So stay tuned for that announcement. Anyway, big hug.
All right. Thank you again.
Thank you. When Grazie's a good boy, he gets a cone. Yeah, vanilla cone. His first one from Dairy Queen. Are you happy with that, Grazie? He's still licking. How about some more? Yeah, you love Daddy now. You love Daddy now. Yeah, you're a good boy.
Thank you, Dr. Scholz, and thank you, Dr. Moyad. But most of all, I want to thank all of you who attended this conference. Thank you for joining us and showing the support for what we do here. Also, thank you to our speakers, Dr. Moyad, Dr. Scholz, Dr. Mulhall, Dr. Kwan, Dr. Kurtzman, Dr. Agarwal, and Dr. Cooperberg for presenting this incredible information and making it available to us. I would also like to thank our sponsors, Bayer, Pfizer, Astellas, Janssen, Novartis, Dendreon, Sumitomo Pharma America, and Sanofi, because if they didn't help, we wouldn't have been able to make this free for all of you. And a special thanks to my incredible PCRI team. You all know who you are, but you have done a great job presenting all of this, and none of us would be here without you. Now, everybody, remember, next year on September 7th and 8th, we're going to be hosting this conference in person, live here in Los Angeles. We're going to have world-renowned prostate cancer experts covering every type of prostate cancer, and you'll have the opportunity to get your questions answered in person. Sign up today at pcri.org/2024-conference. Now, please, one more thing, subscribe to our YouTube channel. You can stay up to date with more content just like this. If you have questions, you can call our helpline, and you can find them at pcri.org/helpline. We're happy to answer your questions and help you build your foundation with your medical team. Now, thank you so much for joining us. I hope to see you all at our upcoming virtual conference in March, and please remember, more than anything, you're not alone.
Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.
One thing my prostate cancer hasn't changed: this place. We've made some great memories here, and we're making one today with a little help from Nubeqa.
Nubeqa is a prescription medicine used to treat adults with prostate cancer that has not spread to other parts of the body and no longer responds to a medical or surgical treatment that lowers testosterone.
I was on hormone therapy, but my PSA was rising, so my doctor recommended Nubeqa.
In a clinical study, men lived 2 times longer without their prostate cancer spreading when they added Nubeqa to ADT. Nubeqa may also extend survival. Nubeqa may cause serious side effects, including heart disease and seizures. Tell your doctor right away if you have chest pain or discomfort, shortness of breath, loss of consciousness, or seizure. Nubeqa can harm unborn babies and cause loss of pregnancy. Common side effects were changes in liver function tests, decreased white blood cells, feeling more tired than usual, arm, leg, hand, or foot pain, and rash. Nubeqa helps you live for what you love. Ask your doctor about Nubeqa.
Prostate Cancer Research Institute is an educational organization for prostate cancer patients, their caregivers, and their families. We put patients first and are an unbiased source of information and support. For over 20 years, our goal has been to meet the educational needs of prostate cancer patients at every stage of their journey. Medical technology is advancing rapidly, and new treatments are becoming available. Patients have to make complex choices which have lasting implications. They face unexpected industry biases and doctors who may not be up to date on the latest research. Your donation helps men receive the latest, most up-to-date information, which empowers them to make informed decisions. Our website, PCRI.org, is a wealth of information and resources. Our conferences and webinars are a way to get patients' questions answered by leading physicians and researchers. And we have a helpline for men to call with questions about their diagnosis, treatment choices, and side effects associated with these treatments. Each week we produce multiple videos covering concepts and every patient question that we can think of about the disease in a straightforward and easy to understand format. This was a brief overview of what we do at PCRI, and to learn more you can visit our website. Your donation directly funds our educational programs, which give life-changing information to men during a very vulnerable time in their life, and we thank you for your consideration. You can visit PCRI.org to learn more.